Good morning. Welcome to the second hearing of Portfolio Committee Number 2, Health, for the inquiry into Budget Estimates 2024-2025. I acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the lands on which we're meeting today. I pay my respects to elders past and present and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. I also acknowledge and pay my respects to any Aboriginal and Torres Strait Islander people joining us today. My name's Dr. Amanda Conn and I'm Chair of the committee. I welcome Minister Park and accompanying officials to this hearing. Today the committee will examine the proposed expenditure for the portfolios of Health, Regional Health, the Illawarra and the South Coast. I ask everyone in the room to please turn their mobile phones to silent. Parliamentary privilege applies to witnesses in relation to the evidence they give today. However, it does not apply to what witnesses say outside of the hearing. I urge witnesses to be careful about making comments to the media or to others after completing their evidence. In addition, the Legislative Council has adopted rules to provide procedural fairness for inquiry participants. I encourage committee members and witnesses to be mindful of these procedures. Welcome and thank you all for making the time to give evidence today. All witnesses will be sworn prior to giving evidence. Minister, I remind you that you do not need to be sworn as you've already sworn an oath to your office as a Member of Parliament. Ms Wilcox, I'd like to remind you that you also don't need to be sworn as you have already been sworn before this committee during this inquiry. For all other witnesses, could you please state your name and position title and swear either an oath or an affirmation, starting from my left.
Dominic Morgan, Chief Executive, New South Wales Ambulance. Affirmation, I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Joanne Edwards, Acting Deputy Secretary, Systems, Sustainability and Performance. I solemnly, sincerely and truly declare and affirm that the evidence now and about to be given by me shall be the truth, the whole truth and nothing but the truth.
Susan Pearce, New South Wales Health Secretary. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Luke Sloan, Deputy Secretary for Rural and Regional Health. I solemnly, sincerely and truly declare and affirm that the evidence now and about to be given by me shall be the truth, the whole truth and nothing but the truth.
Kate Marr, Deputy Secretary, Premier's Department. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Kerry Chan, Deputy Secretary for Population and Public Health and Chief Health Officer. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Philip Gregory Menz, Deputy Secretary, People, Culture and Governance. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Alpha D'Amato, Deputy Secretary, Financial Services and Asset Management and Chief Financial Officer. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Emma Skulander, Acting Chief Executive at Health Infrastructure. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Vince Taggart, Executive Director, Strategic Reform and Planning Branch, Ministry of Health. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Today's hearing will be conducted from 9:15 to 5:30. We're joined by the Minister for the morning session from 9:15 to 1 with a 15-minute break at 11 o'clock. In the afternoon, we'll hear from the departmental witnesses from 2 to 5:30 with a 15-minute break at 3:30. During these sessions, there'll be questions from the opposition and crossbench members only, and then 15 minutes allocated for government questions at 10:45, 12:45 and 5:15. We'll begin today with questions from the opposition.
Thank you, Chair. Minister, welcome.
Thank you. Thanks for having me.
Minister, last year you promised nurses that you wouldn't, to use your words, be dicking them around. You've had over 10 meetings with the union about their wage claim with no progress. Today, nurses across the state are striking because you missed a deadline to present a new pay offer. If that isn't dicking nurses around, then what is it, Minister?
Thank you for your question. A little bit ironic coming from a former cabinet minister who instilled a wages cap.
I'm
that
asking
has caused
about
wages
your responsibility.
Wages suppression for over a decade. That is why we've got considerable gaps now between our nurses' pay here and our nurses' pay in other jurisdictions.
What's ironic about nurses
So-
striking today, Minister?
So let me be clear so everyone understands how we've got to where we are. 10 years of wage suppression
Minister,
under a wages
50,000
cap
nurses are
will
striking
therefore
today. Could you answer the question today in your responsibility?
I need to hit a point of order.
Chair, the opening question was full of invective.
Yeah.
It was very long, and because of that, the Minister ought to be given a reasonable opportunity to respond by addressing the various points that were raised and setting the scene. At the moment, the honourable member's continuing to interrupt him by peppering him with new and different questions from that first one.
Chair, this member is wasting time, precious time. I
remember-
was quoting the Minister, that is all. It was
I'll
an
remind
argument.
all members about the procedural fairness requirement. Thanks, you can continue.
So to be clear, Chair, through you, 10 years of wage suppression will lead to gaps. That's the reality of it. Now, to make that up in a single year is simply not possible at the moment. Now, that doesn't mean that we're not at the table. It doesn't mean that we're not working through the issues. We've resolved a number of issues that the nurses wanted to do. But most importantly, Chair, can I say this? The nurses and midwives, for well over a decade, campaigned long and hard against oppositions and governments of all political persuasions, both coalition and Labor, to introduce a ratio-based system into our staffing. Now, we're the first government to do that. That comes at a cost of around $1 billion. Now, what we're saying to the nurses and midwives is, over the first 12 months, we've prioritised that. We've got that underway. We've got that rollout started. Would I like it to be going faster? Of course. Would health like it to be going faster? Of course. Would nurses? Of course. But this is a huge, complex reform. So I say to the member this. Yes, there are gaps. Gaps caused by a wages cap for over a decade. Gaps now that we are trying to fill. We remain at the table with nurses and midwives. I would challenge anyone to think that they have met the nurses and midwives, any former minister, more than I have over the last 16 months.
Thank you.
I would
This
challenge
is not,
that.
You're entitled to say what you like, Minister, but you are the Minister. This is budget estimates. This is your budget. This is your responsibility. It is not about what I did in my time. It is entirely about you. With 50,000 nurses on strike today, you said that you're at the table. The nurses have not been provided with a new pay offer. With over 50,000 nurses on strike today, why did you miss a deadline to put a new offer to the union? That's a huge own goal by you, isn't it?
Okay, so let's just talk about that question. There won't be 50,000 nurses on strike today. That's point one.
Why did you miss the chance to put an offer to them?
Point two, respectfully through you, Chair. Point two, we wrote to the Nurses and Midwives Association. One of the asks was, before they go down to the Industrial Relations Commission, an independent umpire, an umpire that the union movement asked us to establish, and we established. Before they went down there, they wanted a meeting with myself, Treasurer Mookie, and themselves with health, obviously there. I've arranged that meeting. That meeting was arranged. That meeting is in everyone's diaries. It's for Thursday this week. That's why I was disappointed that they'd taken the action. Now, working men and women make their choices, and unions make their choices, and they've got every right to make those choices. But I've got a health system that I have to run, and it is disappointing that they are taking strike action today. We remain at the table. I'm not pretending we've got a deal yet, because we haven't. But I do say to the community and to nurses that one of their big asks was around ratios. We are the first government to be introducing that here in New South Wales. That's a big reform that comes at a big investment, and that doesn't mean that we're not considering pay. Last year we removed the wages cap with a 4% increase. We've put 10.5% on the table,
Minister,
and reportedly we remain at the table.
Thank you, but that is not what the Nurses and Midwives Union are saying. They said the government has failed to put a better offer on the table, which leaves us no option. Minister, will you apologise to patients who are having their surgery or care impacted by this strike today?
Well, I'm always disappointed, and I'm always concerned as a health minister who cares deeply about the portfolio that I'm responsible for. I'm always concerned when there is an impact on health and hospital services.
So do you take responsibility?
It doesn't have... Well, the reality is I'm the health minister. So, of course, that's why I'm here for. But I'm a minister as a part of a government and a cabinet. And we are making decisions on behalf of the taxpayers of New South Wales. Of course I'm concerned where I hear stories about people missing surgery today.
So will you
of course
apologise?
I'm concerned. Of course I'm concerned. Of course I'm
Will you
worried for those
apologise?
people. Look, if this is about a will you apologise, I'm very sorry to anyone who has missed their surgery today or waiting longer. I apologise if that's what you want me to say. The reality is
No,
this.
I think the patients waiting for their surgery want you to say that.
Of course. I think everyone should be sorry for that. I didn't want to get to this stage. I didn't say that this was the path that I wanted nurses and midwives to go down. I remained at the table. That's
in
what I've
2022,
continued to
Chris,
do.
in
And by the way,
2020
that's what I'll continue to do, just so
In
everyone knows.
2022, Chris Minns called the nurses' strikes a cry for help. This is now a scream for help, isn't it, Minister?
Well, I'll leave others to make that judgment.
The words from your own leader.
Well, what I will say is this. We are working and we will remain at the table with the Nurses and Midwives
All
Association.
right, well, let's talk about that.
I understand we haven't reached an agreement yet, but I also understand that we've done a lot of other things. We've removed your wages cap that caused wage suppression in this state for 10 years for frontline workers.
Let's talk about your portfolio and these estimates.
We've rolled out ratios across New South Wales
yes,
has
you said
commenced.
That, but I'm going to come back to my questions because I have limited time.
And secondly, we've also secured the employment of over 1,100 nurses that were going to lose their employment 1 July this year under your government.
And Minister, in your press releases and your we don't need commentary from you, Mr. Donnelly. You'll have your turn. We don't need press releases from you, Minister. I have questions to ask and I'd be appreciative if you would direct your answers to those 50,000 nurses and hundreds of thousands of patients who are waiting for an answer rather than a statement from you on a press release. Should the nurses, you've said that everybody should be sorry about this, should the nurses be sorry as well?
Well, I think everyone's got a responsibility.
But do the nurses have a responsibility?
Well, everyone's got a responsibility to deliver health services.
Well.
I play a role, the Secretary plays a role, our nurses and our frontline clinicians
So they should be
play a
sorry
role,
as well?
cleaners play a role, allied healthcare
Should they be
staff play a
sorry?
role. Well, that's a matter
Should
for
the
them.
cleaners be sorry? Are you seriously saying that today?
No, I'm saying who delivers health services? Who enables health services to be delivered?
You've had over 10 meetings with the union and nothing to show for it except thousands of nurses striking across the state. When can the people of New South Wales expect a resolution to this ongoing industrial dispute with nurses and midwives?
Well, it's 10 more meetings than your government
This
would
is
have
your
had with them.
responsibility.
But-
You can shirk
but-
it, you can blame others, but what are you doing about it today?
If you let me work through, we remain at the table. In fact, just a couple of days ago, I met with nurses and midwives from my own community. I remain committed to continue those discussions this week. The Treasurer and I will meet as the union asked us to do. We will continue to engage. Have we got a deal yet? No. Can we pay the 15% per year in the single year?
You don't have a deal.
No, we can't. Have we made progress on other things that the nurses and midwives have campaigned for over 20 years on? Yes, we have.
Certainly. So let's go to that. The head of the Nurses Union said, and I quote, "The state government is not bargaining in good faith. Not once in our 10 negotiation meetings has the government sat at the table and discussed nurses and midwives' pay." What do you say to that?
Well, let's talk about that. There's been a range of issues that we have been able to resolve with the nurses and midwives.
But that's not what they're saying.
Okay. One of the issues that they brought forward was a report that they asked us to review, a report that they commissioned by Deloitte. That report, they thought, made huge savings and delivered huge savings that could be put into the wage offer. I read that report. I then had my Chief Financial Officer work through that report with our executive. I met the author of that report and the nurses on a number of times. Unfortunately, that report didn't deliver the savings that the nurses and midwives hoped, and a number of assumptions were incorrect that the author has acknowledged. Now, that's not being disrespectful to anyone. That is just saying that we were hopeful that there might be some savings in there that we could generate in the order of billions of dollars to a claim like this. Now,
All right.
the nurses' claim is around about, in totality, is around about $6 billion. Now, that's a lot of money. That's a lot of money.
So
And
they
of
shouldn't
course-
be paid. Well,
of
let's go
course-
to that. Let's
of
go to the
course-
budget. Let's go to the budget. So the government gave paramedics a 25% pay increase, teachers a 12% pay rise. Will you be budging on your current offer to nurses?
Well, I'm not going to play out our negotiations publicly, and I'm not going to talk about.
But it is. It's already doing that.
Well,
Nurses are on
no,
strike
because-
today.
Well, sure, but I will negotiate and discuss those arrangements with them, and alongside the Treasurer and the Premier and other cabinet ministers. I think you would know as a cabinet minister.
It's not about me. This is your
Ms.
budget
Ward.
estimates.
No,
You are the
I'm
minister.
saying
I'm asking
you would
you.
know as a cabinet minister that you were part of a team and that you understand you play a role in that team. I don't think that you would have discussed those types of negotiations publicly and aired those
Minister,
negotiations
if
publicly.
I was in your role, I would not be asking nurses to say sorry. I would not be asking cleaners to say sorry. I would
didn't
be
say
doing my
nurses
job
should say
and sitting
sorry.
at the
You said
table with
that.
them.
I didn't
They
say
were your
nurses should
words.
say that.
Everyone should be sorry,
No.
apparently, according to you, is the answer.
No.
All right, Minister, are you aware that Western Sydney Local Health District is forcing nursing staff to sign a waiver to reduce their break between shifts by banning them from swapping shifts or assisting their co-workers with overtime?
No, I'm not aware of the individual circumstances.
All right.
I'm more than happy to look into that. Does anyone want to add?
No, I've got people in the afternoon. I'm interested in your response, Minister. It's your responsibility. What steps will you take to ensure that our state's overworked nursing staff are given adequate time to rest?
Okay, well, a number of things in relation to that. Let's talk about that, because it's obviously a staffing issue. I think you would agree that that relates to probably a staffing issue. I'm not saying it's right, wrong or indifferent. I'm saying I think you would agree that. So one of the things that we did when we first came into office, and this is certainly not something that I expected to have to deal with, but I had to deal with it, was that I was informed probably week 1, week 2, that there was one more year left, one more financial year left on 1,112 nurses in the system. Their employment would cease from 1 July
No, I'm
2024.
talking about their breaks. I'm going to come back to that and be specific.
No. I'm entitled to answer this because this goes to the heart of staffing in our hospitals. You raised an issue about nurses having breaks.
Yep.
I'm going to
Let's
talk
talk
to
about
you
that.
about what we're trying to do to enhance staffing so that those nurses can get a break. So 1,112 nurses were going to be terminated 1 July this year. We had to make a fairly rapid decision in the lead up to the budget last year
Minister,
to secure the long-term
when you came to
employment.
office, 50,000
Had-
nurses
had
weren't
we not-
striking. They're striking today. Talking about when you came to office.
Chair, look, I've listened intently. I've let a number of these go, but we're now in a situation where the Minister is attempting to answer the question that's asked, and he's just being cut off continuously by being peppered with additional questions. It's not fair, and as a matter of procedural fairness, he should be entitled to answer the question that he's asked.
Chair, that is not the case. The Minister's had ample opportunity to speak at length where I have not interrupted. He's attempting to waste my time now, and I've been very specific. I drew him back to the point of my question, and he's filibustering.
To the point of order, the Minister has been directly relevant in his responses. He may not be answering the question in the way that the Honourable Member wishes, but he's being directly
It's time
relevant.
wasting.
And I would ask that you remind the Honourable Member of Procedural Fairness Resolution number 19, which is that witnesses will be treated with courtesy at all times.
I think in this particular instance, the Minister had made a link between his answer and the specific question. I also acknowledge that members have been allowing the Minister a fair bit of time before attempting to redirect him today.
Thank you.
I'll allow you to continue.
Thank you. I'll move on. Minister, are you aware that the Area Director of Nursing for Western Sydney Local Health District issued a direction to send home union members wearing badges as part of industrial action? As a Labor Minister, do you think that's appropriate, given the ongoing difficulties in retaining nurses?
Well, I certainly have no issue. I've been in many, many hospitals where there's been more than just a badge. There's been posters, there's been a range of different information. As someone who believes strongly in the rights of working men and women, then of course I have no issue with that. I don't know if that's factual or not. I can't comment on the actual substance that you said, but
You're saying I'm making it up?
Absolutely not. I would never say that, Ms. Ward. But what I am saying is that I've been in many hospitals, including some very recently from rural, regional, remote metropolitan.
Sure.
Many people are wearing the badges that the nurses and midwives, their union, have asked them to wear. I've never had an issue with it. I've gone past, sat in tea rooms
So you
with
disagree with the
posters in.
direction? They should be allowed to wear the badges.
No, I don't have any issue with it. But I just don't know whether, it was presented that way or not. So in context, I'm not sure.
Can we talk about Parkinson's disease? It's been described as a silent pandemic, and there have been nurses, specialist nurses, funded over the last 4 years through an $8.6 million investment that we made. This funding runs out in June next year. Will you today commit to ensure that that funding remains at the same or indeed an enhanced level for our people with Parkinson's disease in New South Wales?
Yeah, it's a very good question the member raises. This is a concern for me, this disease, to be honest. And it's an area where I think we need to do more. In the lead up to the next budget, without breaking the law and talking about government deliberations, so I'll do this broadly. I am looking at what we might be able to do in that space. I think stakeholders have rightly identified that this is a growing problem. I think many of us in this room would struggle to find someone in our close family or certainly within our social circle that's not impacted by this. And this is an issue that I don't think has probably got the attention that it needs for some time. And I think that's not been disrespectful to anyone or any other government. I'm just saying I think this is an area, Ms Carter, where I think we as a government and I think the community can do better.
Minister,
so I'm more than happy to look at it, but without sort of going into what happens in the lead up to a...
Minister, I appreciate your concern and I share your concern. Can you commit that there will be funding for these specialist Parkinson's nurses?
I can definitely commit that this is an area of health and health policy and health funding that I'm looking at. One of the things that I was able to do in relation to Parkinson's New South Wales was provide a $75,000 enhancement and support for the delivery, and I'm sure you know this program, Ms Carter, the New South Wales Health and Wellbeing Program that they help to operate. And I also provided, from memory, I think it was around about 100,000. I'll stand corrected on that.
We're looking at the future,
to their
Minister.
health line,
Your
to their health line, to support their health
in
line.
New South Wales.
Yeah. So I'm more than happy, because this is an area that I've got a good deal of interest in. I'm more than happy to continue to look at this, and I will look at this in the lead up to the budget. I have made some funding announcements to them.
Well, let's look at this budget if you can't commit to the future budget. So Parkinson's New South Wales, they were getting $75,000, not a whole amount of money, in funding last year. What happened to that funding in this year's budget?
Well, as I said to you, I made two funding submissions, one of around 100,000 and one of around 75,000. So I'm not 100% sure where you're referring to.
In a letter to Parkinson's New South Wales, you regretted that they would not be receiving grant funding in 2024-25. Why not?
Well, we will continue, Ms Carter, to look at all of our funding options in the lead up to the next budget. We will continue to do that.
So
it is
don't
a priority.
Parkinson's nurses deserve continued funding?
Ms Carter, to be fair, I just want to be respectful about this. I'm deeply committed to having a look at the work we're doing in Parkinson's right across the board. I know that this is an area you're interested in.
Does commitment mean funding?
I respect that this is an area you're interested in, and I can give you an assurance, whilst I can't disclose cabinet discussions, I can give you an assurance that I will be looking at the funding that they've asked for and identified. Specifically around staffing is something that I'm interested in, because it is a health problem that I think we as a government and former governments can do better.
Good morning, Minister.
Good morning.
As you know, nurses and midwives are on strike today from my community in Albury all the way up to Tweed, and I understand that they're rallying outside your electorate office as we speak today. Nurses are angry, and I've spoken to hundreds of them across the state in the last few months. You've already talked about the safe staffing levels rollout this morning, which I appreciate is an important piece of work that takes time. So far, that's been rolled out in emergency departments in 16 hospitals.
I'd like it to go quicker, but yeah.
But do you accept, to start with, that for the majority of nurses and midwives in New South Wales, that they have not felt any direct, tangible benefit of the safe staffing rollout so far in 16 emergency departments?
Yeah, because we haven't rolled it out. As you said, we've knocked it off in around 16. We're rolling it out in 16. That's a lot less than, I think the total number of hospitals in New South Wales is around 228, give or take. So if you take that number, yeah, I understand that. I think, respectfully, through you, Chair, because I know you're interested in this, I think you would understand that this is an extremely significant piece of work because we're overhauling the way in which our public hospitals are completely rostered. Now, I'm just saying that, would I like things to go fast? Of course. Patience never has been a strong point for me, but equally it has to be done properly. And we have the Nurses and Midwives Association at the table rolling that out and working that through. So, Ms. Con, one of the things they do is essentially ward by ward do a walkthrough with our health staff to essentially get a factual amount of treatment spaces and then build that up into the number. And I'm not saying that's an excuse. I'm just saying it does take a little while. So yes, I would agree that a lot of them haven't seen it yet. Absolutely.
I appreciate it takes time, and lots of people are watching that work with great interest.
Yeah.
But the majority of nurses, as you accept, haven't seen any tangible benefit of that. They're very angry now. We've had 18 months of a Labor government that promised to look after essential workers. You were elected on a promise to look after essential workers. Other states like Queensland and Victoria have better pay and mandated shift-by-shift safe staffing ratios.
Yep.
So for you to speak about these issues in a way that as if it's the choice between ratios or pay, I think makes a lot of nurses angry because in other states they actually do have both.
Yeah, and could I address that? Is that all right? No, I'm not saying it is a choice, and if I've put it that way, I'll change that just so that people are clear. What I've tried to make clear is that the ask, as you would know, in the lead up to the last election, was around a ratio-based system of healthcare in New South Wales. That was what my priority was going into the budget. That problem was exacerbated when I found out 1,112 were falling off a cliff. So I wouldn't have been able to roll this out had I not saved the funding for those, then increase the funding going forward to get more, up to around about $1 billion. I'm not saying that pay is not important. Of course it is. What I've said is that, to be honest, my first 12 months, 15 months has been trying to prioritise the big ask, which was ratios. Last year, we also removed the wages cap and gave a 4% increase, the largest increase they've had in over a decade. And this time we've put on the table 10.5%. I understand that the nurses, that's not acceptable to the nurses. I understand that. What I say to them is that you have a minister still willing to discuss and negotiate at the table. We're having a meeting with the Treasurer this week, and I would like to think that they've seen a minister who has demonstrated a willingness and an urgency to roll out their biggest reform, which is around ratios and the way in which we staff our hospitals. But I understand, for many of them, they may not have felt that yet, and therefore they may be frustrated. I get that, and I'm frustrated at times as well. I'm sure the nurses and midwives are as well. Health is a world. But this just takes time in a complex system.
The 10.5% over 3 years, that's in reality 3.17% per year, which in a cost of living crisis, I mean, it's clearly unacceptable to nurses. They're on strike today. You've repeated multiple times today that you remain at the table. In the 10 meetings that have already taken place to negotiate with the Nurses and Midwives Association, did the ministry actually have the permission of the government to negotiate on pay?
Well, what we had was our pay offer, which was the 10.5. That component hadn't changed, but what the piece of work that we were interested in examining carefully to determine whether there was additional funding and savings that could be contributed to that was what I would call the Deloitte report. And just for the purpose of everyone, the nurses and midwives proactively, to their absolute credit, proactively sought a report to see if there were savings within the way in which we operated and administered our health system that could be delivered. Now, that report identified multiple billions of dollars. Unfortunately, that report, there was a number of significant errors. That's not being disrespectful to the author, Deloitte, or the Nurses and Midwives Association. It's just stating the facts that was the case. So that meant that money wasn't available. But the Nurses and Midwives Association also asked for a meeting with the Treasurer before they wanted to go down to the Independent Industrial Relations Commission. I guaranteed that I would do that, and this week that meeting is happening. I think the only other thing I will say, because I don't want to use a lot of your time, the only other thing I will say is that the offer is 40% more than the previous government's offer. For RN8s, and just very quickly, that's the highest level nurses, so that's where we have the majority of them. They represent around 48%, just give or take. It would take their base salary to just over 101,000, which is higher than everyone, but lower than Queensland, right? So it's still below Queensland, but it is higher than everyone. Where we have some challenges, to be honest, is the early entry nurses, year 1, year 2, year 3. That's where the wage cap has caused a considerable gap compared to other jurisdictions.
With respect, Minister, I think the comparison that matters to nurses and midwives who are striking today is not the comparison to what the previous government offered, it's the comparison to what they can earn in other states, and that's certainly the biggest priority for cross-border communities like the one that I live in. I have a copy of the Deloitte report, and I have some questions about it in a second. The question I actually asked just then, you never answered. The question was, did the ministry have the permission of the government to negotiate on pay in the 10 meetings that have already taken place?
Well, the offer put forward to them was the 10.5 offer that the Treasurer outlined. So that's what we were working on. But in parallel to that, we thought there might be some additional funding coming into the system that may or may not have been able to be used for nurses' remuneration through the Deloitte report. So we were working off a 10.5, but hopeful that this piece of investigative work may have identified savings. Now, it didn't identify any savings for this financial year, certainly. It was largely retrospective, and also the assumptions were made, particularly around the Commonwealth grant process and the Commonwealth cap, were not accurate. Again, I just want to be careful because I don't want people to think I'm disrespecting any of the work. That was an important piece of work. It just didn't take into consideration some key assumptions that maybe weren't available to the author at the time.
So, coming across to this report, and I've also recognised that the Nurses and Midwives Association is actually doing the Treasurer's job for him, and this was a very important bit of work. You've said that there were a number of significant errors. Can you please talk us through what you believe those errors are and what impact it has on the numbers? If these numbers aren't correct, what are your numbers? What are the savings?
I will, and then the degree to which I engaged with this report was significant, and I also asked our Chief Financial Officer, Alfred D'Amato, who's here today, and he also spent a number of times engaging with the author directly. So I'll just throw to him, Mitt's gone in a minute, but I just want to go through some of the things from my perspective. It didn't take in... Firstly, there was no identified savings for this financial year. That was one issue. Secondly, it didn't take into consideration the fact that New South Wales exceeds the Commonwealth cap. So that means that once we got beyond that, we couldn't get any more money from the Commonwealth anyway. Thirdly, it didn't take into consideration a number of COVID payments and adjustments that had been made. All of those things meant that we weren't able to get the savings that were identified in that report. But I might just pass to the CFO just to, if there's been anything additional.
Yeah, respectfully, Minister, I'm happy to come to the department representatives this afternoon.
Sorry, I just wanted to make sure
But I want to clarify this. So the calculations from the Deloitte report were over $1 billion in savings. And it's your assertion that the correct figure should have been zero, that there were no savings identified?
No, that's not my. I would need to take some advice from Alpha to get an accurate figure. It was substantially less than what was there, and there was a couple of problems. I just want to say this because this is important to me. Deloitte actually revised down the original report over $1 billion. So that's substantial. That's a substantial change, respectfully. While in theory there may be some savings, they are not available to fund a wage increase per se due to the effect of the Commonwealth funding cap. And I'll try and explain that in 5 seconds. Essentially, once we reach a certain point and go over, the Feds stop paying us any more money. I mean, I'm being crude, it's a lot more complex than that, but that's essentially it. So we are continuing to look at if there are any ways going forward that we can make any adjustments, but a lot of those things Alpha and his team are already embedding in the changes that we are making. The other savings, and this is important, Dr. Con, the other savings relied on what would be a multi-billion-dollar investment by the Commonwealth to returning aged care services to the responsibility of the state. So to get those savings, you would have had to invest multiple billions of dollars. I'm just trying to... It's a very complex report, and I'm not trying to be disrespectful to anyone.
It is. So you've said that you thought the assumptions were incorrect.
Yeah.
That the $1 billion figure is not correct, but that zero is also not correct. So if you insert what you believe are the correct assumptions, what are the savings? What's the correct number?
Okay, well, I wouldn't certainly put a number on it yet because I don't think that can be identified, but I'll ask the CFO if you want to quickly, Alpha, say something, just to...
Thank you, Minister. Our assessment indicated that we could potentially achieve $6 million a year of savings, and that is the result of the constraints the Minister mentioned, and particularly that the figure quoted retrospective and being adjusted, and also probably depends which report, because I believe there were 2 reports and one has been issued more recently around August.
Thank you. I'll come back to you this afternoon. Coming back to the Minister.
Yep.
So in my own community, the extra building at Albury Hospital is supposed to be completed in 2028. And in November 2027, the final increment of the Victorian government's pay rise is going to kick in. That's a pay rise of 28% over 4 years.
Yep.
So when maternity moves from Wodonga to Albury, will the Victorian nurses and midwives be expected to take a pay cut in the order of $15,000 a year to work at Albury Hospital? Or will nurses and midwives be working on the same shift together, with some of them earning $15,000 more than the other? Which one is it?
Well, that'll be a matter for individuals to make that choice, and by that time, I'm not sure what the settings will be in terms of the wages where we land going forward. So that's not been tricky. That's just been upfront. I don't know what that situation resolves.
So
I do know that.
Clarify my question.
I do know that Victoria, the budget they're under is significant pressure, enormous amount of pressure they're under right now in terms of their budget.
So, Minister, to clarify my question, I've projected out your current offer, 10.5% over the next 3 years, and that's the Victorian government's offer, which the union has accepted in Victoria, which is 28% over the next 4 years.
Yep.
So, back of the envelope calculations, you've got a pay gap of $15,000 for a hospital that's 10 minutes away.
Okay, but I know you know this, but the committee may not. The Victoria government runs the services. They're not funded by New South Wales Health. We pay an amount essentially to allow our patients to access that service. As you know, we don't run that service in the same way that we run.
But nurses who work at
the
Albury
Illawarra
Hospital.
Haven one. That's all.
Point of order.
Sorry.
It's very unusual to take a point of order against the chair, but I'm going to do it. The minister must be given an opportunity to answer the question.
He has been given an opportunity.
No, I don't accept. Point of order. Point of order. I don't accept he's given opportunity. It's a complex matter. The minister is answering the question.
Time.
Do I get my time back if I rule against myself?
To the point of order, the Minister actually has had quite a bit of time to explain this, and he has been allowed a lot of time. I've been listening, I think it's fair enough for you to occasionally, ask another question, which is what you've been doing.
Cut him off.
With respect to the Minister, I'm trying to get you to the point of this question.
Yep.
Nurses who work at Albury Hospital are on the New South Wales Award. The hospital is operationally managed by Victoria, but the nurses are paid on the New South Wales Award. The midwives at Wodonga Hospital are paid on the Victorian Award. When maternity comes across to Albury, those midwives will then need to come across onto a New South Wales Award. Will they either have to take a pay cut to come across to work at Albury Hospital, or will you have nurses and midwives on the same shift doing the same work for in the order of $15,000 a year different pay?
I can't predict what will happen when we open that service. I think I'd be happy to work through a situation with the Victorian government and the workforce. Of course I would be, but that's still down the track, and how long's a piece of string? I don't know, because I don't know what situation the Victorian budget or whatnot will be under, and I don't know how ours will. What I'm saying to you is that I understand the challenges on the border, and to be fair, Ms. Con, you've been a very strong advocate around that community, and I recognise that, both borders, to be blunt. All I'm saying is that I can't project that far ahead and make that determination respectfully. I can't do that at the moment.
I'll be asking you again because we're only talking about in 3 years' time, in the term of the pay offer that you're currently negotiating. Moving on to a very different topic, Hunter New England Local Health District won the inaugural Environmental Sustainability Award from New South Wales Health last year with their strategy to achieve carbon and waste neutrality by 2030. I'm just very quickly going to read some of those achievements. So they reduced carbon emissions by 24%, they diverted 14% of general waste from landfill, and they reduced their water usage by 23%. Yep. That's all extremely impressive. What's even more impressive is that it delivered recurrent savings of $2.2 million. Why is this not happening across every local health district in New South Wales?
It's a really good point, and Ms. Con, I actually initiated a briefing. I think I've had multiple briefings with that group. I'm very impressed with the work that they are doing. Hunter New England was essentially what I'd loosely call a trial site to try and see if these things worked. They're administered under Matthew Daly's team. It is important. I will be looking to expand the work that they are doing, not just from a cost-saving perspective, but also, importantly, from an environmental and a reduction in waste perspective. You would know that health is one of, if not the biggest carbon emitter within government departments, something that weighs heavily on me. It is part of a net zero led program, and we are encouraging all LHDs to adopt some of those principles and learnings. But at every opportunity, I will say to you and others, we continue to have to do better in this space, both from a cost perspective, sure, if you want to focus on that, but importantly from my perspective, from an environmental and a reduction in waste perspective. That's where we need to go.
Thanks, Minister.
If you wouldn't mind, Chair, just on that point very quickly, we started a grants program for our staff to submit environmentally sustainable programs right across the state. So the Hunter New England has been exceptional, as you've made the point. All of our districts and our staff have an opportunity to submit for these grants to enable them to put forward projects that help reduce our impact on the environment. And what we then do is we present that work to chief executives at their forums. We also have a net zero unit in New South Wales Health for the first time. So there is a lot of endeavour around this, just to reassure you that we are very committed to reducing our carbon footprint.
Thank you. And Minister, I'm focusing on cost savings because we've just had a conversation about not being able to pay nurses more than 3.17% this year. Tamworth Hospital replaced LED lighting, paid for itself in less than 6 months, with ongoing energy savings to reinvest into patient care. Is that going to happen across the state?
Well, we will certainly want to see more of those initiatives rolled out across the state. I certainly do. Alpha, did you have any comment on it?
Sure, we have a program to encourage districts to look at exactly the initiative so that we can roll it out through a grant program. So we fund the actual initiative to transfer to change to LED lights.
Go to the opposition.
Thank you, Chair. Minister, are you aware that patients are having to sleep on the floor at Bankstown Lidcombe Hospital Emergency Department?
Well, I'm always concerned of reports like that. Obviously, that's not what we want to see.
Are you aware?
Well, I'm not necessarily aware. I don't know the exact incidents you're calling about, but I'm aware that at times that people stay in emergency departments too long. I am aware of that, Miss Ward. There's no two ways about it.
Does it concern you?
It always concerns me when we are in a situation where we've got enormous pressure on our emergency departments, and that impacts on our ability to deliver health services.
Is that safe?
That's something that keeps me up at night. I know it keeps the Secretary up at night. It keeps...
I'm sure they're not sleeping very well on the floor. Is it safe?
Well, it's clearly not where we want to have our patients. I mean, I think you would... I hope that you would agree that we want our patients looked after, and clearly people sleeping on floors is not the priority, and clearly we need to, as a system, continue to do whatever we can
Thank you.
to support it. That's why we've made big investments in this last budget in terms of
Thank
ED
you. I'll get
and
to the
ED
budget
avoidance
next.
and dealt
Yep,
with
I'll
that.
get to that. We've been provided with photos from members of the community who are shocked by this situation. Do you know if it's occurring in other emergency departments in New South Wales?
I don't know that.
You asked?
What I don't know. Well, I ask about emergency departments a lot. Obviously, I spend an enormous amount of time. It's a focus. It has to be the focus of any health minister.
All right, let's talk about Bankstown Lidcombe Hospital. Do you know what emergency department attendances were in January to March this year?
Yeah, I've got some data for that, because I'll take you through it.
It's just a very specific question.
Yeah, I do. I know it's weird, but I am a bit of a nerd, so I like these things. Bankstown number of attendances, latest BHI, looks around about 14,807.
Correct.
That was up
Thank you. Up 4%.
It was up 4%.
Yeah. Yeah. It's concerning, isn't it?
That it's up 4%.
Yeah.
Oh, absolutely.
Yeah.
It is. I mean, of course it is. I mean,
All right.
when you've got a primary health system that's not doing its job,
Yeah,
it's
okay.
concerning.
Thank you. Are you aware of any ambulance ramping issues at Liverpool Hospital?
There would be ambulance ramping there at times. Yep, there would be. It is a very, very busy hospital, Miss Ward. It's also a hospital where there's growth around the population. It's a challenging area for the delivery of health services.
Certainly.
They also, to be honest, don't have a great primary care network in terms of availability to GPs. And bulk billing
Sure.
GPs is a challenge.
We can come
in
back
Southwest.
to GPs this afternoon. Yeah. Can I ask about the budget, given it's budget estimates?
Yeah, sure.
Because we have we've seen photos of that. It's very clear that that's the case. But let's turn to the budget. In February, you appeared before this committee in Estimates Minister, and you emphatically ruled out cuts to health in the 2024-25 budget. Will you make the same promise in next year's budget?
Yeah, we won't be cutting. Could I just
Yes
talk
or no?
about the budget about Southwest Sydney, because I think that's what I just want to make sure that you're aware of that. That
No,
budget.
you can come back to that in government time if you like.
2.6 billion, and it's an increase of 140 million compared to 2023-24. Just so you're aware.
So you said there wouldn't be cuts. Can you confirm your capital spend on health for this financial year?
Yeah, capital spend is around 3, I think. Let me just give me 2 seconds.
3.207. I can help you out.
3.207. Yeah.
Yep. Mm-hmm. Yeah. Last year you budgeted over $3.571 billion in capital spend for the 2024-25 year, but this year the budget shows only $3.2 billion. So that's a $364 million cut. You said you wouldn't be cutting that budget. Have you misled this committee?
No. That's not the case. We haven't, from my perspective, budgets are really important for health. I just want to tell you though, and you would know this as an infrastructure minister, I think, funding profiles for capital shift year to year, so that if you go back to say a metro project or a road project,
I'm not talking about metro.
that you
Let's
need
talk about
being
health.
involved in. But funding profiles for capital shift year to year when the projects are delivered. So for instance, in year 3, 4 of a 5-year build is where the heavy investment is. So we've delivered the largest budget overall in the history of this state, which is just over 35 billion. So
sure, but that is not played out in these numbers when it is very clear that you budgeted 3.57 billion for 2024 and this year it's only 3.2. That's a straight up cut, isn't it? From your perspective, have any capital projects in the health CapEx budget changed delivery timeline since the last estimates this year in February?
No, I'll throw to the CFO for 1 minute, but I just say to you, I just think it's important that people understand the way in which a project is delivered and that funding changes.
All right, so let's talk about that then. Have you delayed any projects since February?
Capital funding has increased, I think, in the tune of around about 11.2% this year compared to last year. Now, I'll stand corrected on that, but I think it's around that. Alpha,
well, I can
did
come
you
back
wanna
to that
add
in the afternoon.
anything?
No, we can come back to that in the afternoon. I've got you for a limited time and I'm interested in asking you about your budget, your responsibility.
But your questions are important and I want to make sure they get proper answers.
Certainly. It just seems that there's 360...
I take your role seriously and I'm trying to make sure I give you as clear answers as I can.
Thank you. Let's go again. So $3.57 billion in capital spend for 24-25. This year, 3.2. There's $364 million difference between those two. It seems that you're contradicting yourself, Minister, when you can't say whether any CapEx budget items have changed delivery timelines since February this year.
Okay, I'm going to say again, one about the profiles, and then I'll say not a single project has been reduced by a single cent. In fact, this is not a criticism of your government, so I just want to be clear, we've had to substantially increase that component of capital because of cost escalation.
But that's not what the numbers show in your budget in print. 3.5 down to 3.2. That's $364 million difference. It's a yes or a no. Have you cut projects or delayed them to provide for the 364 cut?
Okay. Chair, I just want to try and answer this, if that's okay, because it's important. You're pointing to a figure in the budget that I think would be a forward estimate, not an actual budget. That's first and foremost. That's what I'm going to say.
What does that mean? You've budgeted 3.57 in your budget.
Sorry. Hang on.
Yeah, I'm looking at your budget.
Hang on.
And your budget line
I just need to get this double checked.
You're contradicting
You're not saying
yourself.
you don't understand that. Is that I just want as a cap.
It's not about me. It's your budget, your responsibility, your budget estimates. It's your printed line item that shows between 2 years a $364 million cut. Either you've misled this committee. 24-25 shows 3.57 billion, and then that goes down to 3.2. Where's the money gone, or what have you cut?
As I said to you earlier, there has been a rebalancing which occurs as projects move through a cycle. That's one. Two, not a single project, just remind the committee, not a single project has been reduced by a single cent. In fact, over the 4 years...
This is not the forward estimates.
There's an extra $840 million for existing and additional projects.
This is not the forward estimates, and I'm not asking about your forward estimates with respect, Minister. I'm asking about your cut of 364, where that's gone.
I just answered that question.
You can only do that by delaying projects. That's the only way. Anyway, we'll move on. Recurrent health spending is going backwards in real terms, and you've cut over 10% from the health infrastructure budget this year. What projects are facing cuts?
Okay, well, there's none of the projects, so I just want to be clear on this. You would have probably felt it in your last budget, I would have thought.
What about me?
There would have been, well, just let me explain it. There has been significant cost escalations on all of our capital, not caused by anything the former government did or the current government, just through supply chain and through macro impacts on the way in which infrastructure's delivered. This is the largest budget on record. Those projects are not cancelled or changed. We've had to increase the capital budget for some of the projects because some of the projects, I'll give you an example, like Shell Harbour, needed additional money to make sure the project could be completed
We'll get to
in a
Shore
way
Harbour
that was
and why the
committed.
CFMEU's caused extra money to be spent there. We'll get to that.
Minister, perhaps we can talk about RSV vaccine. How much supply of Abrysvo, which is the vaccine for pregnant women, and Beyfortus, the immunisation for babies, will New South Wales have next year?
Yeah, very good question. Just before I ask Dr. Chant to respond, because it's but I just want to give you very quickly, we've been actually liaising with the Commonwealth at ministerial levels around this. It's a very, very good question. The RSV supply concerns me greatly. Okay, so that level of vaccination and making sure we've got a supply is concerned me greatly. Dr. Chant this year worked very well to make sure that we had that. We're in the process of having discussions and negotiations with the Commonwealth to make sure there is certainty going forward. It's a very good question. I just want Dr. Chant for 45
I might get the details
seconds
from
just
Dr.
to
Chant
outline
this
it.
afternoon.
Okay.
If I get the details, thank you for the offer, and I look forward to talking to you, Dr. Chant, this afternoon. And I appreciate your concern. Is it true that Sanofi approached your department at the end of last year with an offer to immunise all infants in New South Wales?
Well, that specific discussion, there was an approach. There's no doubt about that Sanofi did, and I understand they approached other jurisdictions. We've worked with Sanofi to deliver a targeted immunisation program, and we are pleased to partner with them this year. But
you were late
Ms.
in
Carter,
getting those discussions with Sanofi, weren't you? So that by the time New South Wales took up their offer, there wasn't supply for all of the infants in New South Wales, which is why you only had supply for under 9,000 doses. If it's so important to you, Minister, why the delay in these really important negotiations?
Well, that's not, those assumptions that you made with that question, not correct.
So you had enough to immunise every baby in New South Wales, did you, Minister?
Well, I'm pleased we were one of the only jurisdictions in the country to deliver this targeted program. That's
You
what
had
I'm
enough for
pleased.
every baby in New South Wales,
Well,
did you, Minister?
To be fair, I'm allowed to, I've taken 99% of everyone's questions here. I am allowed to ask Dr. Chant to add a small amount to make sure that an important question on an important issue, no one believes in vaccination more than me, well, probably Dr. Chant does, but no one else certainly does. So just respectfully, I'd just like to ask Dr. Chant to clarify that for 30 seconds.
So you're saying you don't know the answer, but Dr. Chant knows the answer.
I'm not
Is
saying
that.
that. I've told you about the arrangements that we've had in Sanofi, and I understand the importance of it. Dr. Chant is actually dealing with this issue on a weekly basis, so she may have some more information to outline to the committee, and given the enormous amount of respect...
And I look forward to following up with Dr. Chant this
Ms. Carter,
afternoon.
given the enormous amount of respect I put on budget estimates committees and the inquiry, and the way in which people ask questions, I just wanted to make sure there was an opportunity for Dr. Chant to clarify something.
And there will be this afternoon, and I
Sure.
thank you for that. You would be aware that Queensland and Western Australia immunised all their infants this year, but New South Wales did not. Why?
Well, as I said, we are working through Sanofi, we're working with the Commonwealth to improve the rollout going forward. We targeted our program, Ms. Carter, to vulnerable populations. That's where we wanted to prioritise. I think you'd probably agree with that. But we're working with both the Commonwealth and my other jurisdictional partners for next year. Now that rollout for next year hasn't been locked away yet, but as late as a couple of weeks ago at the Health Ministerial meeting, we raised it. Dr. Chant and I actually raised it with the Commonwealth Minister, and our agencies through Dr. Chant are continuing those discussions. And all I was prepared to offer the committee was a 30-second update from Dr. Chant to make sure that if there was anything extra.
As Minister, can you commit to join with us to providing RSV immunisation for all pregnant women and infants in 2025?
I'll continue to have those discussions with Sanofi, Dr. Chant and the Commonwealth. It is a very, very important issue. Dr. Chant?
So your commitment is to talk, not to immunise. Is that right, Minister?
Can I?
Could
I just clarify? I think it's really important because I'm
with respect, Dr. Chan, I'd like to come back to you this afternoon. Our time with the Minister is very limited. Perhaps
I'm not going to make a big deal of it, but I think the last comment was a little bit disrespectful, given my public record on vaccination. I'm going to let it go
Minister,
there.
I asked for a commitment, you couldn't give it.
Yeah, well...
Chair. Thank you, Chair. Minister, when did the states pass on to the federal government any notifications from its suppliers of IV fluids that they were unable to meet their contracts?
Yeah, big issue, IV fluids.
When?
The issue around IV fluids and the shortage of them has been one that essentially has been caused by a range of different manufacturing and supply chain issues. I've actually met with the representatives.
Minister, I have 5 minutes. My question was quite specific. Okay. When did the states pass on to the federal government any notifications from its suppliers that they were unable to meet their contracts?
Look, I think we were liaising with the Commonwealth from August, but Ms Ward, I respect this committee, and I'd want to try and, if you want a specific date, then I'd want to take that component on notice. Just so you know, this has been something that I've been getting daily and weekly briefings on.
Good.
I've met with the company responsible to make our case,
Yep.
and I'm pleased these shortages are now being resolved. I'm not saying we're out of the woods yet. I'm saying that largely they've been resolved.
Are you aware of the reports that the federal government was made aware of the looming shortage of IV fluids over a year ago?
I've heard reports, but I just, I'm not 100% sure of that exact date.
How many weeks? Thank you. How many weeks worth of contingency stores does New South Wales have?
Yeah, I can provide you that, and I just sort of be as accurate as possible to make sure that it hasn't changed from the briefing I received on Friday. So this is as of Friday. We've got, and Joe, if I misquote any of these, please jump in to make sure that we give accurate answers.
How many weeks?
Most LHDs have got certainly over a week's supply, and more likely heading towards 2 weeks supply in terms of LHDs, ambulance, and our health services. Now that wasn't, I've just got to be honest with you, that wasn't the case some weeks ago, and Matthew Daly, Joe Edwards, and myself met with the suppliers because I was concerned to make sure that New South Wales, given the volume of patients that we were dealing with, were prioritised.
Sure, thank you. I'm sure those meetings are important, and thank you for that. But how much are we spending on emergency supplies of IV fluids, and where's that supply coming from?
Well, Joe, jump in here, but what we have is a contract with our suppliers. I asked them, have they adjusted the price around that contract? They said to me they haven't. What they have been trying to do is increase their manufacturing and supply levels to meet our needs, because they weren't, Miss Ward, meeting the needs that we needed in terms of supply. But Joe, did you? Or,
all right, no, I'll come back to you this afternoon. Thank you. But so, what will you personally do, Minister, to secure supply moving forward?
Oh, well, that's a very good question. I'm going to continue to engage with the teams who are looking at this within health, and I will make sure that I reach out again, like I already have done, to the company if I start to see supply challenges again. Now, I'm not saying we're out of the woods, though. Just to be clear, I'm more comfortable than what we were. I'm more comfortable than what we were 2 weeks ago, and we're also engaging with the Commonwealth on this. That I know you would know.
Right. So engaging and reaching out, that's great. I'm going to move on to the Lung Foundation. Minister, why did you reject the Lung Foundation's request for $6 million over 3 years to fund specialist lung cancer nurses in New South Wales?
Oh, well, look, the work that those organisations do is important. I'm not denying that. I'd need to get some clarity around the question that you're asking.
The question is, why did you reject the Lung Foundation of Australia's request?
I'd need to get that clarified, and then I can come back to the committee. I think you'd agree that I haven't taken virtually any questions on notice.
Sure, I appreciate that. You've made a valiant effort, but I just want to, it's very specific. Why was it rejected?
Well, I'd need to clarify that, so I'd need to check, and I'd take that one on notice for the committee because I
Certainly.
want to give an accurate answer.
Lung cancer is the leading cause of cancer death in New South Wales. Why could you not find $6 million to help fund them?
Well, there's a lot of pressure on our budgets across the board, and yes, the work that all of our not-for-profit and our partner organisations do is important, but we've also, just to be clear on this,
Budget.
we've also lost billions of dollars in GST payments, much of which would go to health and education. So this is a challenge, but I'm more than happy to have a
So have you called your federal counterpart to talk about that?
I'm more than happy to have a look at the situation.
Have you called Albo?
But we are making, I think everybody would have seen my public commentary.
Minister,
around
is it a
what I think of
disgrace and a
this. I
slap
don't
in the
think I've
face
missed-
to
I
not
don't think I've
fund
missed-
$6 million for these nurses? They're the words of the CEO of the Lung Foundation. Is he incorrect to call it a disgrace?
I'll leave other people's comments to them. I'm not going to pass judgment on them. That's not the way I've been brought up. But I'll leave that to them. But I will say to you, I will have
It's
a
not
look
a
at.
disgrace.
I will have a look at the correspondence and I'll have a look at the situation. But I'd like to provide a more detailed response. I'd like to take that one on notice, if that's okay.
Thank you.
I'll go to the Honourable Emma first.
Good morning, Minister.
Good morning.
Just want to thank you for the apology that you gave to the women who were survivors of birth trauma. And the feedback that I've received is that that's been really well received by the community, so thank you for that. In the birth trauma report, there were several recommendations that were supported in principle, and I note that the majority of those recommendations require some level of funding. Can I get your commitment as the Health Minister to push within government for funding for those recommendations so that we can actually see the majority of those recommendations realised?
Yes, you can, absolutely. And I remember when you came into my office and you talked about establishing this inquiry. I remember it like it was yesterday, and I wanted this inquiry. That's not always the case for ministers, but I think it was an area where we could make improvement. And full credit to the team of New South Wales Health and the Ministry of Health. They have really focused on this as an issue. I know we've got more work to do. Yes, you can be assured that I will take those issues up. You know that I wasn't trying to be tricky around the supporting principle in any way, shape or form. It was just a matter of that needed to go through government process. But having had the Better Burst Illawarra, I've been a very strident campaigner and an advocate. I'm really pleased that the team, through Deb Wilcox, the team at the Ministry and the team in the local health districts are really starting to make this a priority, and there are, from memory, those 5 areas that we are trying to fast track that I think was important to you as well.
Yeah, definitely. I think I just wanted to get confirmation on record that you would be pushing within government for those in principle recommendations.
Yes.
Thank you. Now, obviously, one thing that came up very, very strongly throughout this report was that the gold standard of care is midwifery-led continuity of care.
MGP, yep.
And obviously we've got a long way to go in supporting the midwifery workforce to be able to sort of realise and dramatically increase midwifery-led continuity of care. What are you doing as Minister to work towards that pathway of increasing specifically midwifery continuity of care?
Yeah, it's important. We've got the blueprint that sits behind a lot of this work. We are obviously, in terms of the workforce, engaging with that workforce through our study subsidy program. So that is providing $12,000 up to 12,000 people to work through their nursing and midwifery and others, but nursing and midwifery degrees. We think that is important. We are trying to invest heavily into Mid-Start. Now, Mid-Start, Ms. Hurst, is a program where nurses can make the transition across to midwifery, so we are certainly focused on that. We've also established 2 groups, an expert health ministerial expert advisory group and another one which is a consumer reference group, and they are helping to not only on the implementation of the inquiry but also providing advice to government around what we need to do in this space. But you are 100% right in the challenge that is midwives is real. It's a global challenge. It's been around for a while. Minister Hazzard has said to me in the past that this is a real challenge for us to deliver healthcare services, and in the bush that is even more pronounced. So we are doing what we can, but I don't pretend for one moment to think A, that it's an easy challenge, and B, that the job's over. I certainly don't want anyone in here to think that just because the trauma inquiry has completed.
We've got another issue at the moment, and I understand it's federal when we're looking at privately practicing midwives and insurance.
Yeah.
And the concern is that federally, if that is quite limited, that will increase the number of free births, so without having any kind of healthcare practitioner around.
Right.
Is that something that you've been briefed on, and is that something you're sort of advocating on within New South Wales?
Yeah. Probably briefed might be a bit exaggeration, which I don't want to do. I've certainly been made aware that this is a challenging component. Deb, are we, just in terms of, are you aware of anything in this space around the insurance?
Not at the moment.
No. Susan, do you want to? Sorry.
Just quickly.
Just very quickly.
Ms. Hurst, this issue of privately practicing midwives and their insurance has been going on for a number of years. So there's been exemptions under the national law for them for probably at least 15 years, which has enabled them to continue to practice safely. It is a priority that we continue to work on, but it very much is a discussion with the Commonwealth. It's really not necessarily a matter for the state on its own.
Yeah. Thank you.
Minister, I've got a few questions around COVID being acquired in hospitals. When I asked about this last estimates...
You asked it last time, yes.
I did. I got a comprehensive answer on notice with thanks to Dr Chant about the Clinical Excellence Commission, which has implemented precautions that are based on transmission, not universal precautions. So if the patient's known to have COVID, the staff then need to mask up. But if the patient isn't known to have COVID, there's no universal precautions against airborne infections like COVID.
Right.
Last estimates I raised the really distressing figure that in Victoria 1 in 10 people who caught COVID in hospital died from that infection. And I was really distressed to find out that in New South Wales we're not even counting. I've asked in multiple times in multiple ways. Nobody can tell me how many people are catching COVID in New South Wales hospitals. So my question to you, for people who are vulnerable, if they've got chronic illnesses, if they've got immunocompromise and they're turning up to a health facility in New South Wales, should the responsibility be on them to advocate for themselves and to ask staff to put a mask on? Or should healthcare facilities be universally safe for people who need to access them?
Well, we want and expect health facilities to be safe. Respectfully though, I think you'd understand that COVID remains a real challenge in our community, and the reduction in vaccination levels concerns myself and Dr Chant significantly, probably caused by a sense of vaccination fatigue as a result of COVID, and that's not having a shot at anyone who's not vaccinated, it's just the reality. That therefore increases the likelihood of the severity of the illness and then presenting to our hospitals. I think our hospitals are doing what we can to manage what has been a challenging winter, where we had big increases in RSV, big increases in influenza, and big increases in COVID. I'm not sure how we could do much better than what we're doing in terms of that.
Thanks, Minister. And look, I appreciate that you're a strong proponent of vaccination. Thank you for that.
Yeah.
There was a study that was just released last month by the Burnett Institute. This is a peer-reviewed published study. It's based on Victorian data because that's the data they have.
Yep.
Now, that study showed that really simple measures, so testing patients on admission to hospital with a RAT test and staff wearing N95 masks as standard, could prevent 1,543 deaths statewide per annum and save $78.4 million.
Okay.
That was for those two interventions together, and they also showed individual benefits. So either testing every patient on admission or the staff wearing N95 masks in all the clinical areas of the hospital. So not in the cafeteria and the gift shop, but in clinical areas.
Yeah.
That's pretty compelling data. Are you going to look at that and take a look at changing our approach in New South Wales hospitals?
Well, I'm a nerd, so I love research. So I'll definitely have a look at that. I've read stuff from them before, but there's been some articles recently, I think I'll stand corrected, in journals like Lancet that talk about that this remains a challenge in our community, and how we cope with it within a hospital setting is challenging, just given the way in which people present to our hospitals and the way in which they move around. I think if you came into an emergency department quite unwell, you might not get a rat test. Like, I'm not trying to be flippant, but that person might slip through in terms of that type of trauma presentation, or that type of serious illness where the priority is preserving life and reducing any more harm. The priority might not be in that initial stage to do a rat test, but I don't think that means that from my observations moving around hospitals like I do, many cases in clinical areas people are still wearing masks, and they are certainly wearing masks where an LHD, I don't like using acronyms, where a local health district has identified large numbers of COVID within a particular community, so they are making those decisions locally. I know you don't want me to ask anyone else to help, but I just, Dr. Chant can add anything if you want to this.
That's
as
right.
well.
And look, you've focused on some of the more complicated issues. I appreciate there's COVID fatigue in the community.
Yeah,
I appreciate the vaccination levels are dropping off. This particular study was looking at rat testing at admission, so not at presentation. So if you come in during a car accident, no one's suggesting that it should be a priority to rat test that patient. It's at the point of deciding they need a bed and admission to hospital. So that rat testing at admission by itself, the modelling for Victoria is that would save 1,176 lives. And $57 million.
Yeah,
so this is serious, both in terms of money and lives saved.
I'm always happy.
The masks, and specifically we're talking about N95 masks or P2 respirators, so not the surgical mask, which I appreciate as a former healthcare worker myself are much more comfortable.
I was going to say, yeah.
Universal use of N95 masks in clinical area, just by itself, without the rat testing, could prevent 854 deaths statewide. Based on Victorian figures, but I've got no reason to believe, unless you can suggest a reason why ours would be any different if we were counting.
Look, I'm always happy to have a look at research, so I'm happy to take that one up and have a look at it. I just don't want the committee to get the impression, or have the impression, that we think COVID is not around, therefore it's not focused on in hospitals. I can't leave the committee with that view. I accept that. If you want me to have a look at that, I'm happy to do it, but I don't want the committee to think that we believe it's not. Every week, at the end of every week, Dr. Champ provides me with a respiratory surveillance report. It's a report that I take very seriously, and it tracks the range of different illnesses like that each week and where we're at. Now, a few weeks ago, I was very concerned, just because we had all three heading up. So this is still a challenge on our health system. I just want to be clear about that. Look, if there's always ways that we can look at to handle it better, I'm happy to have a look at it. I just don't want the committee to think that we're not doing anything in our hospitals. That's all.
Thank you. I appreciate your commitment that it is an ongoing problem. Moving to a very different topic, I understand that with the consolidation of services at the new hospital in the Shoalhaven, the David Berry Hospital is proposed to lose its very loved palliative care service as well as the rehabilitation services. And I understand from government documents that there's a fairly good rationale for moving rehabilitation services to the new hospital where you can be closer to imaging or pathology or acute care. Yeah. I appreciate that. Yeah. But friend of life care, for people who are already dying,
yes,
to have the choice to be close to home in a leafy environment where their friends and relatives can visit them more easily, I'm struggling to understand the rationale of moving the palliative care service specifically to the new hospital. Can you explain that, please?
Yeah. The palliative care service move there was a decision undertaken by the former government and supported by us because of the clinical enhancements that we could do. I'm sure you're aware of the facility at David Berry, but it's extremely It's a much loved facility, but it's extremely old. So we need for the palliative care services to be delivered in a modern way, under the best clinical practice, in a way that allows staff to do their job to the very best, but also patients to be treated at their very best. I can assure you that it will be a very, very nice space in the new Shoalhaven Hospital. I'll give you that assurance, and I'll also give you the assurance that we will continue to consult, and we've begun the consultation around the future use of David Berry, but it will remain in public hands. But we will continue that consultation because I understand it's an asset and a facility much loved. It is over 100 years old, so its ability to perform at its highest peak clinically is simply not there in a facility like that. But by moving palliative care services, we'll be able to expand them and what we offer in that new facility at Shoalhaven. And to give credit to the former government, that was a decision they made.
I'll come back to this one this afternoon. While I've got a few minutes left with you, Minister, coming back to the negotiations with the New South Wales Nurses and Midwives Association. Yeah. We've had a robust discussion about the cost, but I understand that there are aspects of the claim made by the union that, in my view, shouldn't be expensive. So, for example, full-time nurses asking to have 2 days off in a roster back-to-back, even if that weekend is not a Saturday, Sunday, but to have a weekend somewhere. Why have those sorts of claims not been met?
Yeah, I'll just be as quick as I can so that you can get another question in about that, because I know it's important to you. To date, what we've accepted in full or part, and we're just having some negotiations around one of those that you raised there. The ones that we've accepted in full or part is consultation around changes to rostered days off, information around the presentation of union information, so it was clear and easy for people to see, the right for unions to attend and present at induction sessions, which is important to them, enhanced midwifery group practice models, which we're rolling out, which Ms Hurst raised early. Prohibition on rostering a night shift before annual leave. That was something that we've been able to resolve. And a right for all days off to be consecutive. Now, from clarity, I think what we've been able to do is get to a point where we can get 2 consecutive days off in a rostered period. But I think the nurses have come back with a slightly different model or change. So that's not been disrespectful to them, but also I think you could say we've demonstrated that we have tried to get there on these issues outside of the pay issue.
My colleague Emma Hurst already asked some questions about midwifery group practice.
Okay.
So my question is, how many of those midwifery group practice models of care have been shut or ceased to operate in New South Wales in the last year?
I'd have to take that one on notice. I'm not aware of those. We are trying to look. Midwifery group practice is the gold standard. Because of the continuity care model. It is sometimes challenging because midwives, it's fairly demanding on midwives in terms of the nature of the work, and in particular settings you might not have midwives who are able to do that volume of work. So it can be a workforce challenge at times. It is not through deliberately, I'll clarify the exact, but it's not through because we don't believe in midwifery group practice. We 100% do. It's just we've also got some challenges with workforce in this space. That's all.
I understand the challenges with the workforce. Pay for midwives is one of them. The birth trauma inquiry recommended expansion of continuity models like the MGP, and I appreciate that the government supported that recommendation. It's important to expand them, but I've also heard from members of the community about services that have closed, like in RIDE, and other services that are listed as existing, but where no one on the in the community can find any evidence that it's happening. So to put that one on the record, that's Tamworth Hospital that I've received those concerns. So it worries me that there's a recommendation that's supported to expand these services. Meanwhile, ones that were functioning are actually being pulled back or have recently been pulled back.
Yeah, I'm glad you asked about Tamworth. The Secretary and I are, to be honest, looking at that issue. As late as the end of last week, the Secretary and I had a discussion around the Tamworth issue that's been raised. Haven't got a resolution just yet, but I can guarantee you I'm happy to report back when we do. The midwifery workforce is a challenge, but just because it's a challenge, it doesn't mean that we're not trying to work through these things. I'm advised, but I'll just take it on notice just to make sure I don't mislead, that the MGP has not closed at Tamworth, but we're working through some staffing issues there. So that's been as transparent as I can, and as late as last week, I received some correspondence, I think the week before last, from I think a community member, or it might have been a staff member, asking me about this Tamworth one. That triggered a conversation between myself and the Secretary, who'd also been made aware of some challenges, and we're working through it. So I just don't have the complete answer yet, but we are working through it. And from memory, I've also met with midwives at Tamworth in the hospital when I visited there. They raised issues broadly around workforce in that particular area. So, yeah, I'll come back with some clarity around that.
Thank you. I'm pleased to hear that you're across it, and I appreciate this is going to get taken on notice as well. But I'm interested to understand how many hospitals in New South Wales don't offer continuity of care where it's I'm not talking about multi-purpose services where you've got a
you're talking
nurse
about
in the
purpose.
bush. I'm talking about places where you would reasonably expect to deliver a baby, or where you can deliver a
larger
baby.
larger hospitals.
But there's no continuity of care or midwifery group.
Yeah, okay.
Practice.
I'll take that one on notice just to give you a specific amount. But I just want to assure you very, very quickly that model of care is very, very important to me, and it'll be part of the reform we do in this space. That's all.
Thank you. Okay. 2 minutes to the opposition.
Thank you. Minister,
Yes.
the Stroke Foundation asked you for $250,000 in the budget to spend on preventative community education programs, which make sure that
it was
people...
a specific name. It was
fast.
called Fast.
Make sure
Navigator, I
people
think.
get to hospital faster,
Yeah.
get treatment in the appropriate time.
Yeah.
You know about the program, you know how good it is, but you said no. Why aren't you funding stroke prevention education in New South Wales?
Well, we are funding stroke prevention education. It might not be exactly through that program.
What is the program that you're using then, Minister?
Could I just finish this one? Because this one I've engaged with a little bit on. The work that we are doing across the board, we are doing in relation to stroke. We are aware of that, and we do a range of different programs. That specific one, I'm having a look at that proposal because I'm actually aware of that proposal. So I'm having a look at that to see if we're able to consider that in the coming months. I'm not there yet, so I don't have an exact answer to you yet, Ms. Carter. But
you'll take it on notice and get back to us.
I'm confident that we might be able to get to a resolution in that space on that particular program. And
One more quick question.
Sorry. Yep.
You'd be aware that more people in New South Wales die from eating disorders than on the roads. So can you commit to ensure that the New South Wales Service Plan for Eating Disorders, which expires in 2025, will continue and will continue to be funded to support those with eating disorders in New South Wales?
Well, yeah, I mean, I've got no reason why it wouldn't be. Minister Jackson takes the lead in this. The Honourable Emily Savall, who's a part of this committee, does important work in this space as well. I can assure you, those of us who were privileged enough to see her inaugural speech would understand her passion around this. So I'm going to say yes, but the lead on this, Ms. Carter, is Ms. Jackson. So I'll just get some clarity but I'm confident with the work that Ms Saval is doing in relation to this space that we'll continue to invest in there.
Thank you.
Minister, there are critical shortages of over 400 medicines at the moment, and IV fluids is just one of those.
Yeah.
This is impacting antibiotics, pain relief for palliative care, psychiatric medications, diabetic medications. Last week, I understand there was short supply of pre-exposure prophylaxis for HIV in Sydney.
PrEP. Yes.
And you, in respect to PrEP specifically, you said that you were working to guarantee access to the daily medication for those who need it. Can you tell us what that work is, and does that also apply to all of those other essential medicines that are currently in short supply?
Yeah, so I'll deal with the issue. The issue around supply of the other medicines is a concern. The IV one is perhaps the one that I've focused on a fair bit over the last, say, 2 months, Joe, something like that, 6-8 weeks. Time flies. So I've been really focusing on that. New South Wales Health will secure a 1 month supply in relation to PrEP. That'll be available via the New South Wales, I think it's called the New South Wales Sexual Health Clinics that we have. Sorry if I've said that, as well as hospital pharmacies. So those would be the two outlets. This supply will be dispensed through the New South Wales health system at strategic locations, and we know where these are based on the data, including the public health locations around the inner city, Parramatta, as well as some regional locations. The supply will be available to the public and will be dispensed by nurses and doctors and pharmacists, but supply issues for PrEP are expected to resolve, we hope, so it's expectation, we hope, late October, early November, but we are carefully working through this issue, and that is important supply medication, and I'm glad that you raised it because it's an important cohort in terms of access to sexual health services.
Thank you. Are there questions from the government?
No questions, Chair.
Not at this stage.
With no questions from the government, we'll break for morning tea. We'll be back at 1:15. Thank you. Just before we resume with time for the opposition, I've just had a request from Hansard for all of the witnesses to please speak into the microphone so that you're recorded clearly. Thank you, and we'll go to the opposition.
Thank you, Chair. Good morning, Minister and your officials.
Good morning.
Thank you. Minister, before the election you said that, and I quote, "You'll be a minister who focuses on staffing and resourcing and not focus on ribbon cutting." But how many ribbons have you cut since being the minister?
Oh, geez, I don't know, but it's not something that is a priority of mine. I know it's a priority of different ministers from different governments. It's just not my favourite part. I don't know the exact amount that
Could you maybe just take on notice how many health infrastructure projects you've opened? I'm happy for you to supply it on notice.
Oh, yeah, I'm happy to.
Okay, thank you. And then in terms, I guess, of cuts, I want to go to a few issues that have been raised with us. Do you have any information on how many staff have been cut from health infrastructure over the last 18 months?
No, but I'm happy to have Emma from Schoolander from HI talk about any specific changes if you like. We've got a big program running out in terms of our capital, following on from the work that the former government did in this space, but probably our focus has to be slightly different in terms of health this time around, which has to be around how we properly staff those facilities and the new facilities. So it's not a criticism of Minister Hazzard or Minister Taylor at all. They had a priority around building and upgrading some of our health infrastructure, which was needed. My priority's probably been focused on the operational side, which is a challenge and expensive, but would you like me to see if...
Maybe this afternoon, or, even on notice, how many staff are in health infrastructure now, last financial year and the year before on notice would be great.
Sure.
Thanks, Minister. Just talking about services, are you aware that Armidale Mowing, who had been contracted to provide lawn mowing services at Armidale Ambulance Station since 2017, had their contract cut with no notice last month?
I'm probably a bit of a micromanager, but I think even for me, I might not be across the lawn mowing service at individual hospital sites. So I'm not.
The ambulance station.
I'm not aware. I'm not aware of that one at the ambulance station. But
Okay.
I'm happy to look into it. Dom is. Oh, sorry.
I did see. Yes, you lean over there. It's a little awkward down the.
Dom's also the commissioner in lawn mowing.
You were handyman.
my alternative career.
I am just conscious of time, Mr. Morgan, but if you wanted to add
I'll be
something
super quick. Yes, so we went to an emergency services contract that has allowed us to leverage across the state, and so it's a single contract that's been done by Public Works, and they're still free to engage subcontractors across the state to do that work.
So, Minister, just picking up from that answer, will you have a look at that particular issue and then other small businesses in regional areas that have been cut and make sure that engagement? It's a big part, as you'd appreciate, of their business to have that government contract.
Sorry, it's a very big part. And out in regional, rural, remote, the presence that health has had traditionally is significant. And I've spoken to former Minister Taylor about some of these issues where the footprint is significant, and we've got to look at it more than just a health service, but the economic activity that it can drive, as you know, over multiple years in terms of builds. But yes,
well,
I'm happy to.
this was more about ongoing maintenance, but if you could make sure that communication is happening.
I'm happy to through the Commissioner, yes.
Thank you, that would be good. I also want to take you to another procurement issue. Were you or your office consulted prior to the milk supply contract for the Mid-North Coast and Northern New South Wales health districts being taken off the local farmer co-op, Norco?
Norco? Yeah, can I have more than 30 seconds on this one, just because I just want to be clear with the committee. So, obviously, and you're a minister, you've been a minister, Ms Mitchell, so you'll know I don't and should not get involved in the procurement at that level in terms of the supplier and the procurement regulations. That's done through the agency. When I was made aware through the local member and two national members, I did ask to have a look at the process and just to satisfy myself that the completeness of that procurement process. Now I'm working through that information that I've got. There is certainly nothing that indicates anything other than completely normal in terms of the way in which we've procured those services. But I have got a discussion locked in with the local member, Ms Saffin, the Norco's CEO, and our procurement team next week. But I just want to be careful, and I know you completely understand this, but just so the committee's aware, I don't make individual procurement decisions around suppliers who bid for government contracts. That would be highly inappropriate.
I understand.
I know that you know that. I'm just making sure everyone...
Yeah.
I don't make the decision of where they go to. They have to satisfy a criteria. Then as a decision is made by our procurement team with Alpha and others involved. That's not a decision for me.
So-
But I am looking at the process, and it's not that I'm not satisfied. I just wanted to assure myself that this had been done in a way that had taken into consideration all of those things.
Will your office or yourself also invite the concerned National Party MPs to that meeting?
I'm
or
happy
briefing
for them
next
to
week? 'Cause
have
I'm sure they would like
I'm
to
happy for them to have
be part
a
of it.
discussion as well, probably maybe separately, but maybe together if that works. But I'll
Happy to, thank you, I appreciate that. Do you know, and I'm happy for you to take it on notice, but was there a cost saving from this decision? Was that the driver of the change?
I'm going to say I take that one.
That's fine. I'm happy
on
for you to
notice,
take it.
just given the degree, if that's okay.
That's fine. So I guess, and I appreciate what you've said about not being involved in procurement, but obviously a lot of the farmers and Norco themselves are concerned about
100
what this means for their business operations.
Yep.
So is there a chance that this decision will be overturned?
I don't want to say that at all, because I don't want to give any impression that a minister would make such a decision. That would need to be a very unique set of circumstances that a government minister would change an already contracted out service that has had that was an extensive tender process for about 18 months or so, carried out in accordance with the procurement framework, as well as probity advisors, external advisors. So all of those things were built into it. So I don't want to give that impression, but I am just having a look at the process and satisfying myself that all of those other considerations were taken into account as well. Now, nothing indicates that they weren't, but I am meeting with Alpha's team from procurement and Janelle Saffin, the member for Lismore, next week, as well as the Norco CEO, and I'd be happy to engage in dialogue with the member for Clarence and the member for
Coffs Harbour and
Coffs Harbour.
Oxley, and I think there's
Yeah.
a few up there who'd
Yeah.
be interested, Minister.
Yeah.
So I'm sure they'd appreciate that. And Miss Saffin might ask you to sign her petition when you meet with her, see how you go with that. I want to take you to the issue around paramedics in regional and rural areas.
Yeah.
I note that there was an announcement just late last month from you about the additional 125 paramedics.
125,
Yeah,
that's a start.
So can you tell me how many of them are brand new paramedics?
Well, they're all brand new paramedics.
Okay.
Yeah.
I guess my second question then is how many of those 125 are intensive care or extended care paramedics?
I'd need to probably take that one on notice, unless Commissioner Morgan has it.
This was only a couple
No,
of weeks
the
ago.
election commitment was for 500 paramedics. There was
Right.
no funding provided for specialists.
It's interesting because I've got the PBO costings, Minister, where you do talk about those 500 paramedics would all be extended care or intensive care paramedics. So has that position changed of government?
But there's no way they would all be that, because that level of number of paramedics in that specialty area we don't need. Some of the challenges with ECPs and ICPs out in the bush is continuity of their service and needing to make sure that we do that. Since we've come to government, we have delivered on additional ICPs and ECPs. We've delivered training to around about 60 regional ICPs, and their intensive care paramedics, and around 5 ECPs. That is on top, Miss Mitchell, of the 125. So this is an issue. It's been around a while now, this one. I've spoken to a number of paramedics about it. It's trying to make sure we get the balance right between having specialist paramedics out in the bush, but them continuing to be able to maintain their skills and their continuity of service, which I know you know.
I understand that. I apologise because, as you know, we don't have
Yes,
a lot of time.
no.
I've got a copy of your election costing request form here, which is dated the 25th of January last year. And in summary of policy, description of policy, it very clearly says Labor will provide $150 million over 4 years towards hiring 500 paramedics, in brackets, who will be intensive care / extended care paramedics. So that was the commitment in terms of your rural and regional paramedics package, 500 of them who will be intensive care, extended care paramedics. Is that no longer the commitment?
Look, I'm not aware what you're looking at, but I'll just take it as...
It's the PBO costings with respect
so I'll just take it as read. You
You
wouldn't do, and it may have been communicated wrong or written down, I'm not 100% sure. What I'm telling you is, and you would know this, you wouldn't need 500 ECPs and ICPs because they are a specialist type of paramedic.
I understand that. My problem, though, Minister, is with respect. These are your PBO costings that are publicly available before the election, which very specifically spell out that they will be intensive care / extended care paramedics. Is that a broken commitment to regional New South Wales if that is not what you're going to be able to do?
We're going to deliver 500 paramedics. We've also got a commitment to train further ICPs and ECPs. I can't be clearer. I'm doing both. I understand they're important, but I know you know healthcare enough to know that you wouldn't need 500 ECPs and ICPs. That's all I'll say.
Look, all I'm saying, though, with respect back to you, Minister, is that that's not what your election commitment was and what the costing is. And so I would put to you that that's a broken commitment because it's not in line with what was said before the election.
Well, we're rolling out 500. That's arguably the biggest investment. It's the biggest investment in paramedics in the bush we've had for a long time.
Minister, I'm not disagreeing with you. My issue is that intensive or extended care paramedic can make a really big difference in a lot of those communities. And if the community expectation was that was what your government would deliver and it's not going to be the reality, I just think it's important to get that.
Well, I understand that you may be looking at, because for my sins, I've been in opposition for a few times, so I knew those PBO costings fairly well. I think you might be looking at the costing request, not the costing summary component of it. And the PBO costing summary, I think, would make clear that it's not for additional 500 ICPs and ECPs. You will find in opposition, obviously, as you work through this, you request a costing and have a lot of back and forth on assumptions. That's all. So,
well, we can agree to disagree. Sure. I wanted to also, I've only got a little bit left. IPTAS and some of the challenges with patients accessing that scheme. Do you think it's appropriate? There's a 17-year-old child who's undergoing serious medical treatment in a children's hospital, hundreds of kilometres from home, can't return home. But because of his age, he's told that he's an adult and they don't qualify for IPTAS support for his family. It's a specific example and I'm happy to talk to you about it offline in terms of the personal details. But that doesn't really, to us, seem to fit what should happen with criteria.
Okay, so I'd certainly want to have a look at that. IPTAS, and I think you would agree with this, Ms Mitchell, is absolutely critical to the way in which communities can access healthcare. I have spoken to many people who have accessed that program. I did both as a shadow minister, so to be fair on the last government, and since I've been a minister. I think the budget for IPTAS is somewhere around about $200 million, I stand corrected, and we, from that, expect around about 45,000 people to access IPTAS and benefit from it over the course of that. We've also made some improvements through Luke Sloan and the Deputy Secretary and his team around the form and the administration, but I'm more than happy to look at that particular example.
Yeah, and we might take that to you.
No, 100%. That's not an issue. I just want to make sure you know the value of IPTAS.
Trust me, I'm well aware of the value of it. But when there are sort of, I guess, technicalities anomalies, like that, which don't really suit the needs of the families, it's important that we can have that dialogue. Dr. Conn spoke about this a little bit earlier, but the issues around midwifery services in regional areas. I know you talked about Tamworth before, but can I just put some questions to you? Obviously, you know I live in Gunnedah.
No.
This is a massive issue, not just for Tamworth, but frankly all of our surrounding areas where you've got the Tamworth maternity unit being placed on bypass. There have been multiple reports, Minister, of women having to drive many hours in labour. You know, there's an example of somebody I know in Gunnedah who went from Gunnedah to Tamworth to Armidale to Inverell. There's been front page papers about women in Tamworth turning up at the hospital in labour, several centimetres dilated, and their partners have to drive them to Maitland Hospital. You're a dad. If you went to your local hospital and they said, can you drive up to Maitland? It's about the same distance from your electorate up there. These are not great situations that women are finding themselves in.
No.
What can you do that is tangible and real to support some of the workforce challenges and to make it so that women and their families still feel safe giving birth in rural areas, particularly Tamworth and Gunnedah? Because I'm telling you, Minister, this is a huge issue that the entire community is very, very worried about.
Yep, and so am I. I'll be perfectly blunt, and so is the Secretary. And I don't want to go into every private discussion that's been taken place, but the Secretary's also had a number of discussions with the Chief Executive of that local health district, and made it clear that this is an issue that we need to try and resolve as quickly as possible. Workforce, as you know, in regional and rural areas is a challenge, so I'm not saying that it's going to be resolved quickly, but I can give you this assurance that, having read pieces of correspondence around this and people being generous to write to me about this, it's critical that we resolve it. You would be aware the program that was started under you and increased under us around the rural incentive scheme to try and attract more staff to some of these areas, 10,000 and 20,000 in hard to
But are
fill.
midwives in Tamworth and Gunnedah eligible for that?
They would be eligible, as I understand, for probably the $10,000 component. I'm not 100% sure whether they would reach the 20,000. But Phil, did you want to just quickly add something to Miss Mitchell's question?
Yes, Minister. So the team has been working in the last fortnight on making available a $20,000 sign-on bonus for midwives commencing anywhere within the modified Monash level 3 to level 7 facilities. We'd make it a specific campaign under the Rural Health Incentive Scheme. It'll initially be a 6-month campaign. We've canvassed it with all the regional chief execs. They support the initiative. They believe it will assist them in attracting people and getting them on board, and we'll do an evaluation at the end of 6 months to look to learn what we can and continue if appropriate.
Okay. So, and sorry, Mr. Minns, when did you say that should start being made available?
Well, the work's been done to design the approach in the last fortnight, so I don't actually have a commencement day, but I can try and get one in the course of the day.
That would be great, thank you. And Minister, I'm aware you visited the region, and I respect that, and I think, to be frank, compared to some of your colleagues, you are very good at engaging with local members about these issues, and I do just want to put that on the record. But can I say, particularly, the figures that we're getting from some of our local midwives, Tamworth Gunnedah Hospital operating with a 60% deficit, and I appreciate what Mr. Minns has just said. The other issue that's been raised with us is that the Registrar and Gynaecology program from John Hunter has actually stopped in Tamworth. Is that correct?
Oh, jeez. I haven't been made aware of that.
Okay.
Let me try and find out something during the day. But you are right, Miss Mitchell. Birthing services are challenged in all areas, but they're particularly challenging in regional and rural. And it is not lost on me the fact that people have to spend an enormous amount of travel and distance to access these. So when I hear of concerns or pressures in the bush, it is pronounced not because one group is more important than the other, just that the challenges that women and families have to access that care is far more difficult in rural and regional and remote compared to metropolitan hospitals.
And with respect, when your level 4 tertiary hospital unfortunately at times has to turn women away, and the staff do an amazing job.
Yeah.
But what happens is you lose that reassurance. I mean, I had both my kids at Gunnedah Hospital and Tamworth was your backup. People don't have that confidence anymore, and it's not anyway a reflection on the staff.
No.
But it's a real problem when they're not getting the support services and the numbers that we need. So we will continue, with respect to talk to you and work with you on this.
I'm happy
because I
think it's a big issue, and so does the Secretary.
Yeah.
To be fair,
and in terms of midwifery group practice in Tamworth and Gunnedah, you talked about that in relation to the birth trauma inquiry.
Yeah.
Can you give me an update on the program?
Yeah, I understand in Tamworth that continues to be in place, but we are having some challenges with staffing broadly, and we are engaging with them. If that answer is a bit grey over the course of the day, I'll just double make sure that is the case for Tamworth. Did you say Gunnedah?
Just if Gunnedah, it's not there at the moment, but if that's an option in the future, that'd be good if you could provide
at Gunnedah.
At Gunnedah.
Okay, right here.
Thank you. Thank you, Minister.
Right.
I'll go to Ms. Kate Fairman.
Thank you, Chair. Morning, Minister.
Morning, Kate.
Minister, do you think it's acceptable that First Nations children in Broken Hill have double the amount of lead in their system than non-Indigenous children?
No, when I read that report, it was extremely concerning. These reports around a range of issues out in rural and regional and remote New South Wales are concerning. That's not the only one in terms of public health challenges that we face out there, but that is a significant one. Dr. Chant and her team obviously liaise with and work with the respective agencies around reports and monitor what is going on in those communities. But I would hope every parliamentarian is concerned about.
Minister, are you aware of why the blood levels are rising? Like over the last couple of years, blood levels are rising in some of those children. Lead levels, sorry.
Yeah, I'm. A couple of things I'll say on that, Kate. I want to assure the community that we have a comprehensive plan in place to reduce those levels as low as possible, but there's always more that can be done, and where improvements can be made, we will obviously look at those. I am encouraged. Probably one piece of encouragement I'll say to you is that there is high rates of screening within the community, and regular blood screening for lead is a vital way to check that our children are safe. New South Wales Health, through Dr. Chant and the local health district, continue to reiterate that, and this is important, the simple steps that everyone can take to reduce their risk include things like hand washing, clearing the dust, drinking town water, etc. But I know you all know this, but the EPA are the lead agency. That's the only thing.
Thanks, Minister. So New South Wales Health, I mean, yes, they issue advice around this in terms of the dust. I mean, it's pretty hard to say to children living in Broken Hill, isn't it, to avoid the dirt, to avoid the soil, because that's essentially what they have to do, plus to avoid the emissions from the lead mining that's taking place there?
Yeah, it's a challenge, and there's no two ways about it given the nature of the environment that it is. But we are determined and respectfully, I know Dr. Chant cares deeply about the healthcare of people, particularly in remote and regional New South Wales. I see that care every day. This is something that we are working with the EPA on. We know we play a role. Dr. Chant, did you want to add anything just to close off Ms. Fairman's?
I think we would recognise that there needs to be a complex solution to this, and there is a whole of government approach coordinated by premiers to bring all of the agencies to the table as well as local government to look at a solution. Clearly there's long-standing contamination of the environment. The needs are complex, and access to some of the issues that are impacting it is access to housing, particularly in areas. So I think that whilst health takes a key role in supporting the lead monitoring program, we recognise that a whole of government approach is needed
Sure.
to
Let's stick
mitigate
with New
this
South
area.
Wales Health's responsibility here, though. So it's concerning, I assume, Dr. Chant, from a medical perspective, that for Aboriginal children, the most recent results have the average lead in their blood of 7.9 micrograms per decilitre. That's a concerning level.
That's correct. I mean, obviously we would like lead levels to be as low as possible, and we always work to ensure that there is no disparity in lead levels between the population. So that's a particular population.
There's huge disparity,
Huge
isn't there?
disparity. And again, we would work
with some Aboriginal children had blood levels above 20 micrograms per decilitre. That is incredibly concerning, isn't it?
Absolutely, and what we do is on individual cases we do follow up and look at remediation and other aspects, but given the contamination in the environment more broadly, as I said, the longer term solution to this requires a whole of government approach.
So the contamination in the environment more broadly, let's just look at that. So that's a lead mine in Broken Hill. There was a report that was undertaken in 2019, in December 2019, the environmental lead risks at Broken Hill by experts in their field, that essentially recommended a range of different things that had to happen to protect the children in Broken Hill from lead poisoning. One of them was a citywide solution, essentially, and looking at how to curtail the lead that's coming from those operations, the mining operations. So wouldn't it make sense to, if you can't curtail the lead, the emissions that I assume is part of the problem, wouldn't it make sense to try and stop lead mining occurring as much as possible around populations in the future? Minister, did you hear that question?
No, sorry.
Wouldn't it make sense, given what's happening with the children in Broken Hill who have very concerning levels, according to the Chief Health Officer, wouldn't it make sense to stop lead mines being built, from a New South Wales health perspective, if you had a say, being built near populations in the future?
I think, and I'm doing hypothetical, right, because I don't have a...
Well, I'll give you an example. There is an example that,
so
that I'm getting to.
We would, from a health perspective, through that approval process, contribute to advice going to government.
Which you have.
And that would be led by Dr. Chant and her team around that. But that
Thank you. That's exactly right.
Okay.
So getting to that health advice. So this is a lead mine in Broken Hill. It's there. It's operational. The evidence is well and truly in that it is poisoning the blood of the children that live near that mine, and it is poisoning the blood of First Nations children more than non-Indigenous children. There is a mine that is being proposed near Louis, or in Louis, 2 kilometres from a public primary school, 2 kilometres. The advice that New South Wales Health provided, I think, was generally didn't raise alarms about that. How is that, Minister? How can your department provide advice that a lead mine is a good idea within 2 kilometres of a public primary school?
Well, I'll throw to Dr. Chant in a moment, but Ms. Fairman, I hope, and I'm sure this is not the case, that you are thinking or determining that health officials will do anything but give free and frank advice around the health impacts of developments. I mean, that is a baseline what I expect as a minister, and I'm not in any way, shape or form involved in the provision of that advice, as you could imagine, because it's carried out by public health officials like Dr. Chant and her team. Dr. Chant, did you want to add?
So the process, and look, I'm sorry I haven't got the Louis information with me, but if I can just talk about the process. So in in terms of these major developments, there is a requirement under environmental law that
Yes.
there's an environmental assessment. Health reviews that, so EPA is the lead, and that report is commissioned independently. What that report looks at in particular, and Health is interested in it, is looking at the exposure pathways and the evidence for how product moves from the location of any mining or industry or factory, and how that could potentially impact on people.
Yes.
And so the routes could be contamination of groundwater, where drinking water supplies are impacted.
So
it could be in through air emissions. So Health would look at those reviews and check that so that's being done by an independent person who looks at all of the modelling, and then we comment on whether we feel the models were appropriate, and that's the nature of the advice.
Thank
so
you, Dr.
if
Champ.
you want me
Given there's an existing lead mine in operation, that's been in operation for some time, and unfortunately the results are well and truly in that they're impacting children in terms of lead levels. In fact, probably the whole population, and indeed are increasing. It would make sense, wouldn't it? Wouldn't the advice that New South Wales Health should issue, and would have issued, you would think, to the department about a lead mine operating 2 kilometres from a public primary school as well as a village, that's not a very good place for a lead mine, and you would issue an objection?
So our role is to provide advice through the environmental planning processes.
Exactly, and I'm asking what was that advice?
Well, I haven't got that with me. And as I said,
Does it make sense to you, though, that it should be
I
rejected
think it's
from
important,
a health perspective
I think it's
only?
important that there are both environmental impacts and then there are health impacts, and there has to be the exposure pathway. So I would be very happy to go through and get my my Department of Health Protection to review what comments they provided to that. And as I said, that Health Protection New South Wales takes this matter quite seriously, but within the environmental framings,
Thanks,
we would have
Dr.
commented
Chan.
on
Minister,
those
does it concern you? Because it's quite clear, I think, what the exposure pathway is, given the research and the blood levels testing that, again, increasing in First Nations children to a level that is alarming, according to the Chief Health Officer. Does it concern you?
Yes, I was very concerned about the reports. There's no two ways about it, because
however, that there could be another mine.
Yeah, and I will, through
In the
Dr.
Mudgee
Chant,
region.
have a look at the advice that we provided. But, Kate, anything that highlights or puts added pressure on reducing the disparity between Indigenous outcomes, health outcomes, and the rest is something that concerns me.
Can I suggest as well, at the moment, the Bowdens, it's Bowdens lead and silver mine, it's on hold because of a Court of Appeal ruling that it has to go and reconsider transmission lines. Can I suggest that may be an opportunity to go and have a look at what your department submitted in relation to that mine, given the evidence that you've, I think, only just become aware of the concerns in Broken Hill in terms of what lead does to children. Thank you. I have to move on. Can I ask now about PFAS in our drinking water, in Sydney's drinking water? So, firstly, Minister, could you just please, I wrote to you actually a few months ago about this issue. What have you personally found out since then in terms of the current risk as at 10th of September 2024 of PFAS in our drinking water and the drinking water guidelines that we have, which I think are out of date?
So I'll take a little bit of time on this, because it is an issue that concerns me, and I know it's an issue that the Minister for Water is obviously focused on. Can I say from the outset that Sydney drinking water is safe to drink? I certainly consume it a lot. Dr. Chant says it should be your primary form of consumption of fluid, and that's what I certainly focus on during the day, so it's safe. Sydney Water's recently tested the drinking water for PFAS, and all samples, as I think you highlighted, were within our Australian drinking water guidelines, and I'll talk about the guidelines in a minute because they are important. Water utilities are obviously responsible for assessing the risk to drinking water, and if risk is identified, monitoring the PFAS and managing the risk appropriately. Health is advised that Sydney Water and Water New South Wales have added PFAS monitoring to their rigorous testing procedures to provide agencies with up-to-date info. Health works with water utilities to ensure they have assessed risks and monitored PFAS where it's needed. Drinking water safety guidelines, as you would know, are developed at a national level. That's important. And the national regulator, just to go, as I said, I'd go back to the guidelines, is reviewing the Australian guidelines for PFAS in drinking water. But we've requested that we want to be, that review to be carried out as quickly as possible, obviously. But I just want to make sure everyone is clear that Sydney's drinking water is safe.
Thank you, Minister. Can I just clarify, when you said you're requesting that review be taken out as undertaken as quickly as possible of the drinking water guidelines, are you asking that they hasten the timeline in an attempt to ideally review it earlier, given the changes at World Health Organisation level and a lot of other research coming in? Is that what New South Wales is formally requesting?
We want the review to be done properly, so we want to ensure the integrity of the process, but we want to be done in a timely manner. And I think broadly, that's what the community...
At the end of next year is too
That's
late?
what the community would expect. I'll get advice on the actual timing, but...
And Ms Thurman, I could probably confirm that the discussion occurred at NHMRC, and that was mirrored by other colleagues around the nation, recognising the importance of making sure those updates, though those guidelines reflect and have had the opportunity to consider the evidence, and particularly the IARC evidence that was concluded late in December 2023, was published. My understanding is that the NHMRC process will go to public consultation. Work is being done by the working group to get that public consultation document for public consultation as part of the requirement for its guideline development. I would anticipate that happens later this year, and obviously we will review that guideline, and I think that obviously we have always committed to complying with those guidelines.
I'll come back to that.
And I can give you some update on the Louis, but I'm happy to do that later on this afternoon.
All right, thank you.
Ms Tanya Mahalik.
Okay, thank you, Madam Chair. Minister, would you agree that there's a special bond between breastfeeding mothers and their babies?
Yeah.
Yep. And for those women who can't breastfeed or have difficulty to do so, there's a milk bank in New South Wales where they can access milk. Is that right?
I understand that's
yes.
correct. Yep.
Can trans women who are biological men access the services of the milk bank as well?
I'm not sure. I'd have to take advice. Sorry, Tanya. I'm not sure on that one.
Can trans women...
Dr. Chan?
Can trans women... I also ask, Minister, can trans women who are biological males donate milk to the service?
Dr. Chen, sorry.
So I suppose in terms of the other comment, I can probably just give you some information in relation to who could access it. So, but basically in accessing the milk bank, it's really based on the
What's a yes or no answer?
So it's based on the child. So if the child is eligible,
then
it's about the child, because the reason we use the milk particularly is to avoid
so the women themselves don't request for it?
Look, I'm just saying that
I might perhaps take my questions on notice. That might be better, so I can get a more accurate answer. Okay, Minister, can I just put to you, do you believe that parents have a right to permit and oversee any medical treatment their children receive?
I'm sure they're part of the decision-making process as children.
So I can't hear you. Can you repeat that?
Yeah. Sorry, they're a part. Parents play an important part of the care and well-being of children. I mean, I think
Absolutely.
we all.
I agree with you.
hope we all do.
The quality bill that's currently before Parliament would make it legal for people under the age of 18 to undergo gender-affirming medical treatment without their parents' consent. How is this upholding parental rights?
Well, the equality bill, as I think you would know, Ms Mahalik, is one that's been brought by Alex Greenwich, the local MP. The Attorney General, as you know, has carriage of that.
Well, can I just put to you, Minister, I did, it's interesting you say that, because last week I did ask the Attorney General some questions, and he actually asked me to ask you those questions. In fact, I'll quote the Attorney General, who said, "When Ryan is sitting in this chair, you can ask him." And this is the exact questioning I asked him. In fact, it's a repeat of the exact same question.
So just in terms of the health aspect, I think the bill proposes to insert a new section into the Act to allow a young person 16 or 17 to make a decision about their own medical or
And where are you
dental
up to
treatment.
with that?
In his submission to the inquiry, Mr Greenwich indicated that he intends to withdraw this provision, which legislates gillic competence and regulates gender-affirming care due to potential unintended consequence. I understand Mr Greenwich made this decision after receiving advice from New South Wales Health that was communicated through my office.
Did that advice get given to the Attorney General? Because he didn't seem to be able to provide me with that advice last week.
I'm not sure, but I just wanted to make sure you were aware of it, because I know this is an issue.
Will young people nevertheless still be able to have access to puberty blockers with parental consent?
Well, this is an issue in terms of puberty blockers that is always done through a very careful and evidence-based approach. By no means do clinicians, and I don't want to give any indication that somehow a child walks into an interaction with a New South Wales health doctor, nurse, allied healthcare professional, and within the space of that consult they're just handed over puberty blockers. That doesn't take place. So I just want to be clear about it. We use an evidence base.
What evidence is it? Where do you get your evidence from? Is that the Sachs Institute?
Clinical evidence. Sachs Institute's recently done a report.
Right. And just on that report, Minister, they've issued that report on Friday. Have you had a chance to have a look at the recommendations from that report?
I've had a chance to have a look at it. I also, from my own benefit, reached out to the Sachs Institute and had a briefing.
Did you? When was that,
From
Minister?
the Sachs Institute, as well as health officials.
When was that, Minister?
Probably a couple of weeks back.
Okay, so they released their report on Friday.
Yeah.
I noted when I looked at their report, it's actually dated February 24, so it was finalised in February. Do you know how long it's been sitting with health? Was that 7 months delay for it to be publicly released? Are you aware of that?
I'm not 100% sure. That's not my understanding. There might be.
Can I also note, Minister?
Typographical error, but
no, it's not typographical. It's February. It also says in there that it's difficult to draw definite conclusions or definitive conclusions about interventions for gender dysphoria in children and young people from available research. So their first statement is essentially that you can't draw any conclusions.
Yeah, just very quickly, one of the challenges in this area that the Sachs report outlines it. There's been a big increase in the research in this area. But the quality, and I'm using that not in a disrespectful term, but the quality of that, i.e. empirical, doing blind cases, etc., a range of different in-depth research techniques, has not been a part of that increase. So it's a challenging area of healthcare, and we're not...
Do we still pay more than $5 million a year to the Sachs Institute?
Oh, I'm not.
Could you take that on notice, how much money we provide to the Sachs Institute?
Yeah, happy to. Tanya.
Your position.
Thank you, Chair. Minister, how many elective surgeries were cancelled today?
I got an earlier report from Joe Edwards that it would have been several hundred, I would have thought. So we can give you that more updated figure maybe later on the day, but I can't guarantee that because the strike action's not over. So I just
They would have been cancelled. We're not waiting for them to be cancelled.
No,
They would have been already cancelled, so several hundred.
Yeah, but I might not have all of the data coming in, so I don't want to give this committee misleading figures. But there has been substantial cancellation and rescheduling of elective surgery today, without a doubt.
In the several hundred, as we understand it, at this point in time.
I would say so.
Sure.
but-
Yep. Okay. And what contingency plans were in hospitals today to deal with lack of staff?
Yeah, good question, and very challenging when, Ms Ward, it is the largest part of your workforce, so it is substantial. We went through, and I spoke with a number of CEs about what they were doing, as has the Secretary and Joe Edwards. Many of them were going through the hospital and the various parts of the hospital and gauging how many people would be taking industrial action, who would be remaining in place, and of those remaining in place, can the service continue to be delivered in a safe, effective and efficient way. Now that's first and foremost what we try and do. That hasn't been easy. There is different numbers across the state, so there might be more significant action taking place, for instance, in a hospital like Wollongong, for instance, compared to perhaps other services. But they would have done that methodically, and Joe, have I covered that off?
Do you have something to add to that?
Yep.
I know that you may have to race out later
I've
to
already
deal with the
been
crisis today.
out.
You've been out, you come back, thank you.
Look, all of the districts and networks have good plans in place to manage the issues in relation to staffing today. There are a couple of local health districts that are certainly challenged, and they're still currently working through those challenges to ensure they've got adequate cover for the afternoon and night staff.
All right, we might ask you about that this afternoon if you
Sure.
come back on the specifics of what those challenges are.
Thank you. Good afternoon, Minister.
And good afternoon, Damien.
Minister, you're the Minister for the Illawarra, and I heard you earlier speak about Shellharbour Hospital. Are you aware which company is the major contractor on that hospital?
No, sorry.
Okay, well, if I told you it was a company called Besic Watpac...
yes, Watpac, I can remember now a media release that we did. It was Watpac, because I was trying to get the pronunciation right.
No, that's fine. Now, you probably wouldn't be aware of the fact that they have entered into an enterprise bargaining agreement on the 16th of July with the CFMEU.
Right.
Are you aware of that?
No, sorry, I'm not.
And you wouldn't be aware, of course, that of the terms of that enterprise bargaining agreement. However, if I could say this to you, that the enterprise bargaining agreement mandates that unskilled labourers be paid $204,000 a year, 250% above the award rate. What do you say to the nurses and midwives who are demonstrating in Cogra today about the government's refusal to offer a single cent above 10.5% over 3 years?
Well, Mr Tudorhope, what I say is we're offering a hell of a lot more than what your government did.
Well, that's not an answer to my question.
Well, let's be very clear. You said during the Premier's budget estimates...
Quite frankly, you're wrong on that, by the way.
Well, no, I'm not. You said during the budget estimates that a zero wage increase, that frontline healthcare workers... Frontline healthcare workers... that frontline healthcare workers received during COVID was, quote unquote, a very good decision.
There's been a point of order.
Don't ask about your
Point of
donors.
order, Chair. As a matter of respect, the Minister was asked a question.
Well,
He should be entitled to answer the question
He was not
without
answering the question.
people disrespectfully interjecting with comments and snipes.
The Minister's entitled to answer the question as he sees fit. I'll go back to...
I think, to be fair, I was answering a very, very good... I was answering a very, very wide ranging question. The fact is that I understand and am aware that the nurses and midwives are not happy with the current deal. That's why we remained at the table. That's why they asked for a meeting with the Treasurer this week. That's why we're having that going forward. But I've also got to make sure, as you have no doubt, Mr Tudorhope, in the past, I'm a part of a government that's got to make sure that we can deliver services effectively and efficiently, and 15% in 1 year is not something that the government can afford.
Have you ever offered anything above 3.5%?
That doesn't mean that we were not at the table. What's interesting is that wage suppression under your government, of which you were a senior member for 10 years, I don't think you would have to be doing any more than about year 2 maths to understand
we gave real
that,
wage increases to workers.
To understand that very, very quickly.
We offered real wage increases.
That wage suppression causes gaps
real
to
wage
occur
increases
right across the workforce. Now, in terms of the CFMEU, I'm happy to look into the individual matter, but if it's a matter of ensuring staff get the same pay for the same job, then that's a provision the union movement broadly has fought for. I don't know if that is the provision. I don't know that, but I'm happy to have a look at the issue that you've raised. But I want to be clear. It seems a little bit ironic talking about frontline workers' pay from a government that has had over a decade of wage suppression, which has caused some of the disparities.
Looking after union mates is part of your DNA, but that's fine. So what you've in fact done in relation to this contract is ensure that the CFMEU gets looked after. However, you won't look after the Nurses and Midwives Association.
Well, let's talk about the Nurses and Midwives Association and their request from government to government and opposition in the lead up to last election. For over a decade, close to 2 decades, that organisation has requested we move to a ratio-based system across our hospitals and healthcare services. We are the first to commit to that. That was their big ask. We are the first government in New South Wales to commit to that. That is around about $1 billion investment, and that rollout has started. Now, what is also very interesting in relation to looking after the nurses and midwives, we actually made sure that the 1,112 that your government was terminating on 1 July 2024 was remained in place. Now that is, I just want people to understand this, that is 1,112 nurses that are now employed because a Labor government under this Premier and Treasurer made a decision to invest hundreds of millions of dollars to make them permanent. That's what we're doing.
My time is limited. What I would like to put to you is this. This is an EBA which was entered into immediately after the news broke in relation to the corruption which existed in Victoria and the Building Bad program was aired. Do you find it concerning that, in fact, in respect of a New South Wales government project, the CFMEU has now been given access to sites, has control over subcontractors as part of that EBA, in circumstances where there is demonstrably criminal activity being taken by that union? And will you, in fact, review that EBA and that contract with that building company?
Well, as I understand it, the New South Wales government is not part of that EBA, but as you know, a range of steps, and I think, to be fair, Mr. Tudhope, you would acknowledge the Premier's strident reform in relation to
but it's words,
the way,
Minister.
well,
It's
the way
words.
in which we acted very, very swiftly in relation to the CFMEU.
Here's some practical things you can do, Minister.
As I said to you, I'm happy to look into. I don't know what you're referring to, so I don't have it privy in front of me, so I'm not going to make a decision about it until I've had a look at it. I'm certainly not going to do that. I don't think you would. I do have the Chief Executive, Emma Schoolander, here from Health Infrastructure. I am happy to ask her to add anything if she sees fit. Would you like that?
No, I'm sure we can ask questions of... I've got just limited time, I'm sure.
Chair, could I just say, it is a little bit... like I take virtually everything, and sometimes when I want to just provide the committee with clarity about an answer, it feels as if I've been given no opportunity to get clarity from my officials, given that I'm the one who's taking, I'd say 9 out of 10 of the questions here.
We're all here for a limited time in the morning, Minister. We have you for that period of time.
It's a tough gig being Minister.
This was an EBA entered into after the program was aired, outlining significant criminal activity by the union. Doesn't it just show that under your government, crime pays?
That's a ridiculous.
You can answer that
question.
now if you like.
It's a dumb question.
Well, Minister,
it's stupid.
Well, then, in those circumstances, would you take steps to do something about it? Because this is a building site which is still now answerable to the CFMEU.
Okay, so let's be clear, Chair. I'm told that I've already made it clear that I'm happy to have a look at the individual issue. Obviously, I'm not aware of the ins and outs of every contract across New South Wales Health Services, nor probably should I be. But anyway, I've offered the Chief Executive to update from Health Infrastructure, who's here today. You don't want an answer. That's a matter for you. I'm not going to make those allegations about other people in this. Well, I'm not going to make those allegations about individuals in this committee, and I appreciate it if others don't make those individual allegations
Chair, I'm
about
sorry to
myself.
call that to the
The federal government is
Order.
responsible
Sorry,
for
the
receiving
witness,
those
the witness has
EBAs.
spoken through me, and thank
Sorry,
you.
sorry.
There's been a lot of talking over each other from all sides in that last round, and I would ask for the interjections and the talking over each other to stop. The Minister is entitled to pass to someone else to answer a question. If you want to save that for the afternoon, you're entitled to ask a different question, but I don't think it's fair in terms of procedural fairness to repeat a question that the Minister's asked an official to answer.
Chair, thank you. In the limited time I have left that's now been left over, Minister, will you reverse your decision to close Bateman's Bay Emergency Department?
No, because I'll explain to you this fairly simple proposition. It's unusual for you to ask this question, but I accept that the Shadow Minister is only new in the role.
Well,
So
Minister,
I
I'm
will
going to
be
move
more
on. That is
respectful.
disrespectful
So
to another member of
your
this
government
Parliament.
drafted,
It's a no.
developed
You
the
will
clinical
say no.
services plan. Your
Minister,
government
the
did that,
feedback
and we agree.
Chair, I'm
We
seeking to
agree
ask-
with that plan. We agree with your plan to deliver the level 4 hospital. That's what we committed at Eurobodalla. That means that
The
in
feedback
relation to
thank
Bateman's
you.
Bay, Miss Ward, you would understand that to have a emergency department 20 odd minutes down the road from another emergency department would mean that you wouldn't be committing to
Well,
a
let's
level
get to
4
that.
hospital at Eurobodalla. Now
All
that's a
right,
matter
let's
for
get
you.
back-
If
No,
you
let's
don't
get to your
commit that-
commitment and your government and
if you
your
don't- if you
responsibility
don't
to this
commit to
community.
that,
Let's get
that's
back to
fine.
this, because the feedback I have is there was limited consultation. Are you satisfied for the limited consultation, noting that the prospect that not all patient presentations needing emergency care will survive the extra time required to travel to the new Eurobodalla Hospital when it opens?
Okay.
Or is this a we wish you the best of luck situation?
Absolutely not. I'm very confident that the work that I'll say Minister Hazzard did, but it might have been Minister Hazzard and Minister Taylor did with New South Wales Health at the time.
Minister, I'm asking you.
I'm confident the work that I'm talking to you about is the clinical services plan. That was a plan developed by you, by your government. We believe that that is a robust plan, and we believe that the way in which we've committed to deliver a level 4 hospital in the Eurobodalla means that you can't have, literally, emergency departments that close. Otherwise, I think you could see what would happen. You split your resources, you split your staff, you run risks of staff shortages. So we will continue to look at the provision of urgent care services, which is happening there, all of those things. But I want to be clear to the community that a level 4 hospital emergency department, the scale and size that's going to be in the Eurobodalla means that we need to make sure that we're following the advice that your government followed through with.
Well, what do you say to the 18,000 petition signatures that are so incensed at the possible closure of this vital service? What do you do? What do you intend to do to rectify this situation?
Well, I always respect that communities have a right to have a say, and I always respect the fact that individuals take the time to express those views through a petition or through correspondence. We're making important investments in Bateman's Bay, including, I'm sure you're aware, a $20 million community health facility that the local member, Dr. Holland, my parliamentary secretary, has been a very strident advocate for.
I'm going to move on.
And I say that the government is delivering on not only that commitment, but the commitment that has been sought for many, many years, which was, as you know, Ms. Ward, a level 4 hospital. Now, I was proud to turn that first sight,
in
and
the
I look
4
forward
minutes
to it
that we have
opening.
left, Minister, because you're taking a long time to get to the point of the actual question, can I move on? Liza Butler, your candidate and our member there, said a Minns Labor government will bring babies back to Milton Hospital while restoring birth services. When will babies be born at Milton Hospital?
Well, we're looking at, through the Illawarra Shoalhaven Local Health District, I've had a number of meetings and discussions with the CE
When?
And clinicians. Well, just let me sort of get to that in a moment. We're looking at a
Minister,
range
we
of
have 4
different
minutes
options
left.
around maternity services and birthing services. I understand that it's a priority. I'm not going to give you a date, but we are developing the health services plan
But your
around
local member
that.
was clear.
Community consultation will be taking place in September. I understand this is an important issue,
It's
and I
important
will
to your
continue.
candidate.
And I'm happy to update the committee, but I don't think at this stage I have a date around that particular issue. But I understand from
So will you have an answer
Liza,
today?
we've just opened a new MG.
You don't have an answer
midwifery
today.
group
We'll move on.
practice in the Shoalhaven.
Minister, can I take you to Camden Hospital? And your government's land audit has identified a site on Menangle Road opposite the hospital. Are you aware of what that site is currently used for?
No, did you say Camden Hospital? Sorry, I missed
Camden,
you.
yeah, it's being
sorry.
used for parking. So, as a result of the housing development on this site, what alternative arrangements are in place for staff and visitor parking at Camden Hospital?
I'm happy to take that specific one on notice. I can't recall. I may have received some correspondence via the HSU or the local member on that. I'm not 100% sure, but I'll stand corrected and try and provide the committee with advice during the course of today if I can.
Thank you, that'd
but
be
certainly
appreciated.
on
And can you also advise whether alternative arrangements, especially for the safety of staff on night shifts walking to their cars, will be in place before that parking closes? Minister, can I ask you another question in relation to iron infusions? Are you able to commit to ensuring accessible iron infusions for all those with eating disorders?
Well, it's critical.
It is critical,
it's
and
not,
they're
iron
very
infusions are
expensive
not
and hard
just
to get.
important for those with eating disorders. They're
Mhm.
also important for those with diseases and illnesses like Crohn's disease. I know a close friend whose son has those iron infusions regularly to
So-
maintain a chronic condition. So yes,
So commitments, Minister?
I will certainly give the committee an assurance that we will continue to make sure that people
Thank you.
struggling with an eating disorder
Thank
and
you,
trying to
Minister.
manage that eating disorder are given access to healthcare.
Thank you. Minister, just moving on to dialysis. On the 30th of July, a letter was sent from 45 nephrologists in 3 local area health districts, Western Sydney, South Western Sydney and Nepean Blue Mountains,
Yes.
stating they were having to ration life-sustaining dialysis due to a lack of capacity and were in essence providing a service akin to a third world country. Was this letter the first time you were made aware of these concerns and the fact that services were being rationed?
Yeah, good question, Miss Ward, and I can assure you I was very concerned when I received that letter. It wasn't something that the Secretary and I had been made acutely aware of.
So just to clarify, that was the first time?
Yes, that's certainly when I had, from my knowledge, been made aware of the severity of it and the number of people in terms of the number of clinicians putting forward their concerns.
So had you heard about it before that though, or that was the first time?
Look, I'd heard that we have challenges about dialysis in Western South Western Sydney.
Yep.
Yes, because we have, not that anyone should be proud of it, we have above, certainly well above average numbers of people with a range of different kidney issues and health conditions in that area that require it. So
Thank you. Just in the 28 seconds I have left, so has your department made you aware or provided any other advice on other health services being rationed in New South Wales or other strategic reduction of services?
No, not in relation to that.
So just dialysis, no other areas?
Well, that's the one that I've been dealing with. I actually spoke to a clinician recently, one of the clinicians who wrote to me. I rang the clinician. They were in quote unquote, I don't want to say, they were quote unquote happy with the steps that Miss Wilcox as the Deputy Secretary had made around that. So
Because a member for Liverpool spoke about this in Parliament on the 18th of June.
Yeah, and it's important that we understand
So
there
this
that
can't have been the
is-
first time in July that you heard about it.
It's a demand issue in that particular areas. We're not trying to be difficult.
And you only
but-
responded to those
Sorry, Ms. Ward,
nephrologists on the
the time's
30th of
expired.
August
I
after
was-
the Sydney Morning Herald story.
I indulged a couple of follow-ups. I'm not going to give you a third.
I've had multiple.
Takes 4 minutes to answer each question.
Minister, there are serious community concerns in Bellingen about the closure of the Hartley House ward at Bellinger River District Hospital. I understand that the new lift installation that caused the closure of the ward is due to be complete imminently, but there's been no indication from Mid-North Coast LHD of when those beds are going to be reopened. Can you provide some certainty to that community about when they can expect their hospital to be back to full capacity?
Let me take that specific one on notice, if I can. If I can get an accurate answer to you today, I will, just so that you don't have to wait a period of time, because I know it's an interest to the committee and it's an interest obviously to that community, so I'll try and get that answer as quickly as possible.
Thank you. I appreciate that. And while we're talking about Bellingen, locals also have concerns that there might be plans through that local health district to turn what is currently a 24-hour emergency department into an urgent care centre that only runs 10 hours a day. Can you confirm if that is or isn't the case?
I'm not aware of it. I'm happy to have a look at it. The only thing I'll say is that we need to make sure that we're providing services in a safe way, an effective way and an efficient way that meets community needs, but also meets the expectation of taxpayers' money. It's not government's money, it's taxpayers. But we don't have any plans, from my understanding, to reduce the ED in that area. But let me, because I want to be complete in my answers to the committee, let me make sure that that is absolutely the case.
Thank you. I understand that previously you've spoken to the Public Health Association of Australia about a potential trial limiting advertising on publicly owned assets, for example, public transport.
Yeah, they asked me about
harmful
this.
products like junk food. Is that something that you're still working on?
I won't give this more credit from my perspective than it deserves. So it's certainly not a proposal that government is considering, but you would know that my background is in health education and health and physical education, so I understand the importance of it. I just say this, and this is something that when you look at this issue we probably haven't dealt with. Respectfully, my 14-year-old son wouldn't get his information off the back of a bus that he goes to. It's whether we like it or not, through these devices. So the ability to try and say you're going to do one and not the other, I think is a problem. So I certainly haven't pursued that, because I've got concerns with the way in which you would roll that out naturally, and I've got concerns that whether or not it would be effective or not, because I've had a bit of a think about this issue and I'm just not sure that it is effective to do it in the way that is presented, given the way in which particularly young people who we're targeting consume information at the moment. That's all.
Thank you. I promised last estimates that I was going to keep asking about Albury Hospital until we have a single site regional hospital in my community. I've got 7 years to go on my parliamentary term.
I can tell you a community you've honoured that commitment.
Earlier this morning, you stated that extra money had to be found in the budget for the Shell Harbour Hospital to be delivered as it was originally committed.
Yes.
Now, the original commitment by the previous government for Albury-Wodonga was for a single site hospital. Are you similarly committed to ensure that our hospital is delivered as it was committed?
I'm determined to make sure that that $500 million investment between our government and the Victorian government is delivered, to make sure that they've got access to the best possible health services. I think it's a $225 million commitment roughly from each of our governments. It is one of the largest investments in rural and regional healthcare, and I know that you don't agree with where we're building it. I respect that, but we are proceeding with that plan. I'm excited by what it will mean. Do I think that new buildings and new facilities solve every problem in regional and rural areas? No, I don't. That's why I've had a real focus on staffing, working with my Deputy Secretary Luke Sloan around that. So,
Can I keep you on Albury Hospital, please? So
Yes,
this is
you
not
can.
just about where the hospital is, right? I have serious concerns, and not only has this project been cut and cut again, but the point of care projections themselves, the calculations about what our hospital needs are in our community, have been cut multiple times. So the 2021 clinical services plan that representatives of New South Wales Health were a part of had certain bed numbers. Then in 2022, the clinical services plan was repeated to the exclusion of clinicians. We've then got a 2023 master plan and now a 2024 concept design report. And each time, not only is there a lower number of beds being delivered in this project, but the number of beds in terms of calculations of what we need have changed. And that doesn't fit with projected growing population in Albury-Wodonga. So why do you keep revising down your estimates of what we actually need?
Okay, so I think it's important to note a couple of things. Firstly, in relation to bed numbers, these are broad figures, okay, so just take those as what you see. At this stage, there'll be around 380 across both hospital sites at Albury and Wodonga, which is around 135 new beds. This is over a 50% increase from the 2019 bed base at 245. So to be fair on the last government, this was a significant increase that they were looking at. You also have to realise that not everything we do now, and I know you do know this, so I'm probably more talking to the committee, not everything we do now is via hospital beds and inpatient. We do a range of different services, including HIF, hospital in the home, including geriatric outreach, including outpatient clinics that don't necessarily require someone to have a bed in a hospital. Now, we are going to continue to grow those areas for a range of different reasons. A, because they take pressure off our hospitals, but B, because it's far more pleasant for people, if they can, to be treated within their home. So what I am saying is, yes, there will be more beds, but there'll also be different modalities of healthcare delivered as we progress virtual healthcare, etc.
So on these bed numbers, Minister, so the new beds being constructed at Albury, they not only have to make up for the current deficit, so we've got more than 20 patients sitting in parts of the hospital that aren't wards, but they also have to make up for the closure of beds in Victoria. So for example, maternity services and the special care nursery being across to Albury actually subtracts from that. So when I've looked at the numbers, it looks like there's a 39 real increase in beds once you take away the services coming across from Wodonga and replacing the makeshift current beds that are not on wards. Now, the Victorian Department projections, this is from their July Wodonga Hospital Entity Services Plan, their projections are that you need 43 new beds by 2026, and you're delivering 39. So this expenditure, and you keep referring to it as one of the biggest investments in regional New South Wales, the Shell Harbour Hospital, which is in your region, and you're obviously representing your own constituents well, that hospital is getting an investment of $782 million, including 128 from the feds. So continuing to refer to the 225 you're giving to Albury as historical, one of the biggest, is frankly it's misleading. It's disappointing to hear that repeated for our community. Why are you spending that significant amount of money delivering essentially 39 net increase in beds? And I can go on. The special care nursery is currently 18 beds. It's projected to be 14. We're losing 4 beds in our special care nursery. We're getting no increase in the size of the ICU. Maternity's staying the same size. We're getting a shell of a kids ward that's not being fitted out. The helipad's been removed. It's not clear whether there's any car parking. At what point do you actually go back to the drawing board and calculate if it would actually be cheaper to just build a fresh hospital than to continue going down this path with this really, really challenging redevelopment on a site that's just, with all the work that's been done since 2021, it's clearly not working?
Okay, well, a couple of things. I'm happy to have a look at the numbers from those things. That's the first thing. I'm happy to do that. But to give credit to the last government here, and Minister Hazzard and Minister Taylor, I don't think a $500-odd million investment is something to laugh at in a community. That is substantial, right? So, sorry if you don't agree with my terminology as one of the largest, but it is for us. That's the truth. You mentioned Shell Harbour, and that's fine. Secondly is the challenge, what I don't think you and I will agree on, is the fact that there has been substantive upgrades to that hospital, right, that have been made on that site. So to go to a new site, you would essentially be decanting and removing that, even though that they are fairly modern facilities. So you've got, as you know, the investments that were made around the Regional Cancer Centre,
Yeah, absolutely understood, Minister. Sorry, I've got 16 seconds to get this last question in.
It's just
How many
substantial.
hundreds of $1 millions is it worth to keep using a building like the Cancer Centre or the current ED? What I'm asking is, has the maths been done of how much it would actually cost to give us what we need on a new site?
Well, the work was done through the clinical services plan under the last government, and
Which
I don't
recommended
take
a
credit for
greenfield.
people's work, but that is a substantial amount of work and investment. I respect that you don't agree with me that it should be done on the brownfield site and it should be on a new site, but I'm just saying the investments that have been made in that current site means it makes sense to expand there. Otherwise, you're essentially decanting and removing facilities and services that you've only in recent times established.
I'm out of time. I'm going to my colleague Kate Fairman.
Thank you. Minister, how do you, have you heard how the early drug diversion initiative is going that you
Yes.
announced in October last year?
I do. I've probably got some updated numbers around that because I was actually talking to someone recently. I know it is in largely the attorney's area, but I did remember getting some updates around this. Yeah, between March 2024 and 30 June 2024, Ms. Fairman, there were 331 SINs, criminal infringement notices, issued under the scheme. Of this, 21 were issued to people who were Aboriginal, so 6%. 41 people issued with the SIN elected to complete the health intervention. There was 41 people engaged in that process. I just want to make sure.
Yes, thank you. 41 people engaged in that process. When you announced this is obviously the response from the ICE inquiry. The $500 million of funding was going towards treatment programs in the criminal justice system. This was all, based on the ability for the health system in some ways to cope with diverting people from the criminal justice system instead of sending them there.
Yep.
And you said at the time it will potentially stop around 6,000 people from going into the court system for very low possession. So just 41 people, did you say?
Did they elect?
I've got the roughly 6 months, because my office asked for data on this as well, that 46 people completed the intervention in that first 3 months.
46, yeah.
So
Sorry.
there's roughly the figures in terms of who was directed into the court system, and these are people who are caught with low personal quantity of drugs.
Low amounts. Yep.
Vast majority, thousands, around more than 5,000 people were still directed into the court system. One of the very concerning things is how many were directed into the court system still for ICE. So I know that, is this a joint effort between health and police? Firstly, my question is, are you an equal partner in how this is implemented and rolled out? Because it seems as though the police minister maybe, but definitely the police, haven't got the memo that you guys, the health department and the health services, are ready and waiting for people to be diverted to them.
Yeah, I think, to be fair, yes, I feel like I'm an equal partner. It's something that
feel like, or you are,
yeah,
Minister?
I am.
Okay.
I'm an equal partner, and it's something that the attorney, myself, and the police minister, have got an interest in discuss. I think, Kate, to be fair, it's only very early days too, so all of these things have a start-up period. People have to elect to want to do it. Some people turn around and say, I don't want to do it, so to speak. Like it's I'll take the fine or the other consequence. It's not a situation where I don't feel like an equal partner. I do.
So just to be clear, what this is, So if somebody's caught,
Yes.
like a lot of people, right? A lot of people that were caught with
Yes.
with
They can
ice,
take-
with cocaine,
Yep.
with MDMA.
Correct.
The choice, or up to the police
The pathway. Up to the police discretion.
right? Pay a $400 fine, or go to make a phone call.
Intervention. Yep.
Yes. You think that 95% roughly of the thousands of people that have been caught since the beginning of this year actually chose to go to went to court? No, what I'm saying is it's the police that didn't use their discretion.
I'm
So
saying
because-
I don't know that as
No.
the health minister because
It
I'm not at the
clearly,
point of getting
Minister,
that. Yeah.
clearly, it's the police that didn't use their discretion. It's not like people go, no, can you send me to the court, please? Clearly. So what conversations will you have
Miss
with the
Vernon,
minister
could I-
to ensure, firstly, that this program actually works and is effective? Sorry, Dr. Chan, I'll come to you. Because you've got the drug summit coming up. This is a key, like looking at this will be a key part of that, I would hope.
Yes.
So if you're not getting anybody referred in, the police aren't doing it.
Yeah. Well, we'll
So
continue.
we're going to come to the drug summit. Literally, there'll be like probably 100 people that you'll be able to, look at that's been referred, and thousands that haven't.
I'll throw to Dr. Chant in a moment.
Thanks very.
Yeah. Sorry. We are continually in discussions around this, and we are, and I feel a complete partner in this, but it is very, very early days. But Dr. Chant?
So probably just to clarify a couple of elements of the operation of the scheme. So firstly, the police do the criminal infringement notices. So that in itself is a diversion. It doesn't require court attendance. So the issuing of the criminal infringement diverts those individuals. In terms of the 41 or the 46, I'll just have to check the data, but the group that then takes up the intervention, Health had always expected that not all people that are caught with possession will actually be at that time where they're wanting to engage with a health intervention. We are reminding them when they get the Service New South Wales fine, and they also get a reminder that there is that ability to divert. But we are working with police so that there's also some more handout of materials when the original court infringement notice, the sin is issued, that we can then give them something a little bit more tangible to remind them at that time their options. But we were never expecting, Ms. Furman, that everyone would actually choose to take up the intervention, given people's readiness to recognise where they are in that phase of their of drug use. But I would assure members of the community that's a very professional service. It's run by qualified and trained personnel, and so for those people that want to avoid the fine, we would really encourage them to engage in care. But in itself, the issuing of those sins is a first step in diversion, because those people are not caught up in the criminal justice system.
Yeah, so you're saying in terms of the issuing of the criminal infringement notice, that's the $400.
Yes,
when
that's
you're saying
right.
the issue of
yes.
the,
So instead of going to court,
yes.
they get that. So that in itself is a diversion component, and then the second component is they can avoid that fine.
There's two parts, I think,
if they actually avoid paying the $400 if they actually
but
do the
issue,
intervention.
Thank you, Dr. Chant. Yes, I'm aware of that. The issue, though, is that people have been charged. It's the number of people that have actually been charged instead of being given the option of even the $400 fine that I'm referring to. And the number of people, for example, that have been charged, this is since 25th of May 2024, with a low-level drug possession, instead of being diverted, right, into that scheme. The numbers I have, 3,158. This compares to the 160, I think it is, and the 41 people. In fact, no, this is half of that, because I asked in two lots.
Yeah.
So you've got, for example, I just want to, you've got, let's look at meth, ice. This is in direct response to the ICE inquiry. 1,227 people still went to court. Like so what I'm just pleading with you, I think, Minister, is we don't have long until there's the regional hearings and then the December hearing. And things have to change if the police aren't holding up their end of the bargain, which it doesn't look like they are, then all of this money, I'm sure there are good things that are happening, but it's almost 5% almost. I think it's 7% of people in the end, out of everybody, the thousands that have been caught, have been given the option of paying $400, and far less have actually been diverted into treatment.
I know what you're saying, and respectfully, I won't comment on the police because it's not my department, and I'm not. I don't know the interactions they have with individuals at the time, so I'm not privy to that. What I'm saying is, we think this is an important scheme. We think this is we think that this is a scheme that can have benefits and take people down a healthcare path. We think that's important.
Thanks, Minister. I've got 20 seconds. I just want to ask you one more question about this. Minister Catley did say that she's been working with you on this.
Yes.
Will you commit to raising these statistics with her and encourage or request that she ensures that the police are aware of their options in relation to this scheme, and they can send more people to treatment instead of through the criminal justice system?
Yeah, I'm always happy to talk to my ministerial colleagues. I think none of them would say that I don't raise issues that impacts on their portfolio. I do regularly. My only thing around this issue is that it is a fairly new scheme. Now I'm not trying to pass the question, I'm just saying that's a reality for us.
Thank you.
The opposition?
Minister, does the Health Department self-insure for medical negligence risks?
The Health Department?
Well, your department, how do you manage medical
individual
negligence
clinicians
risks?
have their own medical negligence.
And negligence actions taken against hospitals or Department of Health facilities?
Yeah, I'm assuming that there are claims made when something goes wrong.
And you self-insure, or you have an insurance coverage for that?
Alpha or Phil, do we self?
Our staff specialists cover under the TMF policy, which is the government.
No. If it's a hospital claim or a claim against a hospital clinic, self-insurance or a health policy, insurance
through
policy?
TMF.
There'll be that's right, TMF. Will be all self-insured through the iCare scheme.
Okay, so any negligence claims bounce back to iCare and the TMF?
Yes.
So
It
what
depend
discussions?
on the nature of them, Mrs. Carter. I don't know.
Because if it's Ms. Carter, just so I'm clear, if it's something to do with Clinician Park, then that would be often something that
if it's
that
something
practitioner
to do with,
has. That
can I give you an example?
Okay.
If a child is at Maple Leaf House and is receiving puberty blockers, and then there is a negligence action brought, with the example of Tavistock in the UK, there would presumably be an action potentially against a clinician, but also against that Department of Health facility. Who pays and what allowance is being made in the budget for likely negligence claims?
Well, I'm not aware of that.
Well, the NHS is looking at potentially £1 billion of negligence claims. What are we doing in New South Wales?
I'll throw to Alpha about that.
So the annual report discloses how much we pay for insurance altogether, which is part of our self-insured through the TMF and the iCare. And I think there's a component in that refers to the medical indemnity. In terms of whether they will cover specific cases like that, I need to take that on notice, because also depends.
Could you take that on notice? Because a number of insurers are now refusing to provide that medical insurance claim, and it'd be good to know what our exposure is as a state.
Sure.
Thank you.
Thank you. I'll take the last couple of minutes.
Sure.
Minister,
yes.
coming back to Albury Hospital. So you've
yes.
repeated the same line about making the most of the facilities already on the site for over a year now. So are you aware that the coronary cath lab, it was only built in 2018, there's currently one lab and a shell for a second one. There's a capacity for expansion there. In the new project as you're proposing, that's actually demolished and we'll just have one with no capacity for expansion. Are you aware that you're actually taking us backwards?
I'll need to get some advice. Either from Health Infrastructure.
That's right. I'll speak to Health Infrastructure this afternoon. You also, when I asked about point of care projections being revised down, you talked about virtual care and hospital in the home, which, as a GP, I really support those things. But here's one example of how that argument doesn't stack up. Talking about acute care beds, intensive care beds. So we currently have 12 across Albury and Wodonga. The 2021 Clinical Services Plan recommended that we'd need 20 by 2030 and 22 to 24 by 2035. That was then revised in 2022 when you cut the staff out of the consultation. The recommendation was then for either 14 or 16 beds, depending on whether you're projecting to 2032 or 2037.
Okay.
The proposal is for 12.
Yeah.
So how can you use virtual care or hospital in the home to replace the need for intensive care beds? Please explain that to me.
Okay, well, I'll explain a little bit about clinical services plans. They don't always project what the hospital needs right now. Clinicians have a view, and that's fine. Clinician feedback is important. That's not the only feedback, because you would understand that we're operating, as every minister does, under budgets and within budgets. So that is a part of the assessment. But to say that we are going to give, I think this is broadly, somewhat of a second-rate service to the people of Albury and Wodonga, it is not true. We've planned 380 beds across both those hospitals. That means around about 135 extra beds. And you raised earlier about the surgical and inpatient beds. Well, more than 80 additional surgical and inpatient beds will be delivered. So we're arguing, I know, and I'm being respectful, but we are going to deliver there a great service. It may not be the exact service that you or certain individual clinicians perhaps envisaged, but I'm confident it's a service that the community can be proud of, and I'm confident that we'll continue to work with the Victorian Government to make those investments there.
I'll continue with the department this afternoon. Are there any questions from the government?
At this stage, no.
There are no questions for the government. That being the case, Minister, we're finished with your questioning. Thank you for attending the hearing.
Thanks for having me.
And we'll break for lunch and return at 2 o'clock. Thank you. Welcome back, everyone, and we'll start with questions from the opposition.
Thank you, Chair. Welcome back, everybody. Ms Edwards, some questions to you about the nurses' strike and the surgery cancellations, if I may. The Minister was unable to say exactly how many surgeries have been cancelled today. Have you got the latest numbers?
Thank you. The advice that I've received at 12 midday today indicated there were 518 planned surgeries delayed or cancelled today.
Okay, and you mentioned earlier that a few local health districts were particularly struggling with the industrial action today. Which ones are they, and can you provide further details for the committee?
So, as you can imagine, each of the local health districts are under quite a bit of strain today as they're putting contingencies in place to deal with the shortages. We've been working very closely with them and have set up a system flow centre to ensure we're able to smooth and escalate things as much as possible. At the 12 midday briefing, the challenges were in particular around northern New South Wales and mid-North Coast, and also Illawarra.
Okay, and how have wait times in emergency departments been affected by today's industrial action?
I don't have that information at hand, but I can take that on notice.
All right. Do you think that's something you might be able to get today or shortly?
Is there something in particular you are asking for?
Yeah, how have wait times in emergency departments been affected?
Compared to, for instance, last...
A day when there's not 50,000 nurses striking.
Oh, there aren't 50,000 nurses striking.
Okay, well, compared to any other day, how has today affected those times?
Okay.
I think I can add to Ms Edwards' response, Ms Ward. I think predominantly the emergency departments are flowing quite well today.
Mm-hmm. And what impact will these delays have on elective surgery wait times?
Ms Edwards has made a response to that already, so around 500 postponements from today.
So if there's 500 postponements for today, how long will somebody have to wait now for their hip replacement, for example?
Well, I don't think we can provide a response to that. It would be dependent on the type of procedure, where the patient is.
A rough estimate.
It's not possible to provide an estimate.
So people delayed today, will they get their operations tomorrow?
They'll be attended to as quickly as possible. We've made a huge amount of effort this year, over the last 12 months, to reduce overdue surgeries that arose during the course of the pandemic, and in fact ended at the end of June with a substantial reduction in the amount of people who are waiting longer than they needed to be for their surgery, which is a great achievement from the staff of the New South Wales health system. Consequently, we are not heading into this part of the year with the same number of overdue patients as we had this time last year. And so our, as is always the case when a surgery is postponed, we would seek to have that attended to as quickly as we possibly can.
When's the last time you had industrial action on this scale?
I might get Mr Minns to respond to that.
I suppose really my question, Ms Pearce, I'm happy for Mr Minns to respond, but what I was asking was for you to predict the impact on waiting times from the last time.
I don't think it's not, you're asking me to predict something that's not possible, but I think your question about the scale of the action, Mr Minns does have some information on that to assist the committee. Thanks, Phil.
We've been advised from each LHD that approximately 3,813 staff have either participated or have indicated they will participate in industrial action on the afternoon shift. That compares to 5 industrial incidents in 2022. The numbers there, I can provide them directly, but
and is it only the afternoon shift that's impacted by industrial action, Mr Minns?
No, it's day and afternoon. There will, in some cases...
So what were the day figures?
I only have a number that is both. So those who said I'm taking action on the day shift and I'm taking action on an afternoon shift that we currently understand is 3813.
Thank you very much.
And that compares to 2022 where the highest number was more than 4,000 in one event and the lowest event was in the sort of 2.6, 2.7
Thank you.
level.
Thank you.
Yes. Thank you. Ms Pearce, if I may. When you're ready. Yep. Just confirming, was the 30th of July this year the first time that you were made aware that dialysis services were being rationed in the 3 local area health districts in Western Sydney, South Western Sydney and Nepean Blue Mountains?
I'd have to, 30th of July, did you say?
Mm-hmm.
I'd have to take that on notice. I don't recall that information on the 30th of July. I certainly became aware of it when we received media inquiries in respect of it. I know there was a letter to the Minister. I don't recall seeing that letter, but I would have to take the specifics of the 30th of July on notice and come back to you, and I'll try and do that today if I can.
It's not a trick question, it's just literally, were you aware of, do you think it might have been after that then, if you hadn't seen the letter, understanding you're taking it on notice? Do you think it might have been after the media reports, perhaps? And then
we certainly obviously became aware that there had been a letter to the Minister, and you'll appreciate that we get a lot of correspondence.
Yes.
Look, in the normal course of things, for a number of our staff to raise such complaints, I would like to think that we would know about it, and in most circumstances we do. But what I can say, and Ms Wilcox and Ms Edwards can add to this, is that we have met with some of the doctors concerned with respect to that. We've obviously spoken to all chief executives concerned in regard to those issues in the 3 districts, so that we can get an understanding of what the issues are and what we need to do to remedy them. And there have been a number of actions taken in respect of those concerns that were raised.
And what are those? You had anticipated my next question, helpfully. Thank you. What are those next
I'll hand
actions?
over, if you don't mind, to Jo and to Deb.
Thank you, Ms Edwards. Or Ms Wilson.
Thanks, Ms Ward. Yes, the local health districts are looking at a range of initiatives to increase their capacity. 2 examples of that would be they're accessing chairs from some of the close by private hospitals, so that we can purchase that activity from those neighbouring hospitals to support our capacity, and some of them are adding additional shifts to their current rostering so that we can allow more patients to come through and have their dialysis. We've been very focused on those individuals who are on reduced treatment plans, which were part of the doctor's concern. Ms Edwards and myself and another colleague, Mr Patelli, met with those clinicians on the Tuesday, the 3rd of September, and had a great and very collegiate discussion with them, and they put forward some constructive ideas and issues for which they see would be practical to support their patients. We have a follow-up meeting with them scheduled in a couple of weeks, and in the interim we're working with those local health districts. There's in terms of planning for statewide services, for renal dialysis services, local health districts essentially plan for their own communities and network across other LHDs where those boundaries are. And they, from time to time come to us and would put forward proposals for increasing their capacity, which we work with them, whether that be capital planning or with their service agreements.
All right, I might move on. We'll come back to that if there's more time. Thank you. Mr Minns, if I may. Hello. Mr Minns, on Monday the 5th of August, Chris Minns made a captain's call regarding working from home. Mr Minns, you sent a memo to staff appearing to contradict the Premier's edict about that. Can you please clarify for the committee the actual situation regarding work from home arrangements at New South Wales Health?
So the circular that was issued was from the Premier's Department. That followed a discussion at the Secretary's Board where we were asked to provide some information for our Secretary to attend and discuss that. The circular from the Premier's Department was used quite heavily by me in my message to staff. So the perception that there was some kind of alternative message is a result of the treatment of the Premier's Department circular by the media rather than actually by the announcement.
Sure. So you're able to clarify what the actual policy position is as of today?
So I expect tomorrow the Ministry Executive Team will receive a presentation at its regular meeting about the New South Wales Health response to the Premier's Department circular. Once it's been through the executive, we will then start the consultation process that we're required to by our own policy and also that of central government. So that will mean that we'll issue a proposed revision of the policy for all deputies, to all chief execs, for them to consult with staff. We'll also formally consult with unions.
Sure.
The
But I think
actual
if I can just come back to it, I just have limited time. I apologise. I'm not trying to cut you off, but I did ask about, as at today, the Premier had said that your circular was only referring to existing arrangements, not working from home arrangements that had arisen during COVID. Is that correct?
Sorry, I don't follow that.
All right. The Premier said that your circular was only referring to existing arrangements, not working from home arrangements during COVID.
Health
is that correct?
did not issue a circular.
Okay, so that's not correct.
Well, I just can only say that Health has not issued a circular. There was a Premier's Department circular, and there was media reporting of that was not accurate. So we issued a memo to staff that said this is what the
So a memo, it might not have been a circular, but you issued something to your staff, whether you call it a memo or you call it a circular.
But it's not a
something was
policy
issued.
document. It's just a clarification of the fact that because of what the Premier's Department circular says, we will have to follow, as required, a process of reviewing our own policy.
Yep. So there's a review underway as at tomorrow. What is the position as at today?
It remains as it was.
Which is?
That we have some work from home arrangements that arose in the COVID period and there's currently still in place.
But you see, what I was getting at is that the Premier had said that your memo, your circular, whatever you'd like to call it, was only referring to those existing arrangements, not the working from home during COVID. So can you clarify that so we can understand what that position is today?
I do not understand the point you're trying to clarify. I'm sorry.
All right. Well, it was the Premier's words, not mine. We're trying to clarify it as well. So as at today, the position is what?
So we have a flexible work policy. We've had it for many years.
Yep.
We didn't really change it as a policy document with respect to the COVID period. What happened in COVID was
That's okay. I'm just interested in today. So can you work from home today?
We've still got people who are working hybrid, and it's our understanding that the Premier's Department circular makes that possible under certain circumstances.
Okay. So can I confirm that people who have been choosing to work from home on some days during COVID are now returning to the office?
So we've got people who work typically, and we're only talking here about the ministry and the pillar organisations. The vast bulk of our workforce doesn't have the option to work remotely.
But for those that are choosing to work from home on some days during COVID, they're now returning to the office? Yes, or is that correct?
No, because what I said in my memo that afternoon is we will do a review, as we are required to do by the Premier's Department. That review is almost finished, and then we will consult on it. That's what we'll start to do following tomorrow.
But do you see, Mr Minns, I'm not trying to be argumentative, but if you and I are unclear as at today, what the position is, it might be difficult for hundreds of people out there to understand what the position is, whether it's a circular or a memorandum.
It's not unclear to me.
All right. I don't need your commentary, thank you. I'm asking you, Mr Minns, because questions have been put to us. Chair, I ask that you ask the member to restrain himself, as exciting as this is. All right, I might move on. Ms Squillander and Ms Pearce, if I may. Ms Squillander's here. Sorry, I can't see. Thank you. Ms Squillander, have you been asked to prepare any type of economic impact report to support the government in making an application to the Fair Work Commission to stop the protected industrial action by the ETU?
No, I haven't.
Okay. Ms Pearce, are you aware of any work being done to understand the economic impact of industrial action relating to the CFMEU or ETU on health projects in New South Wales?
Not specifically that I can recall.
Sorry, what do you mean not specifically?
Nothing I can recall on those two.
All right, thank you. Ms Squillander, are you concerned about the EBA with the CFMEU for Shellharbour Hospital?
Noting the question that was also raised this morning in relation to that, Health Infrastructure procures its contractors as head contractors using the New South Wales Government procurement guidelines and using pre-qualified contractors within those guidelines.
I understand how procurement works. I'm just asking if you have concerns on that site with the CFMEU involvement.
Health Infrastructure does not have visibility of the EBA. or knowledge of the EBA in relation to that project or that contract.
All right, so do you have concerns about the CFMEU's involvement in that EBA?
I think the CFMEU media of late, certainly I would be dishonest if I said I wasn't concerned about the reporting in relation to the CFMEU. However, I know there are a number of actions underway by both the federal and the state governments in relation to that, and that will run its course. And in the meantime, health infrastructure is focused on delivering the infrastructure for New South Wales.
Yeah, and given that it is focused and that is your area, I just want to be clear about your evidence to the committee today about whether you're taking steps, whether you're concerned, or whether you're content for the action that's being taken by the federal government to suffice for your purposes at Shell Harbour Hospital.
In relation to taking steps, health isn't in a position to take steps directly to review, for example, that EBA arrangement that you have spoken about. Yes, we have had and ongoing will have discussions with Infrastructure New South Wales and the Construction Compliance Unit in the Premier's Department, who have some responsibilities in relation to some of these arrangements and how they're applied within New South Wales. However, my role in health infrastructure is to make sure that we're compliant with the processes and spending the money in the best way that we can within the parameters of the industry.
Taxpayer money, yep. All right, Ms Pearce, can I ask quickly about Parkinson's? I just have some further questions. I know we raised that quickly this morning. I think my colleague raised that. In relation to the $8.6 million funding package in 2021, does the department have a breakdown on how that money has been spent to date and in which local area health districts?
If Ms Wilcox could assist.
Thanks, Ms Ward. Yes, the $8.6 million funding package was principally for specialist nurses and allied specialist nurses and allied health staff. And that funding is distributed to the relevant local health districts to recruit. I'll have to take which LHDs, local health districts, on notice, Ms Ward, and get that to you before the end of the session.
All right, so if you're able to, that'd be helpful, just the breakdown of it and which ones, that would be helpful. I understand that funding in the northern, Sydney LHD upgraded an existing clinical nurse specialist to a clinical nurse consultant, as well as funded an additional clinical nurse consultant. Will these two full-time roles continue next year?
Thank you, Ms Ward. Yes, I was the Chief Executive of that local health district when we initiated that enhancement. We are looking at Parkinson New South Wales's ongoing submission for their submission for ongoing funding. I can take on notice in relation to what the local health district's plans are ongoing for those positions.
Thank you, that'd be helpful. And so when will that funding officially run out and what plans have been developed for ongoing funding?
The funding package that was delivered completes on the June 30, 2025, and we are undertaking some work internally to look at what might be possible for the next financial year.
All right, what does that mean, what might be possible, given that the Minister this morning said that he would like to see that funding continue? Have you been doing work on the budget submissions for 25-26? Obviously, those nurses and Parkinson's New South Wales need some certainty so that they can plan for that.
There is a budget process, you're quite right. We work obviously with the Chief Financial Officer and the local health districts to put up policy packages to government for their consideration. So our intention would be to have it fall into that piece of work. Local health districts too, though, a number of them also run their own movement disorder and Parkinson's services where they have their own staff, not necessarily those that are recruited via a grant to Parkinson's New South Wales. So there are highly specialised clinicians in clinics in a number of our major hospitals that care for people with movement disorders, including North Shore and Prince of Wales.
Okay, thank you. And forgive my pronunciation if I get this wrong. It's not my area, but has the department done any work into the links between, is it paraquat and Parkinson's?
That weed killer, is that what you're referring to?
Yes, correct.
Outside of my skill set, I could take that on notice. I'm aware of the weed killer, but I'm not aware of its relationship with that disease.
There's obviously some concerns about this, so whether that work's being done would be helpful.
Yeah, okay, happy to do that. Thank you.
I want to ask a couple of questions about specialist international medical graduates. Would that be you, Ms Pearce?
Or perhaps Mr Minns.
Mr Minns.
We can both assist.
So there's a fast-track process for bringing in medical graduates, specialists from overseas. Who will be responsible to supervise them in the public hospitals?
Well, I don't think there'd be any essential change in the model of supervision. The Health Workforce Task Force and the Health Chief Executive Forum are still really sort of finalising all the detail of the arrangements that will apply for fast-tracked international medical specialists. My understanding is that that the whole reform will include a national governance model, but in essence, those people will start practicing in our hospitals if they meet the requirements of the new pathway, and in that respect, they will therefore be reviewed by all of the quality measures we have in place in our facilities involving directors of medical services and clinical governance roles.
Could I also add to that, Mrs. Carter? The international medical specialists that you're talking about are, the view is that they're trained to an equivalent standard in the overseas country from which they're coming. So that's the first point to make. This has been an extensive process, and it's been through APRA, which is obviously concerned not just with the registration and the incoming specialists into the country, but obviously also patient safety. So there's been extensive work with respect to this. You would be aware that particularly during the course of the pandemic, our workforce maldistribution issues were exacerbated as a consequence. And through the Health Workforce Task Force, which in fact I chair, and reporting to health ministers, we had a national agreement around the 4 specialties that were of most concern to the various jurisdictions, and we've reached agreement on a nationwide basis with respect to those, and there are other specialties to come. So it's a nationwide piece of work that's been underway now for some time, and health ministers are naturally keen to see whether we can make some inroads into this, because clearly we want to address some of those workforce maldistribution problems we have. Having said that, I will finish by saying that this is not a silver bullet. It is not intended to supplant locally trained doctors and specialists. In fact, obviously it would always be our preference. But having worked in remote New South Wales for more than a decade myself, workforce maldistribution is a long-standing issue, and one with which we have heavily relied on overseas trained doctors for as long as I've been in the health system, which is a very, very long time.
So just to clarify, there'll be no supervision for these fast-tracked...
No, that's not that's not right.
I hadn't finished.
Yeah.
Other than what is normal for any practising specialist in a hospital?
The supervision requirements would... The standard, I don't believe, is any different. And as I said, we are talking about doctors from comparable jurisdictions, UK
I'm sorry, but your time is expired.
Sorry.
I've been very generous.
No,
I'll go to Tanya Mahaley.
Okay, thank you, Madam Chair. I might just start with Ms Pearson. You may redirect the question. I want to ask some questions about the Sachs Institute. I'm not sure who's... perhaps it's Dr Chant. Just in relation to, earlier the Minister did say that there was a typographical error with the February 24th, but when I go online, it's the report's dated February 2024 on a number of occasions. So is that when the report was finalised?
Ms Wilcox can assist.
Oh, sorry, Ms Wilcox, then,
Thank you. Yes, I can clarify. There was a more detailed document that was finalised in February, and over the ensuing months, SACS were refining that into a summary document, which was completed in September. Both documents formed part of the release, but one was a slightly easier consumption given the complexity of the evidence and detail.
Yes, the summary doesn't have the February 24, but the original has.
Yeah, so I guess as you could see, the date that the Minister alluded to, probably both should have been dated September on the date of release, but one document was received earlier, and it was worked on over a period of time to make a summary document.
But once that document was received on February, presumably it wasn't altered after that, is that right?
No, not at all. No, it was the document, and then the months that followed, Sachs Institute used that time to make a summary document.
Okay. And can I just ask, we still have does the Health Minister appoint an individual? Is that right? Dr Chant has in the past represented health on that on the board of Sachs Institute, is that right?
There were occasions where there was a health representative, but we actually removed ourselves from that position.
When was that,
given
Dr. Chant?
any perception of conflict of interest. I would have to check the exact date, but it's well over. I'll have to check. And
I
see
think
if
it's still
can get,
coming up though on their on some of their websites. It does. I mean, that's how I found that you are on the board. Perhaps that needs to be
I had issued a
updated.
withdrawal letter for many moons ago, so I'm happy to do that. It may have been an issue about the plan.
Why was it seen as a conflict? I'm sorry, I'm not familiar with this.
Well, given that New South Wales Health is both a funder of the organisation,
Yes, okay.
and I felt that at that time, being on the board might have given support for. I thought that conflict of interest could be perceived.
I understand it. You're funding it, and also, are you also providing sort of research that you're after? Like, who provides the scope?
So
the terms of
so we
reference
manage
to-
the contract. So the contract is managed by. So we provide funding for the Sachs Institute for a number of services from the Sachs Institute. And so we are a significant funder of the organisation, and that's through a medical research sort of lens. In return for that funding, we get things like evidence reviews, but it also pays for some of the programs of work that have been important for underpinning our research competitiveness, such as some of the work they've done, like the Search Aboriginal cohort, biobanking, some initiatives in that space as well.
And in their report, I'm just interested to know, and back to Ms. Pearce or Ms. Wilcox, it does in there talk about puberty suppression, and it talks in their summary in relation to that research suggests that some of the medications are safe and work well to delay puberty. I'm just interested to know, we've got a contrasting position in the UK where they now are saying that some of this evidence is coming out that it's unsafe, the puberty suppression and the medications involved with that. Have we undertaken any sort of attempts to understand what the UK has relied upon, what evidence they've relied upon?
Yes, thank you. As part of our work in transgender medicine, we have a clinical advisory group, and the group, along with supportive colleagues in the ministry, did take some analysis of the CAS review, obviously an important piece of work.
Review,
that there was some differences between what was looked at, I guess the UK context compared to our own. I think what was similar was that there was, I guess, consistency around our approach. Firstly, to be person-centred, multidisciplinary, very much focused on
this suppression, I think they're talking specifically about that type of medication that suppresses the puberty. Wouldn't it be the same across the UK
the
and
work
Australia?
that the Sachs Institute did, the contrast with the work in the CAS review was they looked at around 84 publications. Obviously, this is an evolving area of medicine, and there are not large numbers or population groups to look at. And the Sachs Institute did validate that those publications had suggested that the work around suppression, work around gender-affirming hormones and other psychosocial support was appropriate. And that is in our local context.
Madam Chair, can I just ask one infrastructure question, and then I'll. It's just an infrastructure about.
Your time's expired.
Okay, so can I ask in the next round? I just want to ask one particular question on infrastructure.
Can I come back to you and can I ask my question?
Okay,
It's the start of my
that's
time. Thank you. I've got a few questions for ambulance for Dr. Morgan. As I'm sure you're aware of this issue, I've heard that paramedics are frequently missing their breaks for a number of reasons, but particularly ramping. So missing breaks as well as having to extend their shifts and do significant amounts of overtime. What's being done to support paramedics to get their breaks and to finish their shifts on time?
Yeah, so look, the genesis of this, ultimately, the challenge is we're an emergency service organisation. When a 000 call comes in, we need to send staff to respond to those calls. Every ambulance service around the world struggles with this challenge. Obviously, you have a set amount of staffing. You bring on additional initiatives such as afternoon shifts that allow us to cover better over the meal break times and into the evening. So that's our primary way of addressing that. Likewise, we do categorisation, so we have policies and procedures that allow us to actually stagger the windows in which we're able to get crews to a break. So essentially what it means is, say a 000 call is triage to be met within an hour, then we will aim to get a crew a break before they go and do that job. So we stagger it in that way. The important thing is there's been a significant investment by both governments to the tune of in excess of $1.76 billion over the last 2.5 years. That has allowed us to make inroads to reducing the number of missed cribs and meal breaks. We've certainly been very, very challenged in the last few months around the winter break, but they're the primary ways that we do it, by additional staffing, by changing the rosters and having better policies and procedures to manage it.
Thank you. And I'm interested in those figures for overtime. Do you know for the last financial year how much was spent on overtime for paramedics?
Across the state, in all types, it was approximately $86 million.
Okay.
Out of a $1.5 billion budget at the time.
Yeah, thank you. And what's the trend with that? Is that increasing? Is it decreasing?
No, so basically it's the same. The main reason for that is that, particularly in regional New South Wales, when we bring on additional staffing, we invariably will maintain that staffing within regional New South Wales. The simple reality is the distance that you have to travel. And so just because we put on more staffing, it actually has a tendency to drive over time as well. That's why we employ additional relief officers, tends to be in the main peri-urban areas such as Newcastle, Sydney, Wollongong and Central Coast.
Okay, thank you. I have a question for Mr. Sloan. As you know, I'm a huge fan of the single employer model for GP registrars. Mm-hmm. What's the progress with that model? What's the uptake been and what's the plan moving forward?
Yeah, the plan is to keep going with it. So we're just in the second round of recruitment in the second year. The first year we had a very rushed, I think I mentioned it last time, a very rushed and compressed time period once the Commonwealth had approved the 80 exemptions for our two collaborative trial sites. In the second year, I've just been told by the team yesterday actually that we've got 31 new applicants for this round, taking us up to a total of, I think it was 52 people that will come on as single employer rural generalist trainees, and we'll continue to work on that. I'm not too sure how we'll fare with the October recruitment, but hopefully it'll be quite positive as we work towards the 80 exemption spots throughout the program. The distribution, however, has probably been the only thing that's still a bit tricky, but we've been pretty positive with a lot of sites in getting not only GPs who have been extremely supportive, because they are the number one supervisors in the case around the single employer model, but we'll continue to work with them, the primary health networks and the LHDs to get them distributed around the state.
Oh, great, thank you. I'd be interested and happy for it to be on notice in the breakdown of what LHDs those 31 are being placed in.
Yeah, for sure.
And I suppose just picking up on your answer there, for the districts that have fewer or maldistribution of those registrars, what are the barriers to putting the registrars through the single employer model in those LHDs?
I think there's no barriers to it. It all comes down to personal choice, like we're seeing in every other workforce challenge at the moment. People choosing where they want to work and where they'll go to, dependent on their own family or personal arrangements or otherwise. So, it really just comes down to personal choice of where they're happy to work throughout New South Wales and throughout the regions.
Okay. And have there been any conversations at all? Oh, sorry.
I was just going to add something on the Section 92. Part of my role, I've been working with the Commonwealth and other states and territories on the new National Health Reform Agreement, and as you'd expect, there's been considerable discussion around the role of the Section 92s and how constructive it's been. Administratively a little onerous, but everybody sees the value as you do. So we're hopeful through this process that we are going to have a more streamlined model that will enable a situation like a Section 92 to occur without all the administrative burden, and something that can be more mainstreamed and easier access right across the country.
Thank you. And I'm also interested, are there any conversations happening about potential future expansion of this, not just for rural generalists, but across the board? So, for example, I've heard from urban GP registrars who are really interested in being able to access parental leave, which is a significant issue for women, of course.
Yes, that's right. We have had some discussion around where there are thin and failing markets right across the country, and our situation in New South Wales is no different. Every state and territory feels similarly, so that has been a consideration. But as you'd expect, some of this policy work is still in a process of negotiation and finalisation, but that's certainly been aired.
Okay,
Yeah.
thank you.
Thank you.
I asked a question on notice probably a month or two ago about vacancy numbers for doctors in training across different local health districts, and the answer was essentially that that's not aggregated at a state level, that it couldn't be answered. Everybody's looking at Mr. Min, so I will as well. Please explain to me how this system works that means you don't have oversight, and I'm just particularly confused because yesterday I asked a question at Minister Jackson's hearing about vacancies for psychiatrists, and the mental health branch was able to answer that question. They had the numbers for how many vacancies there are for psychiatrists across the state, so how come they can answer that question and the doctors in training question can't be answered?
Chair, what I might do is send you the transcript from the Special Commission of Inquiry where this was pursued at length with both myself and Mr. Richard Griffiths. The main issue is that what is a vacancy? So if you take, for example, psychiatrists, if we were to say that there's 15 positions that are vacant, well, the fact is that there might be VMOs working in those positions on a temporary basis. There might be locums filling those positions. So are they vacant in the sense that they mean service can't be delivered? The answer to that is no. And to answer that question, so for each and every role in our system, and there's 170,000 headcount roles, the question you're really trying to answer is who's got a permanent person sitting in that role, or who's got a permanent part-time person or a permanent fractional person in that role. And if they're not permanent, is it actually vacant, or is there a temporary form of labour or a what do we call it, premium source of labour that's filling the role? Now, the only way we can answer that question, and the way we answered it with respect to psychiatry, is we go out and do a manual survey. And so the data that was discussed with you yesterday is only as accurate as it was about 2 months ago when it was struck. It's probably not accurate today in either the number of vacancies or the number that are vacancies that are actually not being filled with some form of contingent labour. So the payroll system, the rostering system, it can't produce the fidelity that answers that question. And the point that we made to the Special Commissioner was what actual help and use is it to know that instantaneously everywhere in the system? And the answer is it's not very useful in the sense that if you've got a vacancy in a clinical role, be it nursing or medical or allied health, you have to make a local decision about whether or not you use contingent labour to fill that, or whether you find another way to make service delivery possible without filling the vacancy. The main thing we want our local people doing is that operational decision making about how do I keep the service rolling. Our HR people out in districts and facilities, they're pretty acutely aware already of where they have the biggest call on their time to produce contingent labour responses to gaps. So they know where they've got a problem. Getting them to not do what they need to do, which is fill them, and instead do weekly surveys of what's the nature of that vacancy, how long has it been there, etc. Because that's what it takes. It's a highly manual process. Now, we were asked to do it by the Minister with respect to psychiatry because she was seeking to understand the veracity of what was being put to her by various stakeholders about changes that were happening in the mix of the psychiatric workforce. And to some degree, there's some evidence in that data, if you take it at 2 points, a year apart, that we have seen more non-permanent situations happening in some staff specialist positions. But we've also seen an increase in the VMOs in the psychiatry workforce in that same time frame, suggesting that there's actually a bit of a swap going on.
Yeah, thank you. So I suppose that example with psychiatrists where you've got a snapshot a year apart, in my view, that's very helpful data when you're looking at those kind of statewide trends to inform recruitment, retention. You're talking about that shift from staff specialists to VMOs. I'm very interested in that data for doctors in training, and I certainly would never expect a survey to be done weekly, but it makes sense for positions that are typically annual, that are typically hired for a calendar year, for that to be done once a year. Are you saying that I need to convince the Minister to request a manual survey to be able to get that data?
I think what I would say to you is I'd very much like to provide you with a transcript of, because we talked about it for perhaps 40 minutes in the Special Commission of Inquiry. My team's got a limited resource capacity for what it does, but it can't answer that question. So if we want to know anything about vacancy rates by any clinical group in the workforce, we actually have to go out there and require people in facilities to go through a quite detailed analysis. So it doesn't just impact my team, it impacts the frontline people who are otherwise trying to ensure that they're adequately planning for service delivery and dealing with any workforce
Did you
gaps that
quantify that for the psychiatrist question? How much work did it take to answer the psychiatrist question?
Well, we need to give the districts about 6 to 8 weeks to do it. So it's not, and as I pointed out, it's accurate that day, the day they strike it. Otherwise it's not accurate.
Sure. In the context of doctors in training, I can't imagine it varying wildly week to week. I'm more interested in that sort of year-to-year period.
Yeah. So there is data that we have available on new interns entering the system, and we know that because our systems tell us. So we run centralised recruitment for year one interns, and we can point to the fact that we've got positions that have not been filled as we work through state-based graduates, interstate graduates, and then international medical graduates. And there is a slight, there was a period in COVID there where there were no vacancies because no young doctors could leave the country. So, we actually filled all of our intern positions. I think in this year we're filling slightly less than we did the year before, but our number of interns go up each year as well. So that data exists and it is there for the trend purpose that you're talking about. What gets more complicated about doctors in training is that you're then moving on to everyone at PY2, 3, 5, 6, etc. So it's a question of just what value do you get from it. And it was put to me by the Special Counsel assisting the Commission that surely you need to know this. And I said, I'm pretty sure that the people running nursing at Bombala know that they've got a problem attracting permanent nurses to Bombala. They don't need us making them fill in a survey regularly to answer that question. They know. And that's why we did things like invent the rural incentive scheme for sites like that.
Yeah, I suppose I'm interested in understanding not so much that gaps where work's not being done, because I appreciate that will be a high priority for people locally, but those broader workforce trends in terms of doctors we're training here in New South Wales, whether they're staying in New South Wales.
Yeah. What I might also provide to you out of session and to the whole committee is the data analysis report that we prepared for the Special Commission. Because it does talk thematically about all of the major trends that reflect demand and supply issues in our workforce. There's no question that we have challenges associated with workforce distribution. We've referenced that. And we have areas and aspects of shortage. And we're very aware of them, right? And it's in that report to the Special Commission. So I'm happy
Thank
to
you.
make
I think the
that
committee
available.
would be interested. Thank you very much. I'll go to the opposition.
Thank you. If I could just pick up, I just wanted to clarify the position of the specialist international medical graduates. So they're operating in a hospital the way any other doctor of their level would be, and there's no special supervision protocol. Is that what I'm understanding?
I might take that on notice if you wouldn't
Okay.
mind,
Yeah,
Ms. Carr,
no,
just
thank
so
you.
I
Thank
provide
you.
you with an accurate
Yeah.
answer.
No,
I
thank you.
think we've got it right, but I just don't want to get it wrong, obviously.
No, if you could take it on notice. And also, I wonder, is there an IELTS requirement for these graduates?
Yes, an IELTS, the
language test.
Language.
What level?
I mean,
of
I think
IELTS?
for any international health professional, they have those requirements. So I can't see that this group would be any different.
If you could take on notice just what the level that's required is, that'd be great. Thank you. Yeah. These questions are possibly to you, Ms. Pearce, or to Dr. Chant, just to follow up in relation to the vaccine procurement for the RSV. Dr. Chant, what advice did you provide to the Minister when it came to the purchase and rollout of the vaccine Beyfortus?
So perhaps I should perhaps just answer in a slightly different way, if that's permissible. So just to confirm that in 2025 we are aiming to roll out a national immunisation program. Just to go back, that there are two different ways in which immunity can be afforded to the new baby, and that can be through maternal vaccination, or it can be through the product that you're referring to, which is a monoclonal antibody produced by, termed nirsevimab, but produced by Sanofi. So in terms of the advice I personally provided to the Minister, was that I certainly provided advice that our general approach to immunisation, and I have to go back to see the exact briefings that were the sequence, but perhaps if I could talk in generalities and then provide the specifics on notice. So in general, we support, from a policy position, we support a national immunisation program. And the national...
Could I just stop you there?
Yeah.
So if you're supporting a national immunisation program, what discussions did you have with your colleagues in Western Australia and Queensland about the fact that they rolled out to a whole cohort?
Well, clearly at the time, the national immunisation program is coordinated by the federal government, and the way that works is that companies apply to have their products, vaccines, put on the national immunisation schedule. They are required to go through PBAC, and then there's also a process where the Australian Technical
But if I can just stop you there, if it's gone through PBAC, well, presumably if it's rather in Western Australia and Queensland...
Perhaps if I could update you on the status of the particular products.
So it's more... why did we only do a limited cohort in New South Wales when other states are doing it more broadly? And was that a decision that you supported?
So perhaps we could go back to just maybe, if I could just also put on the record. So nirsevimab, the Sanofi product, has gone through PBAC processes, which is the Pharmaceutical Benefits Advisory Committee, which provides advice to government on cost effectiveness. With the data presented by Sanofi in its application to PBAC deemed that the product was not cost effective. Now, I do note that there will be subsequent information presented to PBAC, and clearly the company is encouraged to reapply. And similarly, the companies that are doing the maternal vaccination are going through a similar PBAC process. So at the time...
Can I just clarify? So what I'm hearing from you is that you have some concerns about the safety of the vaccines that have been rolled out in Western Australia and Queensland?
Not at all.
Well, then I don't really understand why we're getting a lot of detail about the approval process when the question is, why a limited rollout in New South Wales but not in other states? And was that your advice to the Minister?
So in terms of the two states that rolled out a whole of program, that was done by those states to generate data with the view, look, you have to talk to those states.
Sorry, the only reason they vaccinated all their infants was to generate data?
So the issue at the time, the RSV vaccine was promoted as a good vaccine. I believe that it is very protective and very safe. We entered into discussions with Sanofi to procure some vulnerable persons program, that with the view to getting clarity about the program design for a nationally consistent program in 2025. So that is basically the approach. We are committed to work with Sanofi on the basis that there were two different products in the market that were potentially going to form part of the national immunisation program.
I cannot comment on Queensland and Western Australia. You would have to direct the questions for those. But I'm talking about is that
thank you. That's very
in
helpful.
2025,
thank you.
We are committed to rolling out a program, and it will be in accordance with the ATAGI advice, taking into account any PBAC deliberations as well.
And so in 2025, there will be a Bay Orders rollout of vaccine for the entire infant cohort in New South Wales. Is that right?
As I've indicated to you, these programs are subject to consideration by the Commonwealth. So in terms of the... I'm just trying to reconcile the two statements. The one statement is that we're working towards a vaccination program in 2025. Now I'm hearing hesitation about the fact that there will be a vaccine rollout in 2025. So we are committed to working nationally to achieve a national immunisation program in 2025.
So if I have a baby this year, improbable as that may be, I should expect that it will be vaccinated because it's a baby in New South Wales with respect to RSV in 2025.
We are very committed to rolling out a program in 2025.
Will it happen?
I believe it will happen, and we are actually working actively.
And when's the cut-off for discussions with Sanofi to secure the supplies of the vaccine?
So the issue that I cannot... Those conversations are happening and being coordinated by the federal government, but as I indicated to you, that ATAGI has there has been advice provided that there are two ways to ensure vaccination of the newborn baby in terms of immunity, and that is either through maternal vaccination or through the monoclonal antibody. Currently, the Pharmaceutical Benefits Advisory Committee considered a submission from in relation to a product, Abrysio. Initially, the view was that it was not cost effective with the price that the company put in. That has been asked to be resubmitted, and to consider additional evidence. The PBAC decision of that has not been made public, and I'm not I cannot preempt that process.
So with respect to, can I just ask one question? And Ms. Pearce, I'll happily come to you in 1 minute. With respect to the issue about cost effectiveness, if New South Wales had provided free immunisation to all infants, would we have seen fewer hospitalisations in New South Wales, which would have had a lower personal cost and also a lower financial cost?
I don't want to give any sense that the vaccine... I clearly very much supported procurement of the vaccine and to the rollout. I suppose I'm just also giving the context for the committee, the national processes by which we have the approval and introduction of vaccines. So the vaccine has been rolled out. I'd also just really like to thank our clinicians, our midwives, our nurses, our Aboriginal healthcare workers. I join with you in all of
that, and everybody involved in the vaccination program. It's very important.
But I just
could
really
I go to Ms. Pearce, if that's okay, Dr. Chan? Ms. Pearce, could I just frame this perhaps? Are you in discussions with Pfizer about securing the maternal vaccine? I believe it's called Abrysvo, and can you tell us where those discussions are at?
No, I am personally not involved in discussions with Pfizer.
Is anybody in New South Wales Health involved in those discussions?
As I indicated earlier, Mrs. Carter, with respect to the question that Dr. Chant is responding to, and I will say this as a secretary, I am not a supporter of the state going it alone in respect of vaccination programs and gazumping each other with other states. There are price impacts associated with that type of behaviour.
And so did Queensland and Western Australia create those problems for New South Wales?
I'm not going to comment about Queensland and Western Australia. My point is that there is a Commonwealth process around... Excuse me, Chair, can I finish what I'm saying, please?
I've had a point of order, but I think I know what it's going to be.
Yeah, Chair, look, with the greatest of respect, the witness is attempting to answer the question. The member asking just keeps asking new questions over the top of it, and I think the witness ought to be treated with a degree of respect and given a reasonable opportunity to answer.
I'll uphold that.
All I'm trying to say is that there is a Commonwealth process with respect of the approval of vaccination programs across the state. Certainly from my perspective, and obviously you, I'm sure, would be aware of my role in the vaccination of this entire state during the pandemic, and a great advocate of vaccinations, clearly. But my advice has been fairly consistent to the Minister, as it was to Minister Hazzard before, that it is I believe, not in the interests of the country for states to be jumping out in front of each other with regard to these vaccination programs, that the Commonwealth processes that are in place are there to look at the cost effectiveness of the vaccines, to stop companies from profiteering from vaccines, etc. And on that basis, we provide the advice to our minister. And I think Dr. Chant's credentials in this space are impeccable. And her advice is always in the best interests of the people of New South Wales in all circumstances. Our advice to the Minister is that the Commonwealth has a process, and that is the advice that we provided him in respect of the RSV vaccines.
And have you provided any advice with respect to the cohort of people 75 to 79 years old?
In regard to what?
To the RSV vaccine?
That again is subject to the PBAC processes, and we will be willing to implement that program if it is achieving cost effectiveness.
Sorry, cost effectiveness. What price do we put on somebody between
Can I
75 to 79 becoming
can I just
ill?
make the point that cost effectiveness is one of the considerations that the Commonwealth processes take into consideration. We're not trying to
but
suggest
what does
that.
cost effectiveness mean in terms of a person becoming ill? It's just
Are
an
you
interesting
suggesting
concept.
that we would put price above people's
Well, that's what I'm
interests? Is that
asking,
what
Ms.
you're
Pearce,
suggesting?
because it's been offered as, well, this is all subject to cost effectiveness.
What we're
so I'm trying to
saying is there are
explore what
processes
that means in terms of the health
as
reasoning.
with any medication, any vaccination, with respect to the cost effectiveness and the ability for countries, states, otherwise to roll them out. We are not, under any circumstances, putting the cost effectiveness of a product above the interests of our community.
No, I wouldn't expect that either, so thank you for that clarification. Perhaps, Ms Schoolander, these questions are for you. It's about Bankstown Hospital.
Possibly.
So I understand that health has the lead in terms of the overall development of the new hospital site, and this involves the relocation of the existing TAFE site. So can you tell us briefly where that's at?
Yes, so the Bankstown Hospital project, the planning for that project is underway, and we're in the process of pulling together a business case which we're planning to prepare by the end of this year. The business case will talk about the options, which all of our business cases do, for the investment of the money that's been committed to that project. Those options include the new hospital on the site, which has been a commitment of government, as well as the relocation temporarily of TAFE and the return of TAFE to the site.
So the business case will explore the options, so it's possible that if the business case recommended against a new hospital on that site and relocation of TAFE, that could be reconsidered?
The business case will explore all options, including do nothing. All of our business cases have that option in. Obviously, there are commitments made in relation to delivery of a hospital there, and the clinical services planning supports the requirement for that hospital. So I think that whilst the options will explore that, the options then look at the economic analysis of an investment of a new hospital there, as well as new education facilities on that site. It would be unlikely that it would tell you to do nothing. And so I think that there will be several options considered, and the business case will put forward a recommendation.
And if the TAFE is to be relocated, is that funded out of the health budget?
The business case, we are working closely with TAFE on the business case, and so TAFE is providing input into what's required for that relocation. We're in fairly early planning, and I think TAFE in their estimates commented on the processes that they're undertaking at the moment for that. And I don't have full visibility of their planning at this point in time, but we're working very closely with them, and I expect that the hospital and the TAFE will form part of that business case and the recommendations.
And I'm raising these questions now because you're right, in TAFE estimates it was said it's health is leading, and so we should ask these questions of health. And there are a lot of concerns as to, is the 1.3 billion, is that for the hospital, or is that for the hospital and the TAFE relocation? And a lot of confusion, and that's what I'm hoping you can clear up for us today.
Certainly, our objective is that the business case will cover both the hospital and the TAFE facilities. In terms of the scope of each of those, obviously with all of our business case processes, we review what we're able to afford within the budget allocations, and certainly against the clinical services plan, we expect within the hospital side of this, we expect that we will be able to come up with a viable sort of way forward in relation to the hospital based on that clinical services plan. But it is an act of, I guess, balancing to get the best bang for buck from the money that's available, and certainly we'll be working with TAFE to try and get an outcome that we can both agree is the best way forward.
And the budget is the budget for the business case?
Well, we've got the budget available to fund the business case, yes.
No, I'm sorry. There's been,
Yeah.
as I understand it, a $1.3 billion allocation, and that's the budget that the business case will be working within that envelope of spending that money?
Correct.
And so that involves hospital and TAFE in that?
Correct, and options within that as to what can be delivered.
Okay, so the $1.3 billion covers the new hospital and the relocation of the TAFE?
I think that it's too early to say the answer to that question definitively, because we are in the early planning phases and there's another few months to go to make sure we understand what's required from both of those facilities and the cost estimates against that.
So there could well be a significant cost increase then on that $1.3 billion?
Depending on the preferred scope of the options within the business case.
Okay, so the funding isn't settled. It could well be in excess of what's been currently allocated and promised.
My instruction and my remit is to work to a budget of $1.3 million, but within all of our business cases, we explore options.
Okay, so if I could summarise, the plan, the hope is $1.3 billion for hospital and TAFE, but it well may exceed that once the business case is developed.
I think that I can't definitively answer the question with the available information at this point in time, because I also don't have the full information from TAFE, but certainly we are collaboratively working on a process that will answer that question within the business case by the end of the year.
By the end of the year we should have some understanding, and that business case will be made public?
No, our business cases generally aren't made public.
So how do we get the answer then?
Potentially asking me the question again at a point in time where I've got more information.
So can I just jump in on that? So is that, in your view on the current envelope, is that enough for both?
On the current envelope, is that enough for both facilities? I think because we don't know what we're delivering within both of those, I can't answer that question.
But you must have an understanding of relocating the TAFE and the hospital, whether that is sufficient given.
Well, I think there's a variety of parameters within options for both. So TAFE, for example, is examining what it retains at Bankstown and what it moves to other locations, and they spoke about that too in their estimates. So I think for the hospital as well, we're reviewing what is critical to be within a new hospital at Bankstown and what is not, and I think that process is underway and is not yet determined an outcome.
But the business case would define what the options are. It never leaves an open-ended, go spend whatever you like option. It's
Correct.
These are the different options. So of those options, is the 1.3 sufficient, in your view, to cover off both facilities being...
I don't have that information at this point in time.
Can you take it on notice?
I won't be able to answer that question until the options analysis is undertaken in the coming months with the information that I need to be able to answer the question.
So, to Ms Carter's point, it might be fair to understand that that may not be sufficient. If you can't definitively say that it is,
Well, I
we
think
can
with
only
any
make the
capital
assumption to be
project,
fair
if you ask the question to me for any capital project at this point in the planning process, I wouldn't be able to definitively tell you that it can that we can afford to deliver what's been asked of the scope, because there is a fair amount of work undertaken in the planning phase to get to a point where we have a solid cost estimate for the project, at which point we develop a business case.
Yeah, I thought we were talking about the business case.
Yeah, well, that business case is in progress. So the planning process that I've just described occurs in parallel with the development of the business case.
Okay.
And then
So
once
the
we've
final
got that
business
information, we can lodge that, and that will give you the definitive answers that you're asking for.
Okay, quick question for you, Mr Minns, if I may. If I'm employed by New South Wales Health and I want to seek political office, state or federal, what are the protocols? Do I need to resign? What are the guidelines?
Look, we do have them. I just can't recall them off the top of my head.
Okay. If you could take them on notice, that would be very helpful.
And I think there's difference related to which jurisdiction. So I don't think the requirement is as extensive for local government, for example. So that's why I'd like to take it on notice.
Yeah, and perhaps also on notice opportunities for re-employment, whether there's continuity of service, all of those things would be very useful. Thank you.
Happy to do that.
Yeah.
Ms Mihalik.
Just thank you, Madam Chair. I just wanted to ask just a couple of questions just on the Bankstown Hospital as well. And look, I appreciate that you're waiting for a business case and so forth. Are you still, I mean, there were a lot of discussions with stakeholders, including council, in making a decision about the site. Are there still discussions with the local council being undertaken by health?
Across our program, we'll have ongoing discussions and briefings to council throughout a planning process. So I don't know the answer specifically to when the last time we would have met with council, but certainly through the process that occurs.
Okay. And just on, at the moment, how much money have you allocated towards the business case, specifically of the 1.3 billion? Is there a figure of how much this business case or business cases are going to?
No, generally, I mean, I can take the question on notice, but
notice,
generally
I'm
the
happy.
planning process will take a certain component of the total budget. I don't know the answer to the question.
And will you be relying on consultants as well, officially consultants from outside the Department of Health?
And
as well,
consultants
so?
in sort of what
Well, you may
sense?
rely on communication consultants, you might rely on planning consultants. I'm not sure
Yeah.
who you're, I don't know whether you have all the expertise within New South Wales Health. Are you relying on external consultants to prepare your business cases?
So preparation of the business case itself involves also the design process to pull together the planning and design for the hospital. And in that, yes, we do. We don't have in-house design services. And the preparation of the business case documents themselves are done in a hybrid model at the moment. And we have in-house staff who facilitate and prepare large components of that, but we also outsource.
So you're going to be tendering
elements.
out? I mean, I assume these are quite large.
Yeah, we've already tendered a number of professional services in relation to the Bankstown project.
Okay, and can that be something that a member of the public can find who are the recipients of this?
Yeah,
on these consultants?
in terms of the contracts that we've let against Bankstown, they're available on the e-tender website. The processes that we follow procurement policy and require us to publish.
Does that also publish the amounts?
Yeah.
Okay. And do you have any lobbyists that have been lobbying New South Wales Health in relation to?
Not to my
Bankstown
knowledge.
Hospital? Not to your knowledge. Can you confirm that? Any registered lobbyists, whether they've met with New South Wales Health in the last 12 months in relation to Bankstown Hospital?
I can check. I think the
Put that
answer
on
is no.
notice? Okay, thank you.
Thank you. I've got a question about the single digital patient record. Thanks, Ms. Pearce. I'm interested what involvement GPs have had with this, and if what work's underway to improve visibility for GPs. I know that in Queensland, it's my understanding that GPs can see hospital records that are in recent years.
Yeah, look, I think the Queensland work you're referring to is probably that they've done great work up there with their outpatients data sets that link across to GPs. Obviously, the SDPR is a huge program here across New South Wales, but I'll get Ms Wilcox to respond to that.
Thanks, Susan. Thanks, Dr. Conn. As you'd be aware, the Single Digital Patient Record Implementation Authority has been stood up, and Dr. Anderson is leading that work. The consultation with clinicians as well as NGOs and non-government and community partners and our general practice is fundamental to this work, because this is a significant clinical transformation of our system, and as much interface and connectivity we can get with all partners delivering healthcare across the state for our citizens is really exciting prospect. So there is targeted discussions with our primary healthcare networks, and we have a joint committee at a state level, and Dr. Anderson was already briefed that committee, and we'll have ongoing discussions to see how we can roll this out as part of the implementation. I mean, as you know, there are two primary general practice patient information systems, and in previous implementations, Epic, who is the vendor for our single digital patient record, has managed to get an interface with those types of systems. So we're reasonably confident, but we just have to go through the consultation, due diligence, the resourcing, and all the things you'd expect with such a program. But we remain optimistic about it, and it would be an optimal outcome from our perspective also.
Absolutely, and I understand this is quite a long project, but
Yes.
in terms of particularly that interoperability with general practice systems, do you know what the time frame is for being able to work out if that's that will be possible?
I'd have to take time frame on notice. You're quite right. It's a rollout will start next year and run for another, up to 3 years. We need to make a number of, in fact, about 19,000 decisions, quite literally, over the next couple of months before the implementation takes place. But I'll get a timing for you around the general practice connectivity.
Thanks very much. And I also have another question on behalf of GPs. There's been a lot of media coverage recently of initiatives about increasing or expanding scope of practice for pharmacists, for nurse practitioners. Is there any work being done to actually look at increasing the scope of practice of GPs? I'm particularly interested in things like Roaccutane prescribing, which happens in Queensland, like ADHD diagnosis and management in the ACT.
I think we recognise that primary care is the sort of stalwart and important home for patients. I know I can speak in my area of drug and alcohol that we're really looking at recognising that primary practice does a lot in that area anyway, but looking at how we can better support primary care, including access to additional training, acknowledging the important role of the college. I'm aware that there has been some work, but I would have to take it on notice in relation to the extended prescribing, recognising access to paediatricians are very difficult for ADHD and those areas. So I believe there might have been some developmental work considering the role of primary care in that. But there'd be examples across all of our portfolio areas where we'd be looking at upskilling general practice. I can imagine mental health, there would be similar work. So, but if there's particular areas,
happy for it to be taken on notice, and I suppose I've raised those particular prescribing examples because there's of course regulatory barriers to that happening, even for a practitioner who's come to New South Wales from New Zealand or from Queensland, where they may very comfortably have within their scope prescribing something like Roaccutane.
I'd be certainly happy to take that on notice and talk to my colleagues in pharmaceutical services.
Thanks very much. I'll come back to Ms Pearce, but please redirect it if appropriate. I'm interested in the progress on the LGBTQI plus health strategy, and particularly what's happening beyond phase 1 of that strategy.
Thanks, Dr. Con. So the strategy, as you know, is it's about its second year of implementation. It runs to 2027. We've done a lot of work with HETI, the Health Education and Training Institute within New South Wales Health, to strengthen our workforce education and training. Some funding has also been provided to ACON, who are a very important partner in this work. There's a number of projects that we've funded across the state for local health districts to have local initiatives with their LGBTQI plus community. There's a lot of promotional material around posters and resources that local health districts can access to increase their education and awareness, to mitigate any sort of stigma and other issues in the workplace, and to make sure that all of our healthcare facilities are welcoming locations for the community to come into and feel safe and feel that this is a place they can come and access healthcare. So it's got it's got a couple of years to run. It's a rolling program of activity. If there are specific things that you're looking for, I'm very happy to come back, but it's been received very positively by the communities. We've got strong engagement within our workforce, and there's ongoing work with partners like ACON and Trans Community and others, because making our health places safe and accessible for those parts of the community is what our priority is in this strategy, and making sure when they come and have healthcare with us that we can talk to the whole person.
There were some really excellent projects funded as part of that first tranche of funding, and from memory it was something like $2 million as a one-off. Moving forward, is there a budget for further stages of projects under that strategy?
There is, you're quite right, there's some funding around that we gave to the Gender Centre, some to Rainbow Families, ACON. There was also funding for ACON to undertake some mental health initiatives as well. So they're all at varying stages. We'll continue to advocate for work for this community, but most of the funding initiatives have still got some time to run.
Okay, thank you. Coming back to the birth trauma inquiry, which we discussed this morning, there were a number of recommendations around antenatal education, and of course to be able to provide informed consent, it needs to be informed. And I was particularly interested in the educational resource, which is the Having a Baby book. Now, I've never had a baby, but I have a copy of this book because when I was a medical student on placement in a New South Wales health facility, a midwife gave me that book as a helpful learning resource as a medical student. And there's a section of that book on delivery using forceps or vacuum extraction, and I'm going to quote the book. It says, "Your doctor will choose the method depending on what's happening during the birth. Sometimes forceps are best and at other times it's better to use vacuum extraction. It's often a decision that needs to be made at the time rather than something that you can plan for. Before any of these procedures, your midwife or doctor will explain what will happen and any possible side effects."
Yeah, thank you for that question. Look, it was very clear through the birth trauma inquiry that our communication at times doesn't meet the expectations, and possibly what you've just cited there I would put into that category, done at a particular point in time for a purpose, but I think these are the things we have to learn and we have to keep improving, and we have to listen to women and families and understand what is the right way to communicate. The issue around consent was a very strong feature of the inquiry, as you're aware of, as was communication and how information is provided to women. So I would put that document that you've cited, falls into both of those categories. We have got two very important groups that are stood up that are accelerating 5 components of the birth trauma response, and issues around consent and communication are part of this first tranche of work. We have a clinical advisory group that has both obstetric and midwifery leadership on to help us with the clinical setting, because as you know, an issue around timing of when you seek consent can be quite complex in the birthing experience. And very importantly, we have a consumer group who are there to help us test ideas, put real women's experiences forward. There are a number of women on that group who participated and provided very compelling submissions to the inquiry. So I would say consent and communication are 2 priority areas that we're accelerating in response to the inquiry, and I think our leads and our consumer and women who are contributing to the implementation of our blueprint are critical to making sure whatever communication we provide to women and families, we can improve somewhat on that you've just outlined.
Yeah, thank you. I'm glad that you agree that this is something that needs an update, and I suppose through the inquiry there's complexity in delivering the right antenatal education, and it's of course going to vary in terms of people's preferences and the context that they're in. A resource like this that's a book that's available statewide seems to me as strikingly low-hanging fruit for something to update that could be really broad-reaching. So is updating that book part of that accelerated rollout?
I can't speak directly on that book, but I can say that we are updating the communication more broadly, but we do want to do a round of consultation with our consumers and women to make sure whatever we change actually meets the need. So I can clarify on the specifics of that book, but I can with confidence say that this is an accelerated piece of work, and we all agree it needs to be done.
Yeah, thanks very much. And I did actually want to ask a question. So in the government's response to the birth trauma inquiry, it listed those 5 initiatives that were being accelerated. Could you just explain in more detail, I suppose, what it means that they're being accelerated in practice?
Yeah, so it was quite a large report with the 43 recommendations. So as you're aware, we already had created our blueprint for maternity care. That work was underway ahead of the inquiry, and as I've said previously publicly, it's been, whilst a fairly distressing and difficult time for many people during that inquiry, and very hard to listen to some of that evidence. If there's something positive out of it, it was that many of the things that women raised was validated by the input that we'd had from, literally 18,000 surveys and other people's input into our blueprint. So what we've used the inquiry for is to say what were the things that really got the most attention through all of those submissions and all the witness statements, and we've identified those and pulled them up to say these are the ones we think we heard loud and clear, and these are the ones that would move as quickly as possible on. So the 5 that the Minister announced in the government response to the inquiry will take precedent. There'll be some work concurrently going on. It's sort of like not stop everything and just do these, but we want to give emphasis and priority to those 5 that the Minister outlined.
Okay, thank you. I've got a question about dental clinics. Ms Pearce, please let me know. Thanks, Dr.
Chad would love to answer a question about dental clinics.
I apologise that it's not a very exciting one. At previous estimates in February, it was acknowledged that 4,000 people were waiting longer than the maximum recommended time for public dental services. Can you give an update on the current waitlist figures and particularly how many people are waiting beyond the maximum clinically recommended time?
Okay, so I'd happy to provide. So as at the 11th of August, there was 78,301 adults and 6,700 children on the general dental wait list. Pleasingly for general dental wait care, we've got 96.3% are waiting for assessment and treatment, have waited within the wait times. I'll have to get you the data on those that have exceeded in terms of global numbers. And then there's also a specialist area, which is our real strong focus, because those wait times were much longer than exceedances were much longer.
Yeah,
so
thank you. Happy to have that on notice and appreciate that that's basic arithmetic could work backwards from the figures you've just given me, but not off the top of my head. Thank you, and I am interested in the specialist figures as well.
Dr. Khan, Chair, sorry, can I just make a bit of a correction, disappointingly? So we had 34 single employer offers sent out, but of those there was only 5 declined, so we had 29 in total as of September, so we'll wait for the
thank you.
update.
So 29 rather than 31.
And I'm happy to whip through the local health district breakdown
please.
now. Yep, so Far West is our only one that we're struggling with 0 applicants at the moment. Western New South Wales has 3, Southern New South Wales 2, Illawarra Shoalhaven 6, Murrumbidgee a further 3, Mid-North Coast 4, and Northern New South Wales 1, and Hunter New England Local Health District 10 to make the 29.
Okay, so you said 10 for Hunter New England?
Yes.
That's a great result. My understanding was there was only 1 in the previous.
Yeah. Yep.
Thank you, that's great.
No worries.
Just before my time runs out, I
Dr.
neglected
Khan, could I just update you on the Having a Baby book very quickly?
Please.
Just to let you know, it is undergoing review and it's not currently available in hard copy while that's under review, so that will happen expeditiously. Thank you. Thanks for raising it.
Fantastic, thank you. I did intend to table this morning the paper that I referred to when I was asking questions of the Minister relating to COVID. And
I've got that electronically.
instituted.
I've already accessed it.
That's all right, but there might be members of the public who are watching this who are not as adept as you are, Dr. Chant, at whipping up peer-reviewed articles. So for the sake of the committee, I'll seek to table that journal article. Thank you. With 3 minutes left, I might go to health infrastructure. I'm interested in, firstly, Royal North Shore Hospital. So it's my understanding that in 2020 there was a parcel of land that's been called Block 4B that was given to Lands and Property that's no longer in the possession of Health. Speaking to clinicians in Royal North Shore, I also understand there is a need for expansion of that hospital, particularly outpatient departments. I suppose I also appreciate as a rural resident that that's a retrieval and a referral hospital for a huge number of people across the state and not just serving that local area. When you look at a map, Block 4B is right between the hospital and St Leonard's train station. It seems like a really optimal place to put a very accessible outpatient clinic for people that might have impaired mobility. I'm interested in the work that's happening for potential future expansion of Royal North Shore and if there is any work being done to reclaim Block 4B for health purposes.
So, yes, I know which lot you're referring to, and some of that I can answer. I think in relation to the master planning for the Royal North Shore Hospital, there was a master plan developed in 2023 that reviews the future planning for that precinct. And in relation to Lot 4B, I understand that there is a proposal at the moment on exhibition in relation to development of that, with Property New South Wales sort of taking the lead on that component. As health, the proposal that's been put forward isn't consistent with what we hoped for that site. In relation to its use within the master plan, it's my understanding is that it's not necessarily a prime site for the core clinical activities of Royal North Shore, but it's certainly a location that we would like to be complementary to the North Shore activities.
Thank you. And can I just ask you to expand? You said it's not what you would have hoped for. What would you see as the optimal use for that site?
I would have to take that on notice in relation to our specific request in relation to that site.
Okay. Thank you.
Thanks.
You can have the last 30 seconds if you want.
Thank you. Ms Wilcox, just back to you in the Sachs Institute's report. Page 141 does indicate, just after puberty suppression treatment, it reads that the strength of this evidence remains low. So it was saying that predominantly reinforces findings of the previous review, but then it with research reporting that puberty suppression treatment is safe, effective and reversible, but then it says the strength of this evidence remains low. I'm just trying to understand, why isn't New South Wales Health using sort of precautionary principle in relation to this type of treatment as it does in most cases, particularly when you've got the evidence that you're relying on, the Sachs Institute, rather than relying on the UK's CAS review, where it's saying they really can't back that in, that it's safe.
I think in terms of the credentials of the Sachs Institute, they did review over 80 pieces of evidence and literature.
No, but they've written that in their summary. They're actually saying that it's not
equally
reliable.
They indicate that these medications are safe and that it's not an unacceptable mode of treatment. These things are not done in a sort of a transactional sense. These are complex discussions with young people and their families to look at a person's individual situation. What are the risks? What are the pros and cons of embarking on treatment like this? So I think it's around the totality of the interaction with a young person, and not just a single point that if any one particular study had an opinion on it. What we've got is a sort of a meta-analysis of all of the literature as it responds.
But they're saying they're relying on the previous findings. They're making it clear that the evidence that's for them isn't really reliable, and I'm trying to understand where New South Wales Health now relying. What's your evidence that you're relying on to suggesting this suppression treatment, puberty suppression treatment, is safe?
The Sachs Institute haven't given us direct clinical information. What they've done is done analysis of the available literature, which your point is well made. There are low volumes of patients, so we don't have vast pieces of evidence and population studies, and that's something clearly as it evolves we will do. We've taken this work to our clinical advisory group, who are clinicians that work in this field and understand it, and they've utilised the advice and feel that what we're doing here with multidisciplinary teams, patient-centred care, is absolutely appropriate and aligns with the findings of the Sachs Institute. And there is a lot of alignment with the CAS as well.
See, this point made in page 141 is not in the summary though, so I'm just trying to understand.
Could you repeat that?
What was summarised in page 141?
I already let you ask another question at the end of time. I've been really generous.
I can take on notice the commentary in page 141.
Take it on notice why this particular commentary is not in the summary report, the 4-page summary report that took us 7 months extra to submit.
I'll come back to you with the detail on that. Thank you.
I have a quick question for whoever is representing the Environmental Health Branch. Thank you, Dr. Chant. I wrote a letter to the Minister back in April on behalf of an air pollution expert, particularly regarding the fact sheet on the New South Wales Health website on wood-burning heaters and your health. So particularly noting that there's been new research published this year, including in the MJA, on impacts of wood heater smoke in particular. Is that fact sheet going to be updated?
I'm happy to address that, and just would like to put on the record that obviously New South Wales Health acknowledges the important contribution that wood fire heaters do contribute to Sydney's air pollution. So we certainly want people to be aware of the impacts of indoor and outdoor air pollution. Okay. So I'm happy to review that.
Okay,
fact sheet, if there's a particular section.
Yeah, my question. So I suppose there's two bits to this question. Appreciate your acknowledgement of the issue. It wasn't already under review that you're aware of?
I would just have to check with Environmental Health. Obviously, we review our policies indirectly, but I would have thought that it did highlight. I think it already. I would have assumed it had already highlighted the significant health impacts. But it's important that we do frequently review the fact sheets to incorporate any new evidence that might give strength to that. So I will take that on notice.
Thank you very much. Appreciate you looking into it. It's afternoon tea, isn't it? Okay, we'll have a short break for afternoon tea. questions from the opposition?
Ms Schoolander, if I could just come back to you for a couple more infrastructure questions. The Blacktown Mount Druitt Hospital, I understand $5 million has been allocated for this year. Is that planning money? What's that money for?
In relation to Blacktown and Mount Druitt, I think the number that you're referring to is from the budget papers this year, correct?
Yes.
So that's just our allocation within year for the planning work that we're doing. So the overall ETC or estimated total cost for that project is $120 million. At the moment, we're working on the development of the master plan, and we'll sort of look to share some progress on that either late this year or early next year.
Okay, and you're confident that's on track for 2028 completion?
Yes.
Great. And Rouse Hill, I understand that's $33 million allocated. How much has been spent of that to date?
Spent to date, which was at the end of June 24, was $61 million.
61 million.
61.262
has been already spent? Because
yes.
I have a different... Sorry, if it's a total cost of 33 million, how can 61.2 million have been spent?
Is the 33 million this year?
Well, I think the budget papers identify 16 million allocated in CapEx for Rouse Hill this year.
For this year, sorry. Sorry, I thought you were referring to the spent to date on the project. So do you mean spent to date within this year?
Well, can you give me spent to date and spent to date this year?
Yep, so spent to date is 61.26 million. 61.262 million is spent to date on the project at the end of last financial year.
And so the total cost of that hospital is going to be?
700 million.
700 million, great, thank you. And that is on track to be delivered by 2029?
Yes.
Great. Just curious whether you have any thoughts. The EBA that we heard about this morning, which has labourers earning $200,000, what sort of impact does that have on final costs for health infrastructure?
In relation to the specifics of the EBA and the number that you've quoted, I'm not familiar with the numbers within them.
Sorry, I think my question really is, if we're seeing labour costs like that, will it have an impact on the final costing of health infrastructure?
I think certainly you will have seen and heard there's a lot of narrative at present around construction cost. Escalation started to occur in around 2020. The impacts of COVID had significant escalation impact on construction costs. That was predominantly in relation to materials and the availability of materials being shipped from overseas.
But this isn't a COVID cost, this is a CFMEU cost.
In relation to labour costs generally, and
Yes.
I can't attribute it to the CFMEU. I think it's labour cost escalation more broadly.
So labourers generally would be getting $200,000 a year on a building site?
I can't comment on the specifics of the dollars that they're being paid, but I think the labour cost escalation is attributed to a number of different factors. One of them that you're inferring is the EBA agreements generally. I think another is labour shortage, so certainly the shortage of workers in the construction sector is substantial, and in particular trades, and that has driven certainly the cost of labour up. The cost of labour is a significant contributor to the construction cost escalation.
Are you able to take on notice the average cost being paid, the average wage being paid to labourers on health infrastructure sites?
No, because I don't have the visibility of that. What I have the visibility of is the sort of gross rates of construction that we would have paid previously and now. And I have those gross rates of construction from all the construction tenders that we've got in. Those actual rates of pay to the subcontractors and in turn to the labourers are within the EBAs that you refer to, or the work arrangements between the subcontractors and the labourers.
And do you have any procurement guidelines which suggest that the EBAs, that the labour costs should be moderated to save the people of New South Wales money in these enormously expensive builds?
No. The EBAs, though...
Is that something you could look at in future?
It wouldn't be my role to be able to look at that.
Whose role would it be?
The Fair Work Commission signs off on the EBAs, and the EBAs that we've spoken about today are ones that are ratified by the Fair Work Commission.
I guess I'm more thinking you choose contractors.
Yep.
And could it be something as part of your procurement process or your discussions with contractors that you expect people to be paid a fair wage but not an exorbitant wage?
So all of our contractors are pre-qualified on the New South Wales government schemes.
So just checking, so all of the contractors are pre-qualified, so that means that the contractor we heard about this morning was pre-qualified even though that EBA is a CFMEU negotiated EBA which allows for $200,000 a year for a labourer.
Can't comment on the specifics of the EBA arrangements in relation to that. However, each of our contractors, and the market in Australia is fairly limited in terms of our access to contractors, so Tier 1 contractors and Tier 2 contractors are generally what we need to access for hospital projects. We've got very complex delivery, and you can't just get every contractor to build. So on the pre-qualification schemes, there's been a check to make sure they can build hospitals.
Okay,
All of those Tier 1 and Tier 2s, though, would have EBAs in place or be negotiating those EBAs, and those EBAs are all signed by the Fair Work Commission.
Right,
The federal government has requested that the Fair Work Commission and the I can never say that word, review those EBAs with consideration to the comments that you're making.
Okay, thank you very much. These questions might be for Ms Pearce or for Dr Chant. It's in relation to the interim report of the VAD board, and the interesting. Are you familiar with that report? Have you read it? Yeah, and they make if you look at the figures, in the first 3 months of operation in New South Wales, there were the same number of people accessing VAD than in the first year of operation in Victoria. Do you find that very much higher rate of uptake in New South Wales surprising?
I'll get Dr Chant to respond to the report.
I'd probably answer this by just familiarising the committee with the fact that New South Wales was a little bit later in the adoption of the voluntary assisted dying legislation.
Later?
Victoria introduced the legislation first.
Yes.
And so the Victorian legislation is quite, has a number of prohibitive aspects of it, which means that we would expect uptake in Victoria to be less than in New South Wales.
So you're saying it's actually easier to access euthanasia in New South Wales than it is in Victoria?
There are some controls in the Victorian legislation, given that Victoria was the first state to introduce the legislation. That meant that, for instance, in that legislative model, you cannot raise with a patient voluntary assisted dying, whereas in the construct of the New South Wales legislation, you can do so provided you are provided in the context of end-of-life care with a range of
I'm familiar with the
options.
legislation, but is your comment that the way our legislation is structured in New South Wales, we should expect a higher rate of uptake because the Victorian controls are missing? Is that your comment, Dr Chant?
My comments would be that because we have the legislation in New South Wales allows clinicians to provide advice to patients so that they're aware of voluntary assisted dying where it aligns with their goals of care and in the context of providing advice around alternate prognosis and other models, including palliative care, that gives patients more awareness of voluntary assisted dying. We also have less prescriptions on how you can choose to be administered in a health facility or doctor administered the medication, whereas that is very only limited in, as I understand it, in the Victorian context, in circumstances where you can't actually take the oral therapy. So the Parliament in New South Wales has passed legislation which has probably learnt from some of the implementation challenges in other states and territories, still striking that very important balance and having a number of safeguards in place. So on that basis, I would have expected us to have a greater awareness and the implementation, I think, has been effectively done, and I'd like to acknowledge the workers in our districts and those that are part of the team that have really done a lot of work to ensure that this has been smoothly transitioned and incorporated into end-of-life care.
So you're saying that it's entirely to be expected that we have a higher rate of euthanasia in New South Wales than in Victoria?
I would actually support, that would be my view.
Okay.
Others could have different views, but I think the legislative...
And your last comment, Dr. Chant, where you talk about it being incorporated into end-of-life care. So do you see euthanasia as a pathway that's separate to palliative care, or do you see it as incorporated into palliative care?
So the way we have gone about implementing voluntary assisted dying in New South Wales is saying that it's a lawful option for end-of-life care, provided you meet the eligibility criterion, but that it is reasonable where a patient's goals of care align. So we're not expecting clinicians where a patient says they know that this patient would be clearly not, their views or beliefs or expressed intents or outcome of care be not receptive to this. We're not expecting that to be raised, but in the other context, we're saying it actually should be expressed so that patients ultimately have the choice, but that has to be framed within the legislative controls of making sure that it's discussed other options of care and palliation. And there's been a strong emphasis on making sure throughout the whole process that patients are accessed and linking palliative care. And
thank you for that explanation. You'd be aware of the figures that 2/3 of the requests came from regional New South Wales, where 1/3 of people live. Does this raise concerning issues with respect to access to healthcare in the regions and access to palliative care in the regions?
I would actually say that those figures are a testament to the staff and the implementation by our local health districts, who have worked very hard to ensure equity of access.
So you're not worried that those figures actually indicate perhaps inequity of access to underlying healthcare?
I'm not concerned about... I would be concerned if that was what I believed after my engagement with the local health districts. There's been very much... a lot of engagement with our local health districts as we've implemented that, and based on that input and the advice I've had in relation to the cases and the fact that as part of the process people actually make it sure that people have had the opportunity of linking to palliative care, and those issues have been prosecuted as part of the voluntary assisted dying process.
Thank you.
I'm confident that that is not the major driver for...
Well, the Go Gentle State of VAD report suggests that reduced access to health services in the regions is in fact a factor which drives the much higher rate of access to euthanasia in the regions. Would you agree with that?
I'm aware of that assertion within the Go Gentle report. All I can, I suppose, reflect on is the facts before me, and all I can reflect on is my engagement with the local health districts, with the clinicians involved in voluntary assisted dying. I think it is something that we obviously are very concerned about if that would be a factor, but as I said, that isn't what...
But is it a factor that anybody has sort of taken into reflect on in a policy setting? Because if you've got a situation where 1/3 of the population is choosing something twice as much as the city, doesn't that at least suggest it's an area that should be explored in terms of is there adequate access to healthcare in the regions?
So all I can say is that part of the assessment process when the clinicians are talking through this, so it's very experienced, the legislation requires very experienced clinicians to be involved in voluntary assisted dying. There's a comprehensive clinical guidance document around it. It is... The feedback I've had from my engagement with the authorised providers is there's a lot of care and attention that there are not preventable factors.
Dr. Chant, thank you, and I appreciate the detail, but the question I was really asking was, if in any other field we saw that the regions were accessing a particular option twice as much as the city, I would hope that that would be a red flag, at least for policy consideration. And when you've got the regions accessing death twice as often as the cities, I think it should be a red flag for policy consideration. That's my only question in relation to that. And I'm surprised that it's not.
And I think you've misunderstood, or I've misspoke in the way that I've answered you. Obviously, we're interested in the concept of whether people are at all influenced around voluntary assisted dying because of lack of access to some of the other.
And that's being investigated?
And as part of the process by which the board reviews the cases, there are questions about the patients accessing palliative care. There will be a more fulsome report available, but I can reassure the committee that all of those parameters are considered.
Because you would acknowledge that in the interim report, that question was not even engaged with by the board.
So the report was an interim report, and that was done because of the very strong community interest in it. I think it's important that there are a number of caveats in relation to the interim report, and we do not feel that reflects baseline. And that's because obviously there were a number of patients waiting for voluntary assisted dying. But there will be a full report as required by Parliament.
Thank you. The VAD scheme includes the Navigator service, which, as I understand it, provides information and support to patients and other community members with questions or wishing to seek access to VAD. And I'm reflecting on the recent inquiry into mental health conducted by the Legislative Council, and which flagged the importance of navigation through the health system. Is this a model which could be implemented in other areas of the health network, for example, to support patients who need to access mental health services?
I think the role of the Navigator service is quite specific. I would really have to reflect on its role, but I think the principle you're articulating that acknowledges that the health system is sometimes very difficult to navigate is a reasonable one. And throughout health, we have recognised the involvement of, for instance, peers in helping people through navigate the system, or other health practitioners as what we call care navigators. But this particular service is set up with particular skills, given the nature of the work that they're doing.
So this is not a model that could be replicated in other areas?
The concept of a navigator or someone that can assist people, I think, is you would actually find examples of this in very many other programs that we would run across the state. All I'm saying is the specific training, the expertise, the role of this group is very particular to this service. But I do support the idea of both healthcare navigators and peer navigators in appropriate context in the health system.
And I understand, because it's a mental health issue, do you have any comment about moving towards a navigation model in the mental health system?
It would be inappropriate to comment on that.
Thank you. I understand that. In the interim report, did the VAD board make any recommendations to improve the operation of VAD within New South Wales?
Not that I'm aware of.
Because my understanding was that they had advocated for federal legislative change.
Oh, sorry, I'm sorry. Yes.
And look, I was just curious about that, because is that one of the proper functions of the board under the legislation?
I think the board is highlighting the fact that the criminal code, the Australian Criminal Code, has implications for how the board does its work, and is raising that legitimately. And it's also raising how, notwithstanding the significant workarounds we've put in place, has the potential, and I say potential, to impact on access. But as you've highlighted, we have worked incredibly hard with our districts, and we've also created a central pool of practitioners that can support regional areas, and I just want to commend the work of those groups in ensuring access.
And in terms of funding, so is the money spent on VAD accounted for separately in the health budget?
It fits within the budget. It's an allocation to the districts, and we've worked with each of the districts. So there's a number of components. So there is the Northern Sydney Local Health District is the host for the Navigator service, and also supports a statewide pharmacy service which prepares and dispenses the medication. This year we have provided additional funding for a satellite pharmacy service at John Hunter.
Mm-hmm.
And what we've done is work with districts. We would aim for districts to be self-sufficient, but we have, in addition, funded a group central recruitment of authorised providers in the event to that.
So each local health district would have a clearly ascertainable line figure for
Yes.
VAD?
Yes, they've been
and a separate and clearly ascertainable line figure for palliative care?
I can't comment on palliative care. That
Who
would
could
be
help
my
me with
colleague.
I can assist. I think
Thank
Ms.
you.
Yes,
Thank you
there are
very
a
much,
separate
Ms. Wilcox.
budget item, a separate allocation in the service agreements for the local health district
Okay.
for obvious reasons. Yeah.
Thank you very much. Thank you.
Thanks. Kate Feynman.
Thank you, Chair. Dr. Chant, I just wanted to get, I think maybe it's Ms. Pearce actually. It's about preparations for the drug summit. So maybe it is you, Ms. Pearce.
I think it's Dr. Chan.
Dr. Chan.
Happy to
Is there? Dr.
Carries
Chan.
across that.
I was thinking I might be able to direct questions away from Dr. Chan at some point, but possibly not.
Yeah.
But, is
She's
there
very
a work?
big. She's very busy.
Yes, I'm
Yeah.
very aware of that. Doing very good work. Dr. Chan, is there a steering committee established for the drug summit?
So, we are establishing a steering committee, and it will also be involving the Secretary's board, but we are getting a interagency steering committee to support the drug summit from a whole of government perspective. And health is the lead, and we're very ably supported by TCO.
Okay, when's that going to be established?
We have set the terms of reference for that, and there's a paper going to Secretary's board to establish that group.
Okay, is there going to be NGO involvement, sector involvement in that steering committee, or is that just government?
So there's two. The purpose of this is largely to support government in the preparation of papers to support the drug summit. Obviously, we would expect agencies, and I would just like to acknowledge the team within New South Wales Health that has been engaging with a number of NGOs. So I would see the agencies would be engaging with NGOs through our usual processes to formulate those views. But the purpose of this steering committee is around more government processes to finalise reports for government and position papers.
Okay, so the steering committee. So in terms of setting the agendas, looking at who to invite, the various streams, what, as you just said, position papers, but what's being put forward, is that all the committee? This government agency committee?
It's a matter for government has. The government has. This was an election commitment, and this is very much led from Minister Park in terms of formulating the design. I think there was a media release last week announcing the sites and locations, and also the co-chair model. So those streams have been determined in consultation with, as I understand it, the co-chairs, and the format for the meetings are being worked through.
Okay, and the number of days, remind me, in Sydney?
So it's 2 days in Sydney at the International Convention Centre.
Okay.
And two regional sites.
The International
Griffith.
Convention Centre does indicate that a large number of people are expected to be invited. Is there an indication of how many?
I think that the government is committed to broad stakeholder representation is probably what I could say at this stage. And then the regional visits are in Griffith and Lismore, and obviously they would likely to be much smaller presence, but very important to engage regionally to understand the perspectives.
Yeah. How are those two regional places, Lismore and Griffith, determined?
They were determined by government as appropriate places to reflect rural regional issues.
So, just to be clear, was there a process in terms of calling for interested, for communities, councils, members of parliament, organisations to submit their interest in hosting a summit? Was there any formal process? in that way?
There was no formal process in the relation to the selection of those, or I can't comment on, but there were obviously a number of NGOs did advocate for various sites, but those 2 sites were selected, and they reflect, geographically rural areas. Griffith and then Lismore.
You also looking at, because the drug summit is being held in December, as in the final 2 days in Sydney. Is there an expectation of when key recommendations will come out of that those 2 days in terms of a report and a time frame?
I think those issues would be best directed to the Minister. I think there is on the record, though, the view that the chairs will do a report and summarise their findings. But the matters...
Is there a timeline? I mean...
I think this is really a matter...
Dr Chan, I mean, it is in 2 months' time is when the first regional one, those regional hearings are held, mini summits or whatever they are. 2 months will go extremely quickly, and then in another month there's 1,000 people, however many, going to the convention centre, and then there's Christmas, and then there's a big break, and then eventually, if we get back to Parliament in mid-February. The reason I'm asking is because I'm sure there is some kind of time frame established for this. The summit, the event itself, is fantastic, but it's what happens after that I think most people are concerned about. And is there a time frame? Has anything been set up in terms of a framework for what happens afterwards? Is there a report due at a particular time? Hopefully recommendations that come out of that report, which the sector is, very keen to see some recommendations. When can the sector, the community expect to see that? Is that being discussed?
I think this question, it really is a matter for government, and we'll have to take it on notice. We can't speak for government in regard to those dates and what you're asking. It's not a call that health can make.
So just to be clear, it's a question for government. Like, it's not a political. I'm not asking a political policy question here, Ms. Pearce. With respect, I've just been told that there's an interagency committee that is going to be established, and that committee hasn't even been established yet. And there doesn't seem to be any time frame for any reporting, and the time frame itself is you're saying a government decision, even though we're now at the logistics,
in the normal course of things, when there are summits or there are inquiries, the government would generally stipulate the reporting time frame for that. The Minister was here this morning. If we could take it on notice, we would obviously be very happy. I'm sure Minister Parr would be very happy to provide a response to that.
Okay, so that's absolutely fine if it hasn't been established. Doctor, that's good, thank you. Dr Chant, back to the early drug diversion initiative data and the results from that. In what way? Because the history of this is, of course, from the ICE inquiry. You're very well aware of it, of course. You then got together with the Police Commissioner, Karen Webb, to say that to all intents and purposes, I think, to make sure that there were the health services were in place, and that they would be able to. Was it 2 years ago or something, or 18 months ago? You stood with the Police Commissioner and basically said, we will assess whether the health services are sufficient and robust enough and resourced enough to facilitate a drug diversion initiative. That's correct.
That's correct. It's part of the government recommendations. There were a number of recommendations the former government accepted, and there were some that they wanted further work to be done on. Stood up with Commissioner Webb, and then there was work across the agencies to design a program that was, and then we provided advice. Both of us provided advice that we were satisfied. The components that obviously we were responsible for is ensuring that there were adequate services to support the diversion, and I think probably, I can't speak for Commissioner Webb, but there would have been operational issues around the timing and education and that needed for police. So both was like a readiness check from a health and police perspective. Is
Yes.
my recollection.
Okay, thank you. Has there been any follow-up with the Commissioner? Is there any interagency working group around the EDI that has been established?
So the EDI is going to be evaluated, and there is a evaluation plan for it. Also, as I indicated this morning, that there is interagency work. So one of the examples was a suggestion that more formal information at the point of when the cautioning, the sin was issued in a written form, and standardising what information. I did describe to you that the Service New South Wales fine does have reference to this diversion, but and any reminder if the person does not pay. There's also a highlighting this route, but we just want to make sure that the individual does absolutely know that they can access the diversion to forgo the fine. So there is a lot of operational engagement with police, and we look forward to working with police on this program.
You look forward to working with police on the program or the evaluation of the program?
On the evaluation of the program, I understand it's done by Boscar, but I'll just have to check who is doing the evaluation. It certainly will be evaluated. And as I said, there is operational intersection that I was provided with that as an example of how we are trying to problem solve if there are lack of information for participants. We are trying to make sure it's appropriate and they understand the program. As the Minister said, it's a new program. It does take time.
Remind me when you're saying it is going to be evaluated. Was it a temporary measure, a trial?
No, but I mean, as part of good practice, we want to understand what's working and what's not working. As the Minister outlined today, we're concerned if particular groups are not getting access, and as you heard the Minister read out data by Aboriginality, we're just we want to make sure that geographically there's no variation in who is being offered the access to the program. So obviously an evaluation is a really good way of looking at whether the policy intent is being achieved, and that's a cornerstone of how we want to. Much of the ICE Special Commission initiatives will be subject to evaluation, if not all of them.
Thank you. Just in relation to the First Nations comment that you made, the data obtained from my office suggests that there is a over-representation, which of course I'm sure you have access to in terms of the First Nations community who are I don't have the data in front of me, which is one, but in terms of the people who are basically diverted into the court, not diverted into the court charged. When I visited Broken Hill about 3 months ago now, I spoke with the local area command superintendent there, and they weren't aware of Eddie at all, which is not great. With Boxer and he said he would alert all of his officers to it, and seemed genuinely pleased that there was something like that available. But he said it was the first time he'd heard of it. With the Boxer evaluation, when is that occurring?
So I just need to say that I know the program is being evaluated. I just need to check what is the mechanism for that. So I will double check that just to be. But I would understand that we would need a bit of a period for it to run before we would have sufficient data. And
can I check though? Surely something is going to be prepared for the drug summit.
There would be obviously a range of information that would be presented and packaged for participants to the drug summit to make sure it was a fully informed, and that work is that work is underway.
Okay, and so back to my question before about whether there's a working group or a steering committee again around Eddie, because it was a big announcement, very deliberately, between health and police. There was Minister Catley, Minister Park, and I believe the Premier, all announcing this funding and making a very big deal of this implementation of this scheme, which was essentially going to ensure people, as much as possible, were diverted into the health system and avoided the criminal justice system for personal quantities of possession of drugs. But it doesn't seem to be working from the police perspective at so far, 6 months in. So what's the agency that's monitoring it? Evaluation is one thing, but are you both monitoring it?
Yes.
Together or separately?
So just to be clear, Boscar is doing the evaluation, just been provided that confirmation. And both agents, I am aware that both, that we are looking at some of the aspects, and there would be officer level work with police. But I think what you're raising, Ms Furman, is probably more appropriate to direct to the police minister. I'm happy to pursue this after this meeting, just to check with my own officers at an officer level with police what additional awareness opportunities there are. I think you're right, we do want the scheme to be known by officers, and I'm happy to take that on, but similarly I think it's more within the purview of the police minister.
Okay, thank you. So I am getting a bit of an impression that there might not be a formal coordinated, a formal group between that is health and police that is working on ensuring this scheme is a success, but you have committed to making inquiries with
I'm aware that there is a cross-agency implementation working group led by DCJ that's overseeing this work, but separate to that, I'm happy to take up the issue that you've raised, and clearly I'm sure that has come to the attention of us as we've looked at the data.
Okay, all right, thank you, Dr. Chen, I appreciate that. Earlier, I think you said that you had, and I'm sorry if you reported back when I wasn't here, but about the New South Wales health advice in relation to the Bowden's lead mine at Louis. Did you say you had some information there?
I did. So I can confirm that the local public health unit assessed, didn't provide any comment in relation to the mine. It was actually reviewed by the Commission, and I think it's probably important to note that what I mentioned before was looking at the exposure pathways and the actual the environmental health assessment. So basically, the Commission, who was the Commission of Inquiry looking at the environmental health...
Independent Planning Commission.
Yeah, that's correct. Found the total exposure to all metals except manganese would remain below the levels at which adverse health effects could be expected to occur. And I can provide the advice to you, but they looked at the various air, water, and its contribution to heavy metal exposure. So, and it was looked at independently. It was done by environmental consultants NRIS and validated. So I'm happy to provide a question on notice and fulsomely go through that process with you.
Thank you. And did you say it was the local health district or
the local health district public health unit? So in each of our local health districts there is a public health unit, and they would have looked at it, the actual environmental health risk assessment.
So can I just check on that? So it's the public health unit of local health districts that are responsible for doing assessments of state significant developments, major projects like heavy metals mining?
We would not...
Heavy metals mines?
We would only, obviously we're a network system, so
Sure.
the environmental, so we support our public health units, but many of our public health units have very sophisticated capabilities in this regard, but where there may be deficits, we can support the public health units. We also have an expert panel that we can call upon if there is questions around the modelling techniques used. That's a multidisciplinary expert panel. So we do work in a networked way with our public health units to provide input and support for their engagement with issues of local concern around environmental matters.
Okay. Can I go one last question before my time's run out? What has been New South Wales's health's involvement, if any, into the contamination, the PFOS contamination results, or the PFOS results in the Illawarra River that have also been in the media in the last couple of months?
Yeah. So the Illawarra River, the EPA responded to concerns from the community around that. There was testing underway. I can find the note, but basically we understand that EPA have further tested the river water, and there's been a decline in the levels in the river. We have requested...
The question I'm asking, though, because of those extremely high levels that were found, does the EPA contact and communicate with New South Wales Health about those levels to get your views on it in a formal way?
That's right, but from New South Wales Health's perspective, where they will advise us and work in an interagency way, and we really want prompt notification from EPA on any matters in relation to PFAS detection because of the issues of community concern, and being able to respond to those. What we have done in relation to that is looked at where water could be taken off in the sort of groundwater distribution of the river and further downstream. And so we are working with those local water utilities to make sure that we've got testing, just again to provide that reassurance to the community. So just to be clear, this was in river water and not reticulated water supplies. We are looking at all the downstream water supplies just to make sure that we understand PFAS exposure in those contexts.
Okay, thank you.
To the opposition.
Thank you, Chair. Thank you all. As we fly through to the end, can I ask about GPs and payroll tax? I'm not sure, Ms Pearce, who you might direct that to.
Probably Mr. DeMarshall.
See how we go. See where we go with that. Can I just ask what the current unmet demand for GPs is in New South Wales?
Well, I don't think I can answer that question. If you want some advice in regards to the GP and the payroll tax, probably not a portfolio that controls the policy from the financial point of view. In respect to GP and GP numbers, probably is not me as a CFO to provide.
I think we would have to take that on notice.
The current unmet demand for GPs?
Well, we don't control the GP services. I don't know how we would assess unmet demand for GPs.
And how many full-time doctors that might be equivalent to? I might help you. The last report by the Department of Health and Aged Care has a shortfall in New South Wales of 460 full-time FTE equivalent.
So that's a Commonwealth Department.
Right. So
not the State Department.
Certainly, but you don't have a...
The Commonwealth Department would have a view. The Commonwealth
into
Department would have a view because they are, Commonwealth is responsible for primary health care.
Sure. So, but we don't have any oversight or import or any care or concern about that
we
in
make
New South Wales?
assessments, I suppose, at a geographical level.
Yeah.
And it's probably a little bit more in reverse for us. What we're assessing is the impact on our services, for example, the number of emergency department attendances that we might consider. And this is not, I can't throw a blanket across this, Ms Ward, and say that this is a uniform picture because it's not. That we would make assessments if we're seeing GP-type patients presenting to our emergency departments. I mean, there's a lot of work going on in the state in terms of our in-reach into primary care with urgent care services and the like. really quite significant work that the state is funding. I think it was $134 million to fund those types of services that would otherwise be provided by general practitioners. So we do know, and I mean it's been felt across the country, there are significant issues with the provision of primary care and the number of GPs and the number of doctors who wish to enter their career as a GP, and I know that there's a lot of work around that because obviously that's in everybody's best interest.
Certainly. All right, I might just get to some others, and if it's not within your purview, whether you're able to take it on notice or let us know if it's something that you have some oversight or some input, some data on. So would you have any data about the number of medical practices, understanding that Medicare is a federal thing, but that the medical practices that are currently bulk billing versus not, and how sort of a rebate might lead to a change or an increase in the number of bulk billing practices? We're sort of looking at the issue of ranging
look, I
visual
think
issue.
that we would have to take that on notice. It very much, the questions you're asking very much sit with the Commonwealth.
Yeah, I understand that. But is there any measure that the state government has to identify if or how many medical centres have reduced fees?
Not that I'm aware of.
All right. Are you able to take that on notice and see if there's anything you do yet? Yeah, certainly. Yeah.
Is one of those indicators the uptake at the urgent care clinics that you're opening?
Well, in part. I mean, again, it's and I'm not trying to, evade the question here.
No.
It's not a perfect science. There is, there's always latent demand sitting in our system, and so when you commence a new service, you get some uptake of that. We do know from previous examples, which is why we've gone down the road we have with a sort of a single front door that we've created to enable people to access primary care services via that. We know in previous times when urgent care centres have been attended, they don't always attract the type of patients that would otherwise go to a GP and or an emergency department. So it's not a perfect science, but we do know, look, out of our triage categories 1 to 5, triage category 4 is the by far the biggest number. About 1 million patients a year present in triage category 4. Our emergency department physicians would argue that not all of those patients by any stretch should have gone to a GP. There are many of those people who get admitted to hospital. So it's difficult for us. Look, and I think to be fair, Minister Park has advocated very strongly around the provision of primary care and also other issues associated with the Commonwealth around aged care, the NDIS and so on.
Thank you.
That the state is now stepping into.
Thank you. I might just turn to elective surgery and the elective surgery wait lists, Ms Pearce. In 2022, the former coalition government, I'm sure you know, announced $408 million over 2 years to enable additional elective surgeries. Did the government now invest any additional money on top of that in last year's budget or in this year's budget to address that issue? And can you tell us what that additional investment was?
The $408 million that you refer to, which we're very grateful to have received, substantially was used to drive down some of the overdue patients that had arisen as a consequence of the pandemic. I think at one point in time, because of the enforced slowdowns of non-urgent elective surgery, we had something in the order of 19,000 elective surgery patients who were overdue. And so there was that investment. The current government focus on this, and particularly with our task force that was established, made up of a large number of expert clinicians as well as people from the ministry.
Just bring you back, just to the funding though is what I'm concerned about.
Well,
so has there been additional funding in this year or last year?
I guess I'm trying to make the point that the additional funding was specifically provided to deal with the consequence of the pandemic.
Yes,
the state
spends around. Can I just get to this budget though, and the last two budgets?
The consequence that we were dealing with the $408 million has been dealt with. So the state.
So is the answer no? It's just, is there additional funding or not?
The state spends around $2 billion a year on elective surgery, year in, year out. The 408 million that was provided was on top of that to deal with around 19,000 overdue patients, which we've successfully reduced.
But has there been any additional funding?
The additional funding was required for the pandemic consequence.
Okay, to be fair to you, to understand your evidence to be, there has been no additional
We've
funding.
returned to sort of a business as usual budget arrangement.
Okay.
So,
So there has not been additional funding in those two budgets to specifically address elective surgeries.
I think
Is that
there was some additional after the 400. I just can't quite remember.
It was the cash flow, the 400.
Yeah.
There was also allocated in last financial year. So where the final quantum of the 400 allocated from the previous budget was allocated into last financial year, being the 23-24. And at that point, as the Secretary has mentioned, we have reduced the overdues, and therefore we were on top of the...
Understand all that.
Okay.
It's a really simple question. Has there been, other than the 408 additional, and I'm just going to be fair to you, put it to you, but it seems like it's no.
In this financial year, there was an allocation in regards to additional activity for population and aging as part of the measures. And
elective surgery?
That includes activity overall.
Okay. Well, can you tell us, Ms Pearce, why then there was a sharp increase in people on the wait list in the December 23 quarter, which contrasted obviously with months of improvement of that list?
So the consequence of slowing down non-urgent elective surgery during the pandemic meant that people who were scheduled for surgery increased, and some of those people who were scheduled for surgery were overdue also. So I'm sure one of my colleagues may be able to assist with the number on the planned wait list now. Please, look, this is an issue that always comes up about the elective surgery list. All of those people on the list are planned to have their surgery, and it should not be interpreted that they are overdue for that surgery. So a number gets reported, but those people are scheduled for their surgery. We put thousands of people on a day. We take thousands of people off. So the number has reduced for those planned to have their surgery, and the number of people overdue has reduced.
So, all right, so it's reduced in what context in relation to the, there was obviously the increase in the December quarter. It had improved and gone down. It increased in December, so it's improved in relation to what?
At the end of June 24, the numbers came down to 1859 as overdue.
Okay.
And the number of people on the surgical wait list, Jodie.
All right, so I just want to be clear about this funding then. So just to be absolutely clear, did that coalition funding to clear the backlog from COVID for elective surgery, did that funding finish in December?
It's finished, yes.
Right, okay.
That's it.
And then, so did the numbers of surgeries being outsourced to private hospitals, that stopped in December also, is that correct?
That was the original plan, as part of the funding envelope were available then.
Okay.
That's specific for the catch-up.
Yeah, so there was catch-up, the money ran out in December, and that was the end, and there's no more.
Yeah.
So there was still some surgery done in private facilities.
I'm interested then why it seems that there's been credit taken for the surgery wait list when it doesn't seem to be the accurate representation. It seems to me that the Minister's taking credit for reducing elective surgery wait lists, but the fact is the COVID backlog was funded by that funding. That money has run out in December, and there's no prospect of that being reinstated.
There was a long way to go from December. Look, I'm not going to speak for what the Minister is taking credit for otherwise. I think the data stands on its own feet. From the start of the financial year, 1 July 2023 until the end of the financial year, June this year, the number of people overdue for their surgery, I think we started the year, or the government might have started its term, I think we had 14,000 overdue patients. By the end of this financial year just gone.
Yeah.
So they'd obviously been in government by that stage for more than 12 months. We had reduced that number down to pre-COVID levels.
I might come to Milton Ulladulla Hospital. Who might answer?
What was the specific question?
So there was a commitment from the government for $7.5 million to provide a new CT scanner, an upgrade of the Community Cancer Services Centre. Has the CT scanner been installed?
Look, I don't know. Yep.
Yes.
And Emma,
sorry.
The work's in progress. So it is a project that Health Infrastructure is providing support to the district in delivering, and we're currently planning that project.
Thank you. Is that in relation to the Community Cancer Services Centre?
The CT scanner I'm referring to.
So how's the work in progress for a CT scanner? Either it's installed or it's not, isn't it? Or is there other work?
In relation to installation of a CT scanner. So ordinarily there's capital works associated with that because there's requirements for example, the weight of the scanner, etc. And there's often modifications to be undertaken.
All right, so how far away is it from that hospital getting the CT scanner that was promised 18 months ago?
I do not think I've got that information here, but I'll check, otherwise I'll take it on notice.
Okay, and has the upgrade of the Community Cancer Services Centre been complete?
No, I'm aware that there was some funding allocated for some upgrades, but I don't know the status of
Could you
those.
take that on notice?
Take that
So
on
that's
notice,
been
most
completed?
definitely.
But certainly funding has been committed.
Yep.
All right, and where are the birthing services returning to Milton Ulladulla? Where's that project up to?
That's the subject of the clinical service plan, which is work that will be underway. My understanding is that there'll be consultation starting this month, as in September, with community consultation to have input into what would be the health service plan, which would include discussion around maternity services. So that process will run.
So there's a plan and discussion. Is there funding in place?
I'm not aware of the funding status, but what we would normally do is work through the clinical service plan and work with the local health district in terms of what their budget is and their priority setting for that. And if it was something, maternity or otherwise, they could come forward as part of the normal budget enhancement process and seek further activity to provide it.
Just to be clear though, as at today, you're not aware of funding allocated for return of birthing services at
There is
Milton Ulladulla
community consultations commencing this month for Milton, and the clinical services planning that Ms Wilcox has referred to will be part of that consultation.
Certainly, that's
process.
consultation, that's discussion, it's a plan, but is there funding in place for birthing services at Milton Ulladulla Hospital as at today?
Well, I think until we determine what the nature of the birthing services are, you can't, you can't do one without the other.
Sure.
So once we resolve the issue of what form the birthing services take there, then the funding obviously would need to be contemplated in that regard.
Okay, I have a couple of regional questions.
Can I jump in just with one question first? Ms Pearce, I just want to go back to the payroll tax and the incentives for bulk billing. Just trying to work out what's the mechanism by which you're going to track the clinics for bulk billing so that they can attract the payroll tax rebates?
If I may, we don't control the policy, therefore we're not able to track the GP practices that actually meet the threshold, and that is done by Treasury and Revenue New South Wales, so we have no visibility of the payroll taxes.
Okay, so Treasury will do that, and it's their mechanism for tracking?
That's correct.
All right, okay, thank you. Great.
Yeah, did you say that's the first one?
I've done the first one.
Okay, thank you. So we'll just return to the regional vacancies, and so how many vacancies in the regions have been filled by agency nurses? Sorry, overall, how many vacancies have been filled by agency nurses?
Might get Mr Minns to comment.
Was
in the regions.
No, sorry, across New South Wales,
Across
and
New
then of those, how many are in regions? Regional New South
I would
Wales.
have to take it on notice.
Is there anyone able to
I
get a
can take
number
it on
on how
notice.
many vacancies have been filled by agency nurses?
Not quickly, no. But we'll be able to get some kind of answer for you.
If you're taking that on notice, are you also able to provide a breakdown of whether filling positions by agency nurses has a higher cost than filling them by regular employment?
We should be able to use the budget system to answer that.
We can. You might want to make a comment about the retention rates.
Yeah,
That's okay, we'll get to that. I've got a few questions to get through, so if you're
We
not...
talk about premium labour, so in its title we recognise that it's more expensive than normal labour.
Do you want me to... all right, so then how many, in the 2023-24 financial year, Mr Minns, how much did New South Wales Health spend on agency nursing contracts across New South Wales?
The Chief Financial Officer is advising me 115 million.
Could you speak up, I'm sorry?
115 million.
Thank you. And what's the breakdown of that spend across each of the health districts?
I'd have to get that on notice.
And you will take that on notice?
I think we will have that. Yep.
Right, so just to be clear, you are coming back to the committee with those numbers?
We will take it on notice.
Thank you.
Yep.
All right, and in the 2022-23 financial year, how much did New South Wales Health spend on agency nursing contracts across New South Wales?
That year it was 152 million.
Okay. And what's the breakdown of that spend across each health district?
We should be able to get it. Yeah.
So you'll take that on notice?
Yes.
We will. Can I just add some context though? Look, we
Just
have
bearing
to,
in mind, I've got 1 minute left.
Sorry, but we have to
That's all right.
acknowledge the impact of the pandemic with these numbers.
Sure.
You're comparing apples and oranges.
That's okay, you can put that in your answer. You're most welcome to put what you like in there, but we're just after the information. if
And
that's
we've
all right with
also
you.
done some work to restructure the contracts for nursing agency labour, so we'll put that in our response as well.
Thank you, Mr Minns. Can you advise how many patients in the Murrumbidgee Local Health District and Western New South Wales Local Health District travel for renal dialysis, and how many are assisted at home with those numbers?
We have to take that on notice.
Okay.
Because it actually changes.
Sure.
So some people will be travelling to do it. Other people, when spots become available, will be put into those spots so they don't have to travel as far. But I'll probably also just mention that anyone that does travel, we support them through IPTAS.
Okay, if you can provide those
Yep.
3 options or however many you have, that would be helpful. And then of those patients, have we asked the IPTAS? No. Okay, so of those that travel in both health districts, how many are assisted with IPTAS, IPTAAS?
Yeah, we'd only be able to give you how much IPTAS we provide to patients as a whole for IPTAS. I'm not sure whether we can provide the actual breakdown for their treatment because it's one of those things that we might not be able to pull out specifically because we're just providing it for the actual accommodation and or travel reason.
Can you provide a list of ambulance stations, Mr Morgan, thank you, with that are understaffed in each electorate, or however you divide them by postcode or by each area in regional New South Wales?
I can actually tell you we're over across the entire state. We actually have 55 additional paramedic positions, paramedics employed for the number of positions that we have.
So in every electorate you're overstaffed?
We don't count numbers by electorate.
Okay, how do you count them? By
sectors, which is 8 divisible areas, 4 within the metropolitan
and they're all
area, 4
overstaffed.
within regional. Actually, there's -1 in one area of regional New South Wales.
All right, could you provide that breakdown by those areas as you define them and what the numbers are?
Sure.
That's great, and if that's a good story, that's great. All right, thank you, Chair.
Thank you. My first question is for Dr. Chair. I was quite alarmed by the MPOX alert that was issued for GPs yesterday. So that said that there'd been 236 cases confirmed in New South Wales, including 13 hospitalisations. Compared to national notifiable surveillance from last year of 12 cases, that's obviously a huge increase. Can you please advise what's being done in response?
So as you indicated, we've certainly, the mpox of the particular clade 2B caused a worldwide sort of situation outbreak in 2022. We had much lower levels last year, but this year we've seen 220. You've got the more up to date from the clinical alert, because mine was the 6th of September. What we've established is an outbreak management team. It's meeting 3 times a week, and we've got public health, sexual health laboratory and communications expertise.
we really need to work with our partners, and that part of it is the GP alert. So we've got a webinar with the RACGP on the 30th of September. One of the key issues is that the symptoms can be actually quite easy to not pick up as MPOX, so it really is important to raise the awareness amongst our primary care, as well as we've done some work with our own ED staff and others to make sure that regardless of the presentation or the presentation site, that we recognise and diagnose MPOX as early as possible. Also, we're doing, obviously, increasing our vaccination efforts, and we've made a lot of extra slots at really user-friendly times available at our sexual health clinics. We've also got planned outreach to our sex on premises venues planned, and we've also got some pop-up vaccination clinics in particular sites such as Green Square. Just want to acknowledge that we're working really closely with our community partners, ACON. ACON's really upped its community engagement with printed materials. They've been shared with sex on premises venues to promote awareness. We've also translated our MPOX fact sheets on the New South Wales Health website, and also continued social media posts across New South Wales Health platforms. So we are leveraging off our partnership. It really does require a whole sector response. Vaccines don't absolutely stop you getting the MPOX, but they reduce the risk of you acquiring it, and also perhaps make you less infectious, but what's most important is you're not got a severe disease, so you're very unlikely to be admitted to hospital if you've had those two doses of the vaccine. We are aware that a number of people had the one dose, so we are urging people that haven't had the 2 doses to get vaccinated.
That's great, thank you. I'm glad that so much is being done. Can you advise, in terms of the geographic spread of that current outbreak, is that mostly in Sydney, or are we starting to see cases in regional New South Wales as well?
We have seen cases regionally, but the sexual transmission is particularly in our gay and bisexual men, but we are recognise the network. So we don't want to stigmatise this group. It's important that we have that support health-seeking behaviour. We have seen some regionally, so it is around awareness more broadly of MPOX.
Okay, thank you. I'm going to come back to Albury Hospital. I know, Mr McTaggart, you've been sitting there very patiently all day and you haven't had a question yet. So these might be for you, and they might be for health infrastructure, but particularly Mr McTaggart, I know you were part of the project control group for the Albury Hospital redevelopment in your previous role. I asked the Minister about the decrease in the point of care projections this morning, and I am genuinely seeking to understand things like the ICU figures. So I'm going to jog your memory because I've got it in front of me and you probably don't. So at the moment it's 8 beds of COO and 4 beds of CCU, so 12 beds. The 2021 clinical services plan projected a need for 20 by 2030. Then the 2022 clinical services plan review projected a need of 14 beds by 2032. But what eventually got approved was 12 beds, which is the same as now. The Minister gave this very confusing answer this morning about, hospital in the home and virtual care, which can't possibly replace intensive care beds. You were a part of that process. How did these point of care projections get whittled down?
I guess Dr. Con, as I said at the last budget estimates, some of those calculations that were prepared by Albury-Wodonga at the time were never ratified by either the Victorian or New South Wales state governments. I think it's the 23 CSP where the figure of 12 ICU beds was agreed to by both state governments and Albury-Wodonga Health. During the lunch break, we made a call to the CE of the Albury-Wodonga Health. Currently 5 ICU beds are being utilised by Albury-Wodonga Health, with the others being CCU and HDU. So the 12 beds that have been agreed to not only by New South Wales, but Victoria and Albury-Wodonga Health, plus the board of Albury-Wodonga Health, will be a full sort of fit out of ICU beds when they are built.
So that 12, does that then include HDU and CCU beds, or are those additional to the 12 ICU?
They'll be additional within the clinical services building of the additional more than 80 beds in that building.
Okay. My other question is, as I'm sure you're well aware, we passed 2 orders for papers through the Legislative Council on this subject.
Yes.
Which uncovered, amongst other things, a brief written by yourself to the former Treasurer. And in that brief, you wrote that a risk associated with a new hospital on a new site would be that New South Wales might not have operational control of the hospital once it was built. Did you similarly advise government that with a brownfield upgrade as currently planned, New South Wales still won't have operational control of that hospital?
Can I just take a point of order? Just in terms of the documents that quotes come from, I'm just wondering whether it's appropriate that there is some context around that. It's a quote from it, and I understand that. But I think in fairness to the witness, and it's obviously a time ago, it would, in my submission, be proper to enable himself to understand the full context around which that statement was made. Perhaps take it on notice if he needs to do so, but, and I'm not trying to block the question, but it was a time ago, and I think he needs...
I appreciate your comment. I'd like, if Mr McTaggart is happy to answer it, I'd like the answer. He's of course welcome to take it on notice, and I'd be happy to provide that specific document as well.
I'll take it on notice, Dr. Con.
Okay, thank you. I'm also, I have some questions about the helipad. This might be for health infrastructure now. So the most recent version of this master plan, what are you calling it? The concept design plan that just came out last month removes the helipad at Albury Hospital. We had a helipad when I was a medical student in Albury. We had a helipad for years, and that was removed during the peak of the COVID pandemic, when there was a temporary, basically a tent set up outside the emergency department for triage. It was an emergency, and of course that had to be done. Since then, it then got subsumed into the construction site and then the new ED, so that space is gone. I suppose, are you aware that the helipad was removed, but also that Air Ambulance Vic, who do retrieval from Albury to Melbourne, have opposed the removal of the helipad?
I am aware that the helipad is not in the scope of the redevelopment now, and the images, the concept images that you've referenced, it's correct that the helipad is not in the current project scope. However, we are future-proofing to enable a helipad at the site in future if required.
And to clarify, that future-proofing, is that a helipad that's part of the car park?
I would have to take that on notice.
Okay, thank you. Look, in taking it on notice, I'll read to you this. So this is also from the documents. I'm reading from an email from Air Ambulance Victoria. And the direct quote is, "I think the days of any aircraft landing in the hospital car park are over, and we need to be purpose-built pads well away from ground level to future-proof them." So my concern is that the previous draft of this redevelopment had a helipad on the top of the new clinical services building. My understanding is it's now proposed to be in the car park again, but I appreciate that you've taken that on notice.
Yeah, and I guess just to comment in terms of the advice that we take, we do have engineers specifically that provide advice on the design of helipads that would feed into this, and we would be ensuring that we were receiving that advice through this process.
Okay. Thank you. And can you explain the rationale with the cath lab? So this is another one that I asked the Minister about this morning, and now that we're perhaps not as heated, we've currently got a cath lab plus a shell. What's the rationale in actually removing that capacity for expansion and going back to only one cath lab?
I think the comparison of old to new is quite challenging here, because often just comparing number for number doesn't represent the new models of care that you're able to implement when you enable a new facility. And so overall, in this project, we're doubling the square metres in the hospital. In relation to the cath lab specifically, we are replacing the one with one in a new facility that will be a new, I guess, contemporary cath lab. Our understanding, based on discussions with the local health district chief executive, is that cath lab currently operates 2 days a week. And therefore the future proofing for that cath lab we have deemed, in the scheme of the priorities of the project, not to be required. However, when I mention the new models of care, the cath lab will be accompanied by also 2 procedure rooms, and also one of the theatres will be an interventional theatre that will be able to support procedures, so that the suite of facilities will support new models of care in relation to that.
Sure, and when you say it's only being used 2 days a week at the moment, I mean, because of the capacity issues at Albury at the moment, a significant number of patients requiring interventional cardiology are taken to Melbourne. You can have a heart attack on the main street of Albury and be taken to Wagga Wagga, not to Albury, because of our capacity issues. Have you taken that into account when you're looking at figures like it only being used 2 days a week? If we had enough wards in our hospital, I imagine that it would be being far more utilised.
Yeah, I will take that on notice because it's a specific service planning question, but I will say that those facilities that I've just referenced in relation to complementary to that single cath lab should be delivering a model of care that improves that in line with the clinical services planning.
Thank you. And similarly, in terms of the underutilisation of the cath lab, I have a really similar question with the helipad. I appreciate you'll take it on notice as well. In the correspondence in the documents, there's a statistic quoted about the number of retrieval transfers out of Albury being done by fixed wing. Obviously, that's because we had a tent set up across the helipad in the car park during COVID, so I'd really appreciate a clear understanding of whether that was explicitly taken into account or whether the assumption is, well, they haven't been using the helipad, therefore they don't need the helipad.
Yeah, I'll link that back to the previous question on notice, but I guess just to note that we've had consultation with New South Wales Air Ambulance in relation to the advice on the fixed wing aircraft transfers.
Thank you. And to clarify with Victoria as well, and I know that sometimes there is retrieval from New South Wales, but the majority of our retrievals would be going to Melbourne.
I will confirm that as part of that question.
Thank you very much. I wanted to come back to the subject of medication shortages. Ms. Pearce, let me know. So we had a good discussion with the Minister this morning, particularly around the IV fluid shortage and also PrEP shortages. But obviously, you know, there's 400 medications in critical shortage at the moment. Is there anything else happening on any of those other medications?
So our Clinical Excellence Commission has a process of monitoring medication shortages, and it's also been pleasing to see that the TGA has taken a much more active role. I think this has obviously been highlighted through the COVID pandemic, the supply chain issues, and largely we are as a small market relative to other countries. More globally, I know that there's been discussions around having more on-site manufacturing capabilities, particularly for medicines that are in international shortage or are off patent, to give us a bit more self-sufficiency. But we do have a process whereby the Clinical Excellence Commission, and there's a protocol that underpins this, assesses the risk to the system. And in general, we're more focused on our system, as in the healthcare system. Occasionally, there will be medications where there's medication shortages in the community pharmacy setting, where for particular reasons we might want to act. And so, for instance, that was the case in relation to PrEP because of its preventive components. The things that happen are we usually look at how we can get Section 19A exemptions or advocate for the TGA to take, to fast track their approval processes for other medications. We're quite a large, one of the advantages of being having health share is that we're a very large procurer, and so we can actually come in quite quickly and try and look at alternate products that can, or alternate formulations. We then bring clinical groups together to look at advice for the system about how we might move, and sometimes those things actually bring safety risks that we actually then have to do additional training, say for instance in products that might be able to be administered in one way but can't be administered another way. So it is complex, and look, the health system, this is an emerging issue that's probably been exemplified, exacerbated during COVID, and I don't think there's any signs of it getting better. So I think it's probably something we've got to work with our other colleagues in other states and territories and the TGA and nationally around this issue.
Thank you. I had another question for Dr. Morgan. Sorry, if I can find my bit of paper.
Chair, I can actually give those figures now. If
We might do it once my time is once my timer stopped. Thank you.
Yeah.
Yeah.
Do it at 5:15.
Yeah. So I understand that there are psychologists employed by New South Wales Ambulance that are available to paramedics that they're encouraged to use, which is excellent, for the record. I've heard that some paramedics have had challenges with those psychologists not able to provide records or reports to other external psychologists or health services if they end up seeing another provider. Can you confirm if that's the case?
So they don't do therapy per se. So our staff psychologists don't have ongoing therapeutic relationships. They'll do an assessment and make referrals. So I'm not quite sure what records they would be referring to.
Sure. Look, I imagine in that scenario, results of an assessment or the record of that assessment.
We wouldn't do an assessment per se. It's large. There's 12 of them for a staff of nearly 8,000. So their role fundamentally is to determine is this someone that needs ongoing psychological therapy, as distinct from someone who has experienced a traumatic event and can be linked up with peer support or chaplaincy, that sort of thing. So there wouldn't be a record per se of an assessment.
Okay, so is the challenge that I'm hearing about with records being transferred, it's that record doesn't exist in the first place?
I would say that not a clinical record, not a therapeutic record. I'm absolutely sure that they would say, I've met Tim to discuss this difficult case, but there's not a clinical record in that sense.
Okay, thank you.
Maybe the safer way for me to do it is I'll check with the chief psychologist as to whether there's anything, any sort of clinical record. Might be to do with workers' compensation, but I'd be speculating. So I'll check.
Thank you for the thoroughness.
Yeah.
I have also had it raised with me the incident management system, and of course paramedics are encouraged to raise complaints or concerns through that system, which is good. The issue that I've heard is that there's never any time in the shift to do it, similarly to the missed breaks issue, but that it's not a given that they'll have overtime approved if they want to do that activity at the end of their shift. Can you provide some clarification around that? Should paramedics be getting paid overtime if they're completing incident management reports?
Paramedics are always paid overtime to complete their duties, and reporting incidents are absolutely part of their duties in a timely manner.
Great, thank you. My last question in my minute and a bit remaining, I think it's going to be a question for Ms Pearce. I asked the Minister this morning about the sustainability initiatives. We were talking about the really excellent work that Hunter New England is doing. And I understand that in other areas of New South Wales Health, there are various bits of good sustainability work happening, but it's quite siloed. Have you ever given consideration to having a chief sustainability officer similar to a chief procurement officer, someone who ties all of those bits of work together?
Look, I'll get the correct title for you, but we do have that position.
Okay.
And I wouldn't say the work's siloed. Actually, I think the work is exceptionally widespread. Mr D'Amato commented this morning, I think you'd use the great example of the LED lights. That was something actually that Alpha drove through the system right across the state and encouraged all of the districts to take up that initiative. We have targets as well toward net zero. So, as I think the Minister made the comment this morning, we are sadly a heavy contributor to carbon emissions. So we've got lots of work going on across the state. So it's certainly not confined to Hunter New England. I can confirm that. Happy to provide you. I'd be very happy to provide you with more information on this, because it is something that, as a system, what we're trying to do is twofold here. One is obviously reduce our impact on the environment. Secondly, there's more than twofold. There's many aspects to this. We had a presentation from the Chief Environmental Officer from the NHS, who in fact is an Australian doctor who's working over there. The positive impacts of the work we're doing is that it gives staff a sense of purpose and hope for the future, and their contribution to what they can do. It also helps to improve patient care, and at times it also saves money. So, that's not the main driver of the work that we're doing. It is an outcome at times of the work we're doing, but there is a lot of endeavour, and we do have the wonderful Dr. Kate Charlesworth, who's leading up our net zero unit within the Ministry of Health.
Thank you. And
right
can you just
now.
clarify if Chief Sustainability Officer is not the correct title? What is the
I'll
correct
get
title?
her title for you, but certainly there is a team there, and it's headed up by Dr. Kate Charlesworth.
Okay, thank you.
And my understanding is that her title is the Senior Advisor of the Climate Risk and Net Zero Unit at the Ministry of Health.
Okay, thank you. I think Dr. Morgan was trying to update us during my time there. Well,
Can you do it in government time? Because we've got a
We've
couple
done
more
other
questions.
committees.
Oh, sure.
I'll ask if
Yeah, okay. You for 2.5 minutes? Yeah, okay. You can have 2.5 minutes.
Thank you. This question's probably to Dr. Morgan and also to Ms. Pearce. The government responded last week to the inquiry into mental health and supported recommendation 33, which essentially deals with health-led responses to mental health emergencies along the lines of PACER. And I suppose my question is, has the work to develop the appropriate response begun? Is there a timeline to that, and who's involved in that work? And while that work is continuing, is there funding to continue PACER? And in fact, is there even an opportunity? I understand there's only 16 PACER clinicians. Is there an opportunity to expand this while we're waiting for this new model to be developed?
If I could get Ms. Wilcox
Yeah,
to
thank you.
respond to
Yes,
that. Thank you.
Thank you.
Thanks very much. Thank you for the question, Ms. Carter. We've been working with New South Wales Police. The Secretary and Commissioner Webb have agreed that we would, some of us, senior team have been nominated. I'm working with Assistant Commissioner David Hudson, with Dr Murray Wright and Brendan Flynn from the Mental Health Branch. Quite rightly, the police have raised concerns about the number of call-outs to incidents where individuals are demonstrating behavioural disturbance. But as you would understand, from a health perspective, we would want to make sure that we wouldn't be sending mental health staff into undifferentiated, high-risk environments. So what's the coming together and what's the compromise in some of the things we might consider? We've started some work already with police to try and mitigate the number of transports that they're involved in and time spent in emergency departments to hand over a consumer or an individual with a disturbance. So that work is underway. We have a statewide group of our mental health directors, and we've been talking with them about what might be some other things. We're going to reasonably quickly to support our colleagues in the police force while we do a longer piece of work around what might be a new model, or what might be a combination of models, which could include PACER as a complement to what else we might do, which might mean mental health clinicians in a call centre, for instance, when calls are taken. And already we've got some models where there can be, in southwestern Sydney, for instance, a call back to a mental health clinician to get advice.
And is there a timeline and pace of funding pro tem?
There's a timeline to our work, this new work with the police, and that would be to get a paper to government by the end, or through the Secretary and the Commissioner by the end of the year for government to consider. Any discussion then around what might be the resourcing required would be factored in once that policy position was taken. And yes, you're quite right, the PACER model is very popular and tracking well. We are going to put that into the mix to see what would be the right combination. We want a fair bit of consistency across the state. Obviously, people are calling 000. You wouldn't want a lot of models running, so that's the work we're doing with Commissioner Morgan as well.
And the PACER model is currently funded?
Yes.
Great.
Thank you.
I'll use my last couple of minutes to ask a question of Mr. Sloan, which is about relocation of health workers into rural and regional areas. There's a lot of discussion around financial incentives, but I'm interested in the non-financial incentives. For example, there's a really excellent program I've come across, which is the Attract Connect Stay program in Glen Innes, that does things like finding good schools for kids, jobs for spouses, suitable accommodation, pet adjustments, whatever else people need. And I know there are some local health districts who have a concierge service that's providing something similar. What's the status of that kind of work?
Yeah, so we have a whole range across all the 9 regional local health districts, and that's in addition to the Department of Regional New South Wales, or previous Department of Regional New South Wales's the welcome experience. So some of our districts are very much participants in how that was set up with regards to all those things you said. So the social community warm hug of arriving employees to be able to track them. At the front end of it, we've got a pretty significant communication plan that really puts it out to all clinicians or people that are interacting with New South Wales Health about the the good atmosphere of coming to live and work in regional, rural and remote settings, and that includes people who have made that choice as well. In addition to that, we've got accommodation that we're rolling out across the state. Many of the districts have accommodation allowances for people who are relocating in order for them to get set up, and that's enveloped in part of our key worker accommodation program that we're continuing to roll out based on previous funding and new funding that's been allocated as well. And as I said, all of the districts have some version of the concierge service or a welcome to town or welcome to city service that may not be done as a whole district, it might be done as one community, depending on what the resources are placed in those communities.
Okay. And is there a role of local government in any of that work?
Yeah, absolutely, and it's varied. I would have to say, again, coming back to the whole place-based sort of thing. Some of the local governments are extremely involved in attracting, providing other bonuses through accommodation or building houses themselves and really investing. I could name a few, but I don't want to throw shade on any of the other local governments. But there's quite a few that are actually.
Can I let you take it on notice and then you can not get yourself in trouble?
Look, I'm not going to reach out to every local government and say, do you have a program in place? I could only quote the ones that I would actually know now that do have it, because we will work with the local health districts to ensure those programs are in place from New South Wales Health
absolutely.
point
So
of view.
I can reframe my question. Can my question on notice be which local government areas are working directly with New South Wales Health on those kinds of relocation programs?
Yeah, I'm happy to take that on notice.
Yeah, thank you very much.
Dr. Con, can I just round out the sustainability thing? One of my colleagues has just pointed out the obvious thing to me. Dr. Kate Charlesworth, that I mentioned, actually reports our Deputy Secretary is the DepSec for Systems Sustainability and Performance. So we've also incorporated the sustainability in one of our Deputy Secretary titles as well to, give a nod to the importance of that work.
Thank you. Dr. Morgan's been waiting patiently.
Yes. I can, in response to your question, they don't do clinical assessments and any consult records aren't released without client consent. Okay. So if there's any individual cases that you want me to have a look at, I'm happy to take it out of session, but it sounds like the system would be that they just would normally, with the paramedics' consent, release it.
Thank you.
Yeah.
I'll take that offline.
No worries.
Are there any questions from the government?
We'll have to ask Mr. Slane to elucidate on the Warm Hug program. It does sound like a very inviting program, but and whether it has application here, potentially at the New South Wales Parliament.
Yeah.
But in light of the time and the great patience everyone's displayed today, and thank you on behalf of the government for the excellent evidence you provided, I'll put the question on notice.
Thank you. I just will say that was metaphorically a statement. It's not an actual program, and if you want to copyright it, you absolutely can. But the premise of the community coming together around
I appreciate the clarification. I may well have used it beyond this hearing without the clarification. So
that's fair.
Were there any other answers on notice that people were burning?
I am just able to answer that Lot 4B question about Royal North Shore. So this is a statement from the Northern Sydney Local Health District and as it relates to their master plan that they've provided. So Health, in line with the master plan, proposed an integrated development for Lot 4B and the adjoining health-owned land. The proposal included a residential development with a significant portion of key worker housing, a minimum of 30%, and complementary health services, particularly research and education facilities, on the adjacent health-owned land. The current proposal from the Department of Planning, Housing and Infrastructure is for a standalone residential development on Lot 4B with no enhanced access or amenity for the health precinct and a target of only 10 to 15% for key worker housing. And there are also concerns that there's insufficient parking and traffic provisions within the existing proposal. The scale of the proposed development is also not aligned to what we recommended.
Thank you. That's very helpful.
Okay, I can give those statistics. Hunter New England sector is 705 position FTE, plus an additional 62 that have been established but not yet operational. So they're 3 new stations we're building but haven't yet started. And assignment staffing, so the number of people employed, 724.99. So Hunter New England is 19.99 over. The North Coast is 585 positions, 612.63 paramedics employed. That's 27.63 over. Southern New South Wales, 879.29 established and 894.94 employed. That's 15.65 over. And Western New South Wales, 425 positions and 421.54 employed. So they're short 3.46. For a total across New South Wales, including the new stations to be built, of 2,658.29 positions against 2,657.1, or one short overall.
Thank you.